All right. So a very good evening, everyone. So I hope I'm audible and visible to all of you. Yeah. So just give me a quick thumbs up. So if I'm audible to all of you, just give me a quick thumbs up so that I can start. All right. Okay, great. So now, so the today's session, basically it will be the session that will be concentrating mainly for the INI-CET, the one which you have on 19th of May, that is day after tomorrow. Right, and most of you are under the impression key like the INI-CET, the word itself will give you a very big hype in your brain, saying considering that the questions might be very difficult, or the questions might be in very deep. So I'll try to discuss some of the previous year questions of the INI-CET, right, where the questions are not being asked in depth. What you need to understand is mainly the concept of that particular question, right? And almost all the questions which I'll be discussing, they're all the one which have been asked in the previous years of the INI-CET exam. So I'll be discussing around 130 to 150 questions, and I'll be covering the questions of all the topics. Like you take the endocrinology, neurology, cardiology, pulmonology, rheumatology, infections, so and the hepatobiliary system, gastroenterology. So all the systems I'll be covering in this particular session. Okay. So each particular topic, I have kept around 10 to 11 questions, wherein I'll be trying to cover the majority of that particular entire system in that around 10 to 11 questions. Okay. So without wasting much time, let us start with the session. All right. Yeah. So the class duration, so it will be around 4 to 5 hours, right? The entire class duration will be around 4 to 5 hours. And the PDF of this particular the questions, it is available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. And it is also available on Dr. Bhanu Prakash Telegram channel as well. So on both these Telegram channels, you have the PDF of this particular question bank, right? And right, so this is the Instagram handle. You can just follow me on my Instagram for the recent updates related to the general medicine, right? Now, let us start with the session. So the first question, the important questions, I'll start with the endocrinology first, right? And I don't want to spend much time on individual question. I'll try to spend only 2 to 3 minutes on the individual questions, so that we'll try to cover more and more questions. Okay, right. So the first question is, a high dose dexamethasone suppression test was done on a chronic smoker with complaints of weight gain and hyperpigmentation. The before and after ACTH values are high. What is the most likely clinical diagnosis? The pituitary adenoma, ectopic source, exogenous source, adrenal adenoma. Yeah. So any one of you, please. What do you think is the correct answer? So the point is weight gain, hyperpigmentation, the ACTH values are high before and as well as the after high dose dexamethasone suppression test. No. So it is not adrenal adenoma, and even it is not the pituitary adenoma as well, right? So the very important point here is, first of all, we are diagnosing Cushing's, right? First of all, we are diagnosing Cushing's. All right. So in case of Cushing's, yeah, very good, Sundaram, and as well as Sajan, the answer is the ectopic source. Now, in case of Cushing's, like what are all the etiologies for the Cushing's? The most common cause of Cushing's is the iatrogenic steroid supplementation, right? And what is the most common cause of non-iatrogenic Cushing's? That is the pituitary adenoma. But if you take the etiology of the Cushing's, we classify the etiology of the Cushing's into the ACTH dependent type of Cushing's, and then we have ACTH independent type of Cushing's. And ACTH dependent type of Cushing's, again, we have two types. One is the pituitary adenoma. And what type of pituitary adenoma is this? It is corticotroph type of pituitary adenoma. And the other one is the ectopic source, right? This is how the etiology of the Cushing's has been classified. Now we do high dose dexamethasone suppression test mainly to diagnose what type of ACTH dependent type of Cushing's is it. Okay, only in case of ACTH dependent, we do this high dose dexamethasone suppression test. Now with high dose dexamethasone, if the before values and as well as the after values of the ACTH levels are high, then that is suggestive of ectopic ACTH. Whereas you take in case of pituitary adenoma, right? Before high dose dexamethasone suppression test, the ACTH values will be high, right? And after high dose dexamethasone suppression test, the ACTH values will be reduced. Okay, that is what you will observe in case of the pituitary adenoma. And for exogenous source and as well as adrenal adenoma, we don't do this high dose dexamethasone suppression test at all. The purpose of doing high dose dexamethasone suppression test is mainly to differentiate whether it is pituitary adenoma, right? Mainly to differentiate whether it is pituitary adenoma or ectopic source. Okay, so if it is ectopic source, before and after values of the ACTH levels will be on the higher side. Okay, so the answer in this question is, right, the answer in this question is the ectopic source. Now quickly, can anyone answer me what exactly is the treatment of choice for the Cushing's? Yes, can anyone answer what exactly is the treatment of choice for the Cushing's? So the treatment of choice for the Cushing's will be the surgical resection of the tumor, right? And if you're not able to do surgical resection, if there is any contraindication for the surgical resection, then in such clinicals, in such case, we need to give the medical management. And the medical management that we give is the ketoconazole, right? The medical management that we give is the ketoconazole. That is a drug of choice which will do the medical adrenalectomy. It is basically an adrenal enzyme inhibitor, right? Then you take ectopic source of Cushing's. For ectopic source of Cushing's, how is that you will treat? Now, can anyone tell me what is the most common cause for ectopic source of Cushing's? Yes. What is the most common cause for the ectopic source of Cushing's? Quickly. The most common cause for ectopic source of the Cushing's will be small cell carcinoma of the lung, right? And this small cell carcinoma, this is also called as the oat cell carcinoma, right? Yeah, very good, Angel Roy and as well as Sajan. And so now, how is that you will treat this small cell carcinoma of the lung? Small cell carcinoma of the lung, right? You need to give the anti-neoplastic drugs, that is cisplatin, and as well as the irinotecan. So these are the drugs that we need to give for, right? These are the drugs that we need to give for the small cell carcinoma of the lung causing Cushing's, right? Now we'll move on to the next question, right? Yeah. Fulminant diabetes mellitus is seen in diabetic ketoacidosis, Coxsackie B virus, non-ketotic hyperosmolar coma, autoimmune pancreatitis. Yes. Yeah, very good, Joy. Excellent. So the fulminant diabetes mellitus, it is seen with the Coxsackie B virus. Now, what exactly is, now you take this Coxsackie B virus, it is a type of the enterovirus, right? It is a type of the enterovirus, and that is associated with the fulminant diabetes mellitus. So basically what will happen is the antibodies, they are produced against these particular viruses, right? And the antibodies which are being produced against the viruses, they will cause the beta cell destruction. Once there is beta cell destruction, the insulin level completely gets lost, and that will result in the development of what is called as the fulminant diabetes mellitus. Okay. Now, you take this fulminant diabetes mellitus. There are many other clinical conditions where you come across this fulminant diabetes mellitus. I'll just tell you the conditions. Just give me a minute. Right. So, right. So these are all the conditions where you'll have the fulminant diabetes mellitus. That is familial autoimmune diabetes, then acute pancreatitis associated diabetes, sepsis associated diabetes, drug-induced fulminant diabetes, that is mainly the steroids, okay? Viral infections like Coxsackie virus, and bacterial infections like necrotizing fasciitis. So these are the conditions where you have the presence of the fulminant diabetes mellitus, okay? So that was about the question related to the fulminant diabetes mellitus. Now we'll move on to the next question, right? So I'll not spend much time on the individual questions, hardly 2 to 3 minutes, because we have almost like around 130 to 150 questions to be discussed. Many of them are like clinical based and some of them are single liner questions. Okay. Mark the true statement. MEN2B is known as Sippel syndrome. MEN1 is also known as the Werner syndrome. Marfanoid habitus is a feature of MEN2B. MEN4 is associated with CDKN1B. So it is like the, yeah. So once the session is over, I'll send you this PPT even with the explanation as well. Right. So what do you think is the correct statement? Joy, no. 2, 3, 4 is not. No, D is not the correct answer. D is not the correct answer. Okay, because MEN1 is known as Werner syndrome is a wrong statement, yaar. Why you people are going with D? D is not the correct statement. Nah, not even C. Right, even C is also not correct. Even even A is also not correct. Right? Very good, Subha. So the answer is B. The answer is B. So let me just discuss this. So now, if you take the MEN2B, right? What is it called as? It is also known as Sippel syndrome. It is a wrong statement. So Sippel syndrome is what? It is MEN2A. MEN2A is the Sippel syndrome, right? And what is the another name for MEN2B is, the another name for MEN2B is, it is called Wagenman-Frobois syndrome, right? Wagenman-Frobois syndrome is for MEN2B. Then what about the Marfanoid habitus? Is it present in MEN2B? Yes, Marfanoid habitus is an extraendocrine manifestation that is present in case of MEN2B. Now, why your MEN1? Yeah, so this is the place where many of the students, they got confused. So what is that confusion is? Right. So what is that confusion is? Your MEN1, what is another name for MEN1? The another name for MEN1, it is Werner syndrome. So this is like, very silly mistake. Many of you have opted for D actually, the fourth option, right? So MEN1 is called Werner syndrome. And what exactly is given in your options there? In your option which is given there is the Werner syndrome. N is given there. What is Werner syndrome? Werner syndrome, it is progeria. Right? Werner syndrome, it is progeria. So you need to be very careful while solving these type of questions. So first and foremost, very important when you are attempting the exam is, you need to keep your brain completely stress-free, right? Don't think about the result. Okay, this is very important note. Don't think about what will be the result. Just concentrate on the question properly, right? Read the question with complete brain open. Don't narrow down your thought process. Keep your thought process completely open and then read the question. Okay. So if you just mistaken it as Werners as Wormers, your question is gone. And is it that you don't know what MEN1 is Wormers? You know that. But why is that we do mistake? Because of excessive anxiety and as well as stress during the exam. So because of that, like many of the students, they miss their rank and they miss their seat. So please, during the exam, just try to maintain that particular calmness and as well as coolness. Don't think of the result. What will be the result? No, that is not the point where you need to think during the exam time. During the exam time, what is required is to just concentrate only on that particular question. Okay, right. So the answer here is your B, that is 3 and as well as 4. Now, a quick recap of all the MEN syndromes. Okay, so if you take all the MEN syndromes, so we have, just 1 minute. Yeah. So we have MEN1, MEN2A, MEN2B. MEN2B is also called MEN3, and then you have MEN4. Okay. MEN1, it is called as Werner's. That is what we have discussed, right? And what is the gene that is being mutated in MEN1? In MEN1, the gene mutated is MEN1 gene. It is a tumor suppressor gene. And on which particular chromosome your MEN1 gene is being present? MEN1 gene is present on chromosome number 11. And MEN2A and as well as MEN2B, the gene that is being mutated is RET proto-oncogene. And this RET proto-oncogene is present on chromosome number 10. And MEN4, the gene that is being mutated is CDKN1B, right? And this CDKN1B, this particular gene, it is present on chromosome number 12, right? And what are the various components of your MEN1? Various components of MEN1, please remember 3 Ps. What are these 3 Ps? Pituitary tumors, parathyroid tumors, and pancreatic tumors. That is MEN1. Whereas you take in case of MEN2A, please remember this particular mnemonic, that is TAP. What is this particular TAP? T stands for thyroid, medullary carcinoma of thyroid. A stands for adrenal pheochromocytoma. P stands for parathyroid tumors. That is what is your TAP. Whereas in MEN2B, you have only TAP. P is not there. T is what? Medullary carcinoma of thyroid. P is what? Sorry, A is what? Adrenal pheochromocytoma. Parathyroid tumors are not the part of your MEN2B. Whereas you take in case of men4, in case of men4, you have sex organ tumors. What will be that? In males, there is testicular tumor, and in females, there will be cervical tumors. Okay, so that is about your men syndromes, right? We'll move on to the next question. Right, we'll move on to the next question. Yeah, 31 Asia. So once again, I'll just repeat. Men1, 3 Ps, pituitary, parathyroid, and as well as pancreatic tumors. Men2A, that is TAP. What is TAP? That is thyroid medullary carcinoma of thyroid, adrenal pheochromocytoma, and parathyroid tumors. Men2B, you have only TAP, T and A. P is not there. Medullary carcinoma of thyroid and adrenal pheochromocytoma. Whereas in men4, the gene that is being mutated is CDKN1B. You have reproductive organ tumors. In males, it is testicular tumor, and in females, it is cervical tumors. Okay, right. We'll move on to the next question. Yeah, is that fine, Nesvi? Right. Yeah, coming on to the next question. Which of the following is used in the treatment of hypercalcemia, right? Hypercalcemia due to vitamin D toxicity. Yes, which of the following is used to treatment of hypercalcemia due to vitamin D toxicity? Dexamethasone, hydroxychloroquine, chloroquine, and as well as ketoconazole, right? Good. Very good. Right. So you need to give dexamethasone. So particularly like dexamethasone, in which clinical scenarios we give dexamethasone? Dexamethasone is actually steroid. So this particular dexamethasone, how is it that it will reduce the hypercalcemia due to vitamin D toxicity? I'll tell you the mechanism also. Dexamethasone is a steroid that can be used in the treatment of hypercalcemia due to vitamin D toxicity. And how does it work? This particular dexamethasone, it reduces the intestinal calcium absorption, right? It reduces the intestinal calcium absorption. And not only that, the dexamethasone, it will also promote, right? It will also promote renal calcium excretion. Right, it will also promote the renal calcium excretion. So that is what is being done by your dexamethasone. That is what is being done by dexamethasone. Now, what is your hydroxychloroquine and as well as the chloroquine? The hydroxychloroquine and as well as the chloroquine, they are the anti-malarial drugs. Hydroxychloroquine, it is an anti-malarial drug. It is nowhere related to used in the treatment of hypercalcemia to vitamin D toxicity. Now, this hydroxychloroquine, apart from anti-malarial activity, can anyone tell me in which autoimmune disorders we give hydroxychloroquine? Yeah, Vaibhav, I'll come to your question, Vaibhav. I'll come to your question. Your question is very much valid question. Yeah, very good, Anusui. One is, it is used in rheumatoid arthritis. One more. It is also used in the treatment of lupus. It is also used in the treatment of lupus. Whereas you take chloroquine. Chloroquine is also an anti-malarial drug. It is no way used in the treatment of hypercalcemia due to vitamin D toxicity. And you take the ketoconazole. Ketoconazole is what? It is an antifungal drug, right? Now and this ketoconazole, we also use this in the treatment of the Cushing syndrome because it is an adrenal enzyme inhibitor. It is adrenal enzyme inhibitor. Okay. Now, we have a very genuine question from Vaibhav, right? What Vaibhav is asking is, which is better option, sir? Steroids or bisphosphonates if the option is, if both the options are there. Now, this particular hypercalcemia, if it is due to hyperparathyroidism, right? If it is due to hyperparathyroidism, then we give bisphosphonates, right? We give bisphosphonates, okay? Now, if the hypercalcemia is due to vitamin D toxicity, then we give dexamethasone. Tell me one inflammatory condition where there is vitamin D toxicity causing hypercalcemia in which we need to give steroids. Listen my question carefully. Tell me one inflammatory condition where there will be vitamin D excessively produced and because of which there is hypercalcemia and where we give steroids. What is that inflammatory condition? Yes. So vitamin D toxicity is usually observed in any one of you quickly. That is in case of sarcoidosis. That is in case of sarcoidosis. So in sarcoidosis, non-caseating granulomatous tissue will produce vitamin D, and vitamin D is the one which will cause hypercalcemia. And for sarcoidosis, what is the treatment that we give? That is dexamethasone is what we give, right? Vaibhav, I hope, Vaibhav Anand, right? I hope I have answered your question, right? Next, we'll move on to the next question. Okay, we have a 56-year-old woman presented with a gradually diminishing visual field. She was found to have the pituitary mass and underwent transsphenoidal hypophysectomy. Now she has low levels of ACTH, TSH, FSH, and as well as LH. Which of the following hormonal supplements is not needed in the patient post-operatively? The options are mineralocorticoid, thyroid hormone, glucocorticoid, estradiol. Very simple and easy question, right? Very good, Muguntan. So, like basically, what is this question about? This question is about the hypopituitarism. The question is about the hypopituitarism. So whenever there is hypopituitarism, the hormonal supplementation which is not required is the mineralocorticoid. Why your mineralocorticoid is not required? Because the production of the mineralocorticoid is not dependent on the ACTH. It is dependent on the RAS. Okay, right. And there are two important stock questions related to hypopituitarism. So tell me, in hypopituitarism, what is the first important hormone that will be reduced? Yes. What is the first important hormone that will be reduced? Any one of you? First important hormone that will be reduced. Quickly. Yes, very good, Sajan. That is the growth hormone, right? That is the first important question. Next, what is the most common cause of the hypopituitarism? What is the most common cause of the hypopituitarism? That is another important stock question related to the hypopituitarism. Not prolactin, right? It is the growth hormone. Growth hormone is the one which is being, yeah, very good, Banu Pratap. So that is the pituitary adenoma. Okay, it is the pituitary adenoma. So the pituitary adenoma is the most common cause for hypopituitarism, right? The next important stock question is, what is the first hormone that need to be supplemented in the treatment of the hypopituitarism? What is the first hormone that should be supplemented as a treatment in the hypopituitarism? Yes, first hormone that need to be supplemented as a part of the treatment in hypopituitarism, right? Very good, very good. So that is, you need to give steroid, right? You need to give steroid. Now, which steroid to be given? Yeah, so which steroid to be given? Hydrocortisone or dexamethasone? What is that we will give? Yes, Nabi said hydrocortisone, Sajan said dexamethasone. So what do you think, is it correct? Hydrocortisone we will give or dexamethasone we will give? Right? Yes. What is that we will give? So please, no. It is not hydrocortisone. It is dexamethasone is what we will give. Dexamethasone is what we will give. Now the question is why. Now you take hydrocortisone. What is the beauty or advantage of hydrocortisone is hydrocortisone, it has dual activity. That is corticosteroid activity and as well as mineralocorticoid activity. But in patients with hypopituitarism, do you want the mineralocorticoid activity? No, you don't want mineralocorticoid activity in hypopituitarism. What is that you want in hypopituitarism is only we want corticosteroid activity. And what is that particular steroid which is having maximum steroid activity? The steroid which is having maximum steroid activity is dexamethasone. So that is the reason why in case of hypopituitarism causing adrenal insufficiency, we give dexamethasone. Whereas you take adrenocortical insufficiency, that is Addison's. In Addison's, the drug of choice will be hydrocortisone because in Addison's, mineralocorticoid and glucocorticoid, both of them will be reduced. Okay, so I hope this explanation is very clear for you, right? Now we'll move on to the next question. Okay, so like one set of questions which are very commonly asked in the previous years is about Rohit Kumar, ketoconazole is a drug of choice. Actually, we give metirapone as well, but the drug of choice is ketoconazole. There is no doubt in that. 100% lock it, right? Ketoconazole is a drug of choice. Okay, right. So yeah, you see the next question. The serum electrolyte values of a patient weighing 60 kg are given below. Calculate the sodium deficit in patient where the pH is 7.42 and the sodium is 120 milliequivalents and the chloride values are 90 milliequivalents. So how is that we will calculate? Vaibhav said 200 milliequivalents. Okay. Any other answer? Any other answer? So first of all, you need to know what is a formula. You need to know what is a formula in calculating the sodium deficit. Everyone is saying 200 milliequivalents, huh? Okay, so now we'll just try to apply the formula for the sodium deficit. So if you see the formula for the sodium deficit, just give me a minute. I'll just open that formula for you. So the formula for the sodium deficit is this formula. That is the sodium deficit. What has been asked for you in the question? In the question, what has been asked for you is, right, calculate the sodium deficit is what is being asked for you. The formula is the total body water in liters multiplied by desired sodium minus the current sodium. Okay. Now, how do you calculate this total body water? So total body water, it is given by the formula that is 0.6 multiplied by body weight in kgs. 0.6 multiplied by body weight in kgs. Now we'll try to substitute the values. Okay. So now 0.6 multiplied by what was the weight of our patient? The weight of our patient was 60. Weight of our patient was 60, right? And that is multiplied by desired sodium. How much is the desired sodium? That is 140. How much is the value of the sodium of the given patient? It is 120, right? It is 120. So if you calculate this, the value, it comes around 720 milliequivalents. If you calculate this, because 0.6 into 60, so that comes around 36, right? 36 multiplied by 20. So that comes around 720. So the answer in this particular question will be 720 milliequivalents. Right? Okay, so this is 720 milliequivalents. Okay, so you need to know the formula. What is the formula for calculating the sodium deficit? That is total body water multiplied by desired sodium minus current sodium. Total body water, how is that you will calculate? 0.6 multiplied by body weight. Okay, so I'll be sending you this PDF. I'll be sending you this PDF with explanation once the session is over, right? We'll move on to the next question. Right. So comment on the diagnosis for, this is very, very important area for the questions. For serum alkaline phosphatase being normal, parathormone levels normal, vitamin D3 levels normal, elevated serum calcium levels. What do you think is the answer? Vitamin D intoxication, hyperparathyroidism, multiple myeloma, nutritional rickets. Sajan, vitamin D. Sajan, vitamin D3 levels which has been given is normal. So how can you consider vitamin D intoxication? Ye nahi ho sakta, na? Right. So the correct answer is, Vaibhav said rickets. In case of rickets, you have vitamin D deficiency, right? Because what is being given here is vitamin D3 levels are being given normal. So the correct answer here is the multiple myeloma. So in case of multiple myeloma, serum alkaline phosphatase levels are normal, parathormone levels are normal, vitamin D3 levels will be normal, but it is only the calcium levels that are being elevated. So basically what is multiple myeloma? It is a cancer that involves the plasma cells in the bone marrow. And because of this cancer in the plasma cells, there is excessive production of monoclonal immunoglobulins, right? And what are these monoclonal immunoglobulins? These monoclonal immunoglobulins are the M proteins. Now, I'll try to give you the explanation for each and every option. You take in vitamin D intoxication. Why isn't it vitamin D intoxication? Because in case of vitamin D intoxication, vitamin D levels will be elevated, and because of which there will be hypercalcemia. And because of this hypercalcemia, what will happen to parathormone levels? The parathormone levels will be reduced because of the feedback mechanism, right? Then you take in hyperparathyroidism. In hyperparathyroidism, parathormone levels will be elevated, calcium levels will be elevated, and even serum alkaline phosphatase levels also will be elevated, right? Then you take in case of the nutritional rickets. In case of the nutritional rickets, what is all that you will have? Vitamin D deficiency will be there, calcium deficiency will be there, and phosphorus or phosphate deficiency also will be there. So the answer in this question is what? That is multiple myeloma, right? So this serum alkaline phosphatase story, like, you should not forget. You need to revise just before going to the exams. Now I'll give you a table where you have the scenarios where the serum alkaline phosphatase levels are normal and the serum alkaline phosphatase levels being elevated. Okay, so this is an important table, right? So this is the important table. You see this. You just concentrate only on this. Okay. You take what are the scenarios where the serum alkaline phosphatase levels will be normal in spite of the bony pathology, In case of osteoporosis, the serum alkaline phosphatase levels may be normal or increased. Vitamin D deficiency, the serum alkaline phosphatase levels will be normal or increased. Renal osteodystrophy, serum alkaline phosphatase levels may be normal. So three conditions: osteoporosis, then vitamin D deficiency, then renal osteodystrophy. These three conditions, they may be normal or increased. Now, what are the conditions where serum alkaline phosphatase levels are increased? That is in hyperparathyroidism. Then you take in patients with rickets, then Paget's disease of bone, and osteomalacia. The serum alkaline phosphatase levels are increased. And what are the conditions where it is decreased is in patients with the hypoparathyroidism. In hypoparathyroidism, it is decreased. Okay. So this particular table is very, very important. I'll just send you this once the session is over, and you can go through this particular table where I have given you comparison of parathormone, vitamin D3, and as well as calcium in all these particular conditions. Okay. So this will be an important table for you to revise once just before going to the exams, right? Now, coming on to the next question, right? A 19-year-old woman comes to the clinic complaining of milk coming out of her nipples for the past 5 months. She is nulli gravida. She's experiencing galacturia on the physical examination. She is diagnosed to have the prolactinoma. The characteristic physical examination findings that comes after galacturia is bitemporal hemianopia, anovulatory cycles, amenorrhea, infertility. Yes. Okay, so some of you are saying A and some of you are saying C. And let me see, majority of you, what is that you'll answer? Right. Okay, so the correct answer is bitemporal hemianopia. Right. Now, if you see the sequence of events, first and foremost, there is some, some general knowledge type of question. It is like some common sense type of question. What is that? The question is being asked, the characteristic physical examination finding. Okay, that is examination finding, right? So you take amenorrhea and infertility will be there in prolactinoma, but amenorrhea will be the clinical symptom given by the patient, right? And even infertility, that will be the clinical symptom by the patient, right? The patient comes and says, right, they are not having the children. Whereas bitemporal hemianopia, that will be the physical examination finding, right? So this is like some common sense. And not only that, right, after the development of galacturia, in prolactinoma, if it is macroadenoma, right, if it is macroadenoma, what is that? After that galacturia that will develop is, there will be development of bitemporal hemianopia. That's very important point you need to know. And you need to know the differential diagnosis. What is the differential diagnosis for prolactinoma? What is the differential diagnosis for the prolactinoma? Anyone? The differential diagnosis for prolactinoma will be craniopharyngioma, right? Then what is the difference between craniopharyngioma and the prolactinoma? So in case of the prolactinoma, right, in case of the prolactinoma, you will have bitemporal, right? You will have bitemporal superior quadrantanopia, right? You will have bitemporal superior quadrantanopia, okay? Whereas you take in craniopharyngioma. In craniopharyngioma, the visual loss will be bitemporal inferior quadrantanopia, right? Bitemporal inferior quadrantanopia, right? Yeah. Okay, no, this antipsychotics and all, they are like hyperprolactinemia will be there, but you don't have the visual manifestation in case of the antipsychotics. Antipsychotics like phenothiazines and as well as risperidone, yes, they will cause hyperprolactinemia. But in case of antipsychotics causing hyperprolactinemia, you don't have the visual manifestation. The visual manifestations are mainly because of the mass effect over the optic chiasma, right? And what are the other drugs which will be causing hyperprolactinemia? That is alpha-methyl-dopa, metoclopramide, then your cimetidine, then phenothiazines and risperidone. These are all the drugs that will cause the hyperprolactinemia, right? Now, moving on to the next question. A 32-year-old male with history of the, even haloperidol, right? Very good, Lalit. A 32-year-old male with history of the peptic ulcer disease and diabetes mellitus presents to the emergency department with complaints of nausea, abdominal pain, and lethargy for 2 days. He reports having occasional dark, tarry stools. Lab showed elevated glucose and high anion gap metabolic acidosis on the ABG. So which of the following insulin should be used in the management of this particular patient? Regular insulin, Lispro, Glargine, Aspart. Okay. So this is very simple and easy question. This is not at all a difficult one. It is only the length which is giving us a fear that the question is difficult. But the answers, if you take, they are very simple and easy. So just be confident. 1 minute. Yeah. So just be confident in the exam also. Don't get scared by seeing the length of the question, right? The length might be very big, but the answers will be very simple. Just be confident and just be with a positive attitude. Just go to the exam. So the answer is what? That is the regular insulin. There is one more question asked on the diabetic ketoacidosis, right? You see this. A patient with diabetes mellitus for the past 5 years presents with vomiting and abdominal pain. She is non-compliant with medication and appears dehydrated. Investigation revealed the blood sugar value of 50 milligrams per deciliter, right? And the ketone bodies are positive. What is the next best step in the management? The IV fluids with long-acting insulin, IV fluids alone, the intravenous insulin alone, IV fluids with regular insulin, right? So this is another important question. You need to be very careful. Yes, like what is that we start first? The one what we start first will be the IV fluids. That is normal saline. Yes, Mugundan, that is a great mistake, right? Is it that you will give only IV fluids? No. Along with IV fluids, you also need to give regular insulin. And the route of administration of this particular regular insulin will be intravenous, right? Where you need to give 10 units of insulin IV bolus, and followed by that, you need to start the insulin at a rate of 0.1 unit per kg. Intravenous infusion is what you need to give. And whenever you are giving insulin infusion, what is that you need to monitor for? You need to monitor for the potassium levels. If the potassium levels have dropped to less than 5, you need to give IV KCl. Less than 5 it drops down, you need to give the IV KCl, right? Because the hypokalemia, it can cause tachyarrhythmias and it can cause VT and as well as VF. And you need to monitor the bicarbonate. If the bicarbonate value, if it is less than 10, then we give intravenous sodium bicarbonate, right? And what is the most common precipitating factor for the diabetic ketoacidosis is infection. So that is the reason why you also need to give IV antibiotics. And these patients with diabetic ketoacidosis, you need to admit the patient in ICU and then treat the patient, because this acidotic pH will disrupt the blood-brain barrier and make the individual to land up in coma. So that is the reason why patients with diabetic ketoacidosis, they are usually managed in the ICU, right? Now coming on to the next question. Yeah, the fluid of choice is normal saline. There is no doubt in that, right? The fluid of choice is the normal saline, okay? Right. So now coming on to the next question. So a medical camp was set up on a military base. A 20-year-old military recruit is found to have HbA1c of 6.1% and fasting blood glucose of 120 milligrams per deciliter. He has no family history of diabetes mellitus and has no signs and symptoms of diabetes. General physical examination is unremarkable. Which of the following best describes the blood glucose level in this patient? Yeah. Right. So, no. It is not normal. It is not normal. It is impaired glucose tolerance. What is the normal value of your HbA1c? The normal value of your HbA1c is less than 5.6%. That is a normal value, right? And if the value is in between 5.7 to 6.4%, this we call it as impaired glucose tolerance, right? And if the value is more than or equal to 6.5%, this we consider it as diabetes mellitus. Okay, so this particular patient comes under your impaired glucose tolerance. What is the first line treatment that you will be advising in this patient? What will be the first line treatment that you will be advising in this patient? Anyone? First line treatment that you will be advising in this patient. Come on, quick. The first line treatment. Yeah, so that is basically LSM, lifestyle modification. Okay, it is not just only the diet. Along with the diet, the physical activity is also very, very important, where the individual is advised for the brisk exercise for 30 minutes, 5 days in a week. 5 days in a week, right? So these were the questions on the endocrinology. Now we'll move on to the questions on the cardiology, right? What is the difference between third and fourth option? Diabetes mellitus and maturity onset diabetes of young. See, maturity onset diabetes of young, usually it is the age group between 20 to 30 years, right? Maturity onset diabetes of young, the age group is around 20 to 30 years. And maturity onset diabetes of young, here you have beta cell dysfunction. It is not beta cell destruction, it is beta cell dysfunction. And it is due to gene mutation, right? And what is the gene that is being mutated in case of your MODY? That is HNF1 alpha. Right? Actually, many genes are being mutated, but the most common gene that is being mutated is the HNF1 alpha. And which type of MODY is very common? That is MODY3 is very common. And what is the drug of choice in case of MODY? The drug of choice is you need to give low-dose sulfonylurea. And the other points about MODY is they should have a very strong family history. Strong family history in the sense minimum 2 generations should be diabetic. It is not just only father, even grandfather also should be diabetic in case of the MODY, right? And these patients with MODY, they will have normal BMI and they never develop diabetic ketoacidosis, okay? Whereas diabetes mellitus, if you see, right, we have various forms of diabetes mellitus. There is type 1 and as well as type 2 diabetes mellitus. And even MODY is also one variant of diabetes mellitus. Okay, so that is what is the difference between your third and fourth option, right? Yes, Vaibhav, did you understand this? And in case of type 1 diabetes mellitus, the age will be less than 20 years. Whereas in type 2 diabetes mellitus, the age will be more than 30 years, right? Whereas in MODY, the age is 21 to 30 years. Okay, so that was about the question on the diabetes, right? We'll start with the cardiology questions. Okay, you see the question first. An adult patient presents with pulsatile swelling in the neck below the angle of the jaw, which produces an outward expansile impulse. The consultant, in suspicion of the condition, did an MR angiography, which is shown below. Which of the following is the most probable diagnosis? Right, very good, very good. Right, excellent. So the answer here is the carotid body tumor. Now, can anyone tell me what is this particular sign that we come across in carotid body tumor? What is this particular sign that we come across in carotid body tumor? Right, this particular sign, it is called as light sign. This is called as light sign. What is light sign? Light sign is nothing but this carotid body tumor, right, that will cause spreading or that will cause splaying of the internal and as well as the external arteries. It will cause splaying of internal and external arteries. So it is nothing but your carotid body tumor. And please remember, carotid body tumor, it's a slow growing tumor, right? And what is the age group at which you see this particular carotid body tumor is around 40 years, and it's a slow growing tumor. Then how will you rule out the other options? You take Graves' disease. In Graves' disease, you will have a swelling, but it is non-pulsatile. Right, it is non-pulsatile. Okay, so what is given here? It is pulsatile swelling which has been given. So your Graves' disease is gone. Then you take B, that is brachial cyst. Brachial cyst is the one which is more common in children. It is more common in children, but not in adults. So that is gone. But what exactly is the brachial cyst? Brachial cyst is a small fluid-filled sac that looks like lump under the skin on the side of the neck. And that is more common in children. Then you take thymic cyst. Like you take thymic cyst. Thymic cyst is what? It's a benign mediastinal disease. And in patients with thymic cyst, what will be the presentation? The presentation, because it's a mediastinal mass. Okay, it will compress the trachea, causing dyspnea. It will compress the esophagus, causing dysphagia. It will compress the recurrent laryngeal nerve, because of which there is hoarseness of voice, right? And there can be even cough. That will be the manifestation in case of thymic cyst. Okay, so that is not the answer. So the answer is what? That is carotid body tumor. And another name for carotid body tumor is what? The another name is, it is also called chemodectoma, or it is also called paraganglioma. That is another name for this carotid body tumor. Right? And this particular carotid body tumor, how is that you will identify? You will be able to identify that carotid body tumor, that is by the angiography. That is MR angiography. And what is a very important sign? That is light sign. What is the treatment of choice for carotid body tumor? The treatment of choice for carotid body tumor is the surgical excision has to be done. Right? Surgical excision has to be done. So that is about the carotid body tumor. Okay. Right. And you take the aneurysm. Yes, Vaibhav. So how is that you will differentiate between carotid body and as well as aneurysm if no image is given? See, if image is given, it is difficult to make out. But you take carotid body tumor. Carotid body tumors always and always and always, they are present over the angle of the jaw. Whereas aneurysms, right, that is carotid aneurysms, it can be in the suprasternal area also. The carotid body aneurysms, you have that pulsations in the suprasternal notch. Right. Okay. But whereas carotid body tumors, the pulsations, they are in the angle of the jaw. So the location, anatomical location is the one by which you will be able to differentiate if the image is not given. Yes, Vaibhav, I think I have answered your question. Okay. We'll move on to the next one. True about the definition of the postural hypotension. True about the definition of the postural hypotension. Right. So this is another very, very important question. So, yeah. Yes, Vaibhav. B question mark. Okay. So, what do you consider? So, there should be decrease in systolic blood pressure and there should be decrease in diastolic blood pressure. Right? Okay, so those students who are having confusion, let me clear your confusion. Oh, no, I did not expect multiple answers for this question. I thought only one answer will be there for this question. Okay, let me just clear it off. Systolic blood pressure should fall more than 20 millimeters of mercury and diastolic blood pressure should fall more than 10 millimeters of mercury. After how much time? After 3 minutes of standing. After 3 minutes of standing. So the answer in this question is B, right? It is not your D. It is not diastolic blood pressure fall in 20. It is systolic blood pressure fall in 20, right? That's a very, very important point, okay? And there are multiple conditions which will be causing your postural hypotension, right? Whereas if you take endocrine disorders causing postural hypotension, you see that in case of pheochromocytoma. You see that in patients with Addison's. You see that in patients with diabetic autonomic neuropathy. These are all the endocrine disorders where you have the postural hypotension. Now, can anyone tell me, what is the drug of choice for the treatment of postural hypotension? The ad is coming for a longer time this time. One more ad. Right. Chalo, okay. What is the drug of choice? What is the drug of choice for the postural hypotension? Quickly. Yeah, midodrine. Very good. Lalita's answered. Anisul Nabi, you should not give alpha blockers. Okay? You should give alpha agonist. You should give alpha agonist. Alpha blockers, if you give, the blood pressure will further fall down. Okay? So drug of choice is midodrine. It is midodrine. Again, Nikita, it is not alpha blocker. It is alpha agonist. It is alpha agonist. Please don't get confused, okay? Right. Yeah. So this is one of the very, very important ECG. Right. So we have a 68-year-old male admitted to the ICU for acute exacerbation of COPD. Develops a sudden onset palpitations. The following ECG changes are seen. What do you think is the most likely diagnosis? Right. Yes, Vaibhav, thank you very much. Yeah. So without seeing the ECG also, what is the way by which you can answer is by the history, that is COPD. Okay. So if the history says COPD, in COPD, the most common arrhythmia will be MAT, that is multifocal atrial tachycardia. Now, what do you understand by this multifocal atrial tachycardia is, if you take the rhythm strip, which is nothing but lead to, like there should be more than or equal to 3 different P waves, right? There should be more than or equal to 3 different P waves, and heart rate should be more than 100, right? Heart rate should be more than 100 per minute. Now the question comes to here, what is the drug of choice in this patient? What is the drug of choice in this patient? Anyone? What is the drug of choice in this patient? Excellent, Satvika Sai. That is verapamil. That is verapamil. Okay, that is non-dihydropyridine calcium channel blockers. Verapamil or diltiazem should be given. But actually, in case of MAT, we give beta blockers. We give beta blockers. But because the patient is having COPD, the beta blockers are usually avoided. So that is the reason why we cannot give beta blockers. So in them, what is that we give is verapamil is what we give. You take ventricular tachycardia. So how will be the ECG of ventricular tachycardia? Now you just tell me this particular ECG, is it like monomorphic ventricular tachycardia or is it polymorphic ventricular tachycardia? So what is it? Is it monomorphic or is it polymorphic ventricular tachycardia? Very good. No. Why it is polymorphic? It is monomorphic. You see the QRS complexes. All the QRS complexes in an individual lead, they are of similar morphology. So it is monomorphic ventricular tachycardia. Now, if this particular patient is hemodynamically stable, if the patient is hemodynamically stable, what is the drug of choice? What is the drug of choice if the patient is hemodynamically stable? So if the patient is hemodynamically stable, please remember the drug of choice will be quickly. Yeah. So the drug of choice will be amiodarone. That will be amiodarone. For example, if the VT, if it is digoxin-induced VT, if it is digoxin-induced VT, what is the drug of choice? What is the drug of choice if it is digoxin-induced VT? Anyone? If it is digoxin-induced VT, yes, that is lignocaine. That is lignocaine. Now, and the next point you need to be very much aware is, like if the patient is hemodynamically unstable, then what is that we do? We do the DC cardioversion. We do DC cardioversion. Okay. And this is the ECG of the atrial fibrillation, right? Where you don't have the P waves and you have the RR interval being completely variable RR interval. So in this particular question, the answer is multifocal atrial tachycardia, right? Now we'll move on to the next question. Yeah. Now, this is a very tricky question. Now, let me just see how many of you can answer this question, right? This is one of the PYQ of the INI-CET. What is the correct sequence after the P wave? What is the correct sequence after the P wave? Right. So P wave in the ECG, what does it represent? This represents the atrial contraction. This represents the atrial contraction. Atrial contraction is nothing but, it is a second rapid filling. Atrial contraction is nothing but second rapid filling. Okay. Right. So A, B, D, C. Yeah. So we have the correct answers coming from Muguntan and as well as the Santi. Right. So the correct answer is B. That is ABDC. ABDC. Now, so your atrial contraction, it corresponds to what? It corresponds to the A wave in the JVP. Okay, it corresponds to A wave in the JVP, right? Now, when the atria is contracting, what the ventricle will be doing at this time? At this particular point of time, the ventricle will be relaxing. What will be the next event after this? The next event after this will be the ventricular contraction. Whenever there is ventricular contraction, what is that you will listen? You will listen the first heart sound. You will listen the first heart sound. Okay, you will listen the first heart sound, right? Then followed by that, you take after the ventricular contraction, what is the event? After the ventricular contraction, the event that you will have is the ventricular relaxation, right? So in case of ventricular relaxation, the ECG, what you will have is a T wave. In the ECG, what you will have is T wave, right? And once the ventricle is relaxed, the ventricular pressure is reduced, and that will subsequently cause the first rapid filling. That will subsequently cause the first rapid filling. The first rapid filling is the one which will occur after, so first rapid filling. So this first rapid filling, it is due to passive opening of the AV valves. Passive opening of the AV valves. So the answer is what? Your A wave, then B, then your T wave, and then rapid filling of the ventricles. Okay, so the answer is A, B, D, C, right? A, B, D, C, right? Now, how is that you will be able to get familiarized with these type of questions? We come across one particular, right? One particular diagram in the physiology. What is that particular diagram we come across in the physiology is, I'll just show you one diagram. This you need to be very clear with. The concept should be very clear about this particular diagram. Okay, if you are very clear with this particular diagram, then you will be able to answer any type of question. And this particular diagram we learn that in the physiology. Yeah, yes, Sadvika side, that is nothing but your Vickers graph or Vickers diagram. So if you are very clear with this Vickers diagram gives you what? It gives you the combination of the JVP, cardiac cycle events, ECG changes, and as well as the heart sounds, and ventricular pressure changes and atrial pressure changes. If you are very clear with this, then you will be able to crack these type of questions. Okay, right. I'll not go into detail of that because it takes definitely a lot of time because we have many questions. I'll be sending you this PDF. Once the class is over, you can just go through that. Please don't mind. Okay. Now we'll move on to the next question. A 45-year-old female patient presents to the clinic with complaints of increasing fatigue and as well as shortness of breath. Upon auscultation, the physician detects the pansystolic murmur that is best heard at the right side of the heart. The murmur is louder during inspiration. The patient denies any history of fever, chest pain, and recent infections. What is the most likely diagnosis for the patient condition based on the described finding? Aortic stenosis, mitral valve prolapse, ventricular septal defect, tricuspid regurgitation. Abdul Kalam, no. Nah, yaar, Ashutosh, why do you answer it as ventricular septal defect? It is not VSD. It is not VSD. Okay? Yeah, very good. So that is tricuspid regurgitation. What is that point which makes you to answer it as a tricuspid regurgitation is, yes, you have a pansystolic murmur and it is increasing on inspiration, right? It is increasing on the inspiration. And what is this particular sign called as? This particular sign, it is called as the de Carvalho sign, right? This is called de Carvalho sign. Whereas in ventricular septal defect, you will have a pansystolic murmur, but there is no change with respiration. Okay, and mitral valve prolapse, if it is causing MR, if there is MR component in case of the mitral valve prolapse, then if MR is very severe, in MR you will have a pansystolic murmur that will be best heard at the apex, that will be radiating to the axilla, and this particular PSM of the murmur, it will increase on expiration. Right, it will increase on expiration. Right, now how is that you will rule out the aortic stenosis? Aortic stenosis, what is that you will have? Aortic stenosis, you will have ejection systolic murmur. You will have ejection systolic murmur. Okay, and where is that you will listen that ejection systolic murmur best? That is in second right intercostal space, which we call it as the aortic area. And this murmur of aortic stenosis will be radiating to the carotid. Right, will be radiating to the carotid. Okay, so this is very important. And not only that, the murmur of the aortic stenosis will be also radiating to the apex as well. And that we call it as Gallivardin phenomena. Whereas in mitral valve prolapse only, what is that additional sound you will have is, you will have a mid-systolic click with late systolic murmur. Mid-systolic click with late systolic murmur. That is what you will listen in case of mitral valve prolapse. But if the MR is severe, then you will listen a pansystolic murmur that is heard best at the apex, that will be radiating to the axilla and which will be increasing on expiration. Okay, so the correct answer is what? Tricuspid regurgitation. Why? Because there is de Carvalho sign which is given there. Right, now we move on to the next question. So we have a patient who comes to the hospital within 3 hours of the onset of the chest pain. The ECG revealed SC segment depression in the anterior chest leads, and the T wave is inversion. The T wave is inverted. She could be best managed by PCI, thrombolysis with the altiplase, prophylaxis for arrhythmia, aspirin with heparin. Yes, ejection systolic click and mid, both are same. Yes, Muguntan, both are same. Ejection systolic click and mid systolic click are the same. Okay. Yeah, who's that? Who want to do PCI? Abdul Kalam want to do PCI. Dabir want to do PCI. Hemalata want to do PCI. All commercial doctors. Just in a lighter way, right? So it is not PCI. So the patient is having the ST segment depression, right? And troponin levels are not given here. Troponin levels are not given here. Okay, so either it could be unstable angina, right? We don't know the troponin. Okay, for suppose if troponin is given to be positive, what it will be? This will be NSTEMI. So it will be unstable angina or the NSTEMI. Remember, the best management for unstable angina or NSTEMI, it is not PCI. It is aspirin with heparin or aspirin with anticoagulant. Aspirin with anticoagulant. Either it can be unfractionated heparin, it can be low molecular weight heparin, or even it can be fondaparinux as well. That is the treatment, best treatment for the unstable angina and as well as the NSTEMI, right? I hope everyone is clear with this. Yeah, very good, Anisul Nabi. So in case of the NSTEMI, your thrombolysis is completely contraindicated. Completely contraindicated. Okay. So the answer here is aspirin with heparin. Whereas you take in case of STEMI, where you have a transmural infarction, in case of STEMI, the PCA is the best treatment option. PCA is the best treatment option. Whereas NSTEMI and unstable angina, the best treatment option is aspirin with heparin, right? Aspirin with heparin, you need to give for at least 48 hours or 24 to 48 hours. After giving the aspirin with heparin for 24 to 48 hours, then we do a coronary angiogram. And if the coronary angiogram shows a blockade more than 70%, then we do percutaneous coronary intervention. Okay. Otherwise, the best management is aspirin with heparin, right? I hope this point is very clear for you, right? Now, coming on to the next question. A patient comes with palpitation to the emergency department. His pulse is 180, blood pressure is 70 millimeters of mercury. ECG shows the narrow QRS tachycardia with regular heart rate. What is the next step in the management? This is the question which has been repeated multiple times in the previous years, right? Multiple times. Yeah. PSVT is a right, sure short question, definite question on the PSVT, paroxysmal supraventricular tachycardia, right? So what is the point here? The patient is hemodynamically unstable. So any arrhythmias which are like hemodynamically unstable, what is that we need to do? DC cardioversion. There is no doubt in that because the heart rate is 180 and blood pressure is 70. That means the patient is hemodynamically unstable. And the QRS complex, it is narrow QRS complex tachycardia, which is suggestive of your paroxysmal supraventricular tachycardia. Now, for suppose in this patient, let us just assume the blood pressure is 110 by 80. 110 by 80 millimeters of mercury. Then what will be the first line treatment? What will be the first line treatment in this question? नहीं यार फर्स्ट लाइन ट्रीटमेंट पूछा है मैं संजय फर्स्ट लाइन ट्रीटमेंट सो द फर्स्ट लाइन ट्रीटमेंट इज so either you need to do a carotid sinus massage or as you people are telling, that is Valsalva maneuver. That is nothing but Valsalva maneuver. Okay. And if the question is asked like drug of choice will be adenosine. Right? So how much is the adenosine that you will give? Everyone is aware you need to give 6 milligrams of adenosine, IV bolus. Followed by that, you need to give a saline flush. And with 6 milligrams, if the patient does not respond, then you need to give 12 milligrams of adenosine. IV bolus has to be given. That is followed by flush of saline. Right? And even with 12 milligrams of adenosine, if the patient does not respond, the PSVT patient is not responding, then we give beta blockers or non-dihydropyridine calcium channel blockers is what we need to give if the patient is not responding even to 12 milligrams of adenosine as well. Okay. So that is about your PSVT. PSVT is a very, very important topic. You need to be aware of in and out related to PSVT. And one more important question is they will give you the history like bronchial asthma is there in the patient. Right? They'll give you a point saying that the patient is having a past history of bronchial asthma. Which of the following drug that is being preferred that is verapamil will be preferred, because if there is like bronchial asthma, you cannot give beta blockers, right? Beta blockers are usually avoided if there is pulmonary pathologies. So in such case, you need to give verapamil. Okay. So the correct answer in this question is DC cardioversion, because the patient is hemodynamically unstable. Right. So coming on to the next question. In a patient with non-ST elevation MI, all of the following can be used for the treatment except, this is a repeat question actually. Yeah. Because it caused bronchospasm, that's why we give saline flush. No. The reason for saline flush is not for the bronchospasm. If you take the half-life of adenosine, the half-life of adenosine is just 5 seconds. Okay. And within this 5 seconds, we want that adenosine should be going to the heart, and it should be 1 minute. This ad has come. Right. So within 5 seconds, it has to go to the heart, and it should block the AV node. It should block the AV node. That is what we want. So now if you give IV fluid, saline flush, when you give saline flush, that adenosine which has been given in the peripheral line, that will reach to the heart immediately. That is the reason why we give saline flush. Okay. It is not the reason why it is causing bronchospasm. Yes, Nabi, I hope this point is clear for you. Right. Yeah. So yes, NSTEMI, just now we have discussed, that is thrombolytic therapy, it is avoided. Thrombolytic therapy is avoided. Streptokinase should not be given, right? Yes. Now, this is a very important question. So what is the waist to hip ratio that is associated with increased risk of the heart disease? More than 0.8 in males, more than 0.8 in females, more than 0.85 in males, or more than 0.85 in females. Yes. No. The answer is not C here. No, Joy has answered it correctly. So females, if they are having the waist to hip ratio more than 0.85, they are at increased risk of development of the heart disease. That's a very important point. Please make a note of it. Right? Next question. Yeah. So this is like the question based on the definition of the rescue PCI. Yeah. Ekadashi has asked one question. One quick question from Ekadashi. So why streptokinase is avoided in case of NSTEMI? Now, in case of NSTEMI, it is not transmural infarction. It is not transmural infarction in NSTEMI. In NSTEMI, what is that you will have is subendocardial infarction. It is subendocardial infarction. And thrombolytic therapy is indicated only when there is transmural infarction, where there is 100% blockade of the vessel, we give thrombolytic therapy. Whereas in NSTEMI, it is subendocardial infarction where you don't have 100% blockade of the vessel. That is the reason why thrombolytic therapy is avoided. And very important is this thrombolytic therapy, it is associated with hemorrhagic manifestations. It is associated with hemorrhagic manifestations. So that is the reason why we don't give thrombolytic therapy just like that. Only when it is indicated, we give thrombolytic therapy. I think this, yes, Ekadashi, is this point clear for you? We give thrombolytic therapy only when there is transmural infarction. Yeah. Coming to the next question. Rescue PCI is done for which of the following? Right. So the definition of the rescue PCI is that even after thrombolytic therapy, if the patient is having persistent chest pain with ST elevation more than 90 minutes after thrombolysis, even after thrombolysis, the patient is having chest pain, right? And the ECG is showing the ST segment elevation even after 90 minutes of thrombolysis, then you need to do rescue PCI. Okay, that means this we consider it as, this scenario we consider it as failed thrombolysis. right? Failed thrombolytic therapy. Then we do this rescue PCA. Okay, that's a textbook definition. More than 90 minutes is a textbook definition, right? Next question. Yeah, one question on the murmur. The continuous murmur is the murmur that begins in systole and continues without interruption, encompassing the second heart sound throughout the diastole or the part of thereof, part of the diastole. Which of the following leads to a continuous murmur? Which of the following leads to the continuous murmur? Yes. Yeah, very good, Ramasubbu. The answer is peripheral pulmonic stenosis. So, what do you mean by the word peripheral pulmonic stenosis? That is branched pulmonary artery stenosis. Branched pulmonary artery stenosis. You will have the continuous murmur. That means either it is in the right descending pulmonary artery there is stenosis, or in the left descending pulmonary artery there is stenosis where you will have a continuous murmur. Whereas in case of severe pulmonary artery hypertension, what these patients will develop is pulmonary regurgitation. Because of pulmonary regurgitation, they will develop early diastolic murmur. And this early diastolic murmur is the Graham-Steele's murmur. This will be Graham-Steele's murmur. Okay. And this type A dissection will cause aortic regurgitation. Even this will cause the early diastolic murmur. Right. And rupture of the cardiac chamber. Right. The entire heart is completely ruptured. Right. So now, what are the other conditions where you will have the presence of this continuous murmur? That is PDA. That is nothing but your Gibson's murmur. And you also have this in case of ruptured sinus of Valsalva, RSOV. Right, and you also have this continuous murmur. 1 second, the ad is coming. Yeah, you will also have this particular continuous murmur in case of the AV fistula, and you will also have the continuous murmur in case of the coronary fistula, right? And you will also have the continuous murmurs in case of the venous hum. That is venous hum, where the continuous murmur is being heard over the supraclavicular area. And you also listen the continuous murmur in case of the mammary souffle, right? Mammary souffle is like during the pregnancy. Your mammary souffle and venous hum, they are the physiological murmurs, right? So the answer here is the peripheral pulmonic stenosis, right? This was the cardiology questions. Now, we'll move on to the questions related to the nephrology. A patient presents with the frequent urination, nocturia, and enuresis. The 24-hour urine volume was measured and recorded to be 7 liters. The urine osmolarity was 260 milliosmoles per liter. ADH assay was performed and the recorded values were reported as 0.8 picograms per ml. An MRI of the brain was performed and T1 weighted indicated the absence of the bright spot. What is the most likely diagnosis in this patient? Right. So this is like straight question. That is polyuria is there, polydipsia is there, and along with that the ADH levels were done. The ADH levels are reduced, and even you check the urine osmolality, the urine osmolality is reduced. So all these points, they are very much suggestive of your pituitary diabetes insipidus. Because there is absence of the bright spot. T1 weighted image showed the absence of the bright spot. Abdul Kalam, RSOV stands for ruptured sinus of Valsalva. Ruptured sinus of Valsalva. Okay, right. And now in case of, how is that you will rule out nephrogenic diabetes insipidus? In nephrogenic diabetes insipidus, the ADH levels that will remain normal. Okay. And how is that you will rule out the primary polydipsia? In primary polydipsia, the urine osmolality will be reduced, and even the serum osmolality also will be reduced. Both of them will be reduced in case of the primary polydipsia, right? So the correct answer here is the pituitary diabetes insipidus. Okay, next question. Yeah, so one question definitely you will be having on the ABG, arterial blood gas analysis. Definitely there is one question. So ABG finding of a patient said like pH is 7.12, PCO2 is like 50, bicarbonate 28. What do you think is the diagnosis? What do you think is the diagnosis? Yeah, very good. That is right? So that will be your respiratory acidosis with metabolic compensation, because your pH, it is decreased, and PCO2, it is increased. When both of them are moving in opposite direction, the primary acid-base disorder will be respiratory. So respiratory what? Respiratory acidosis because the pH is decreased. And what will be the compensation? Metabolic compensation is what you will observe, right? So the answer is A here. Okay, next question. A 60-year-old patient has come with a history of the hyponatremia, right? He was treated by a large volume of the hypertonic fluid over 24 hours, following which the patient developed the quadriparesis. What is the most likely cause for this particular patient's condition? Yeah, so whenever there is hyponatremia, what should be the rate of correction of the sodium? The rate of correction of the sodium will be, right, 0.5 milliequivalents per hour. The rate of correction of the sodium should be 0.5 milliequivalents per hour. Now, if you do a faster correction with a hypertonic saline, that will result in central pontine myelinolysis, which is also called osmotic demyelination syndrome. Which is also called osmotic demyelination syndrome, where there is rupture of the myelin sheath surrounding the pons, where there is the rupture of the myelin sheath within the pons. Okay, and in case of this osmotic demyelination syndrome, the classical presentation will be quadriparesis. And what will be the type of the quadriparesis that you will have in these patients is spastic quadriparesis. Spastic quadriparesis. And how will you diagnose this central pontine myelinolysis? That is by doing MRI, right? That is by doing MRI. MRI is the one which will reveal the lesion within the central pons. It will reveal the lesion within the central pons. And as such, is there any treatment? There is no specific treatment for central pontine myelinolysis. Okay. Only thing, like, you need to just give the physical therapy. That is physiotherapy for spastic quadriparesis, occupational therapy, and as well as the speech therapy is recommended. That's all. That is the only treatment for ODS or CPM. That is central pontine myelinolysis. Okay. Next question. Rinku Devi, a 26-year-old female, laborer by occupation, presents to you complaints of pain, abdomen, nausea, restlessness since 4 hours. She gives history of episodes of hematuria. Ultrasound showed 3 into 3 centimeters stone in the right renal pelvis. There is no evidence of hydronephrosis. Which of the following is the best procedure for the management of these patients? ESWL, PCNL, antegrade pyeloplasty, retrograde pyeloplasty. Right. So the size of the stone is how much? That is 3 into 3 centimeters. When the size of the stone is around 3 into 3 centimeters, then the option of the treatment, right? The option of the treatment here is percutaneous nephrolithotomy. The option for the treatment is percutaneous nephrolithotomy. I'll just try to tell you when you should do what. That is the ESWL. That is extracorporeal shockwave lithotripsy. Extracorporeal shockwave lithotripsy should be done when the stone size is less than 2 centimeters. Less than 2 centimeters, you need to do extracorporeal shockwave lithotripsy. And when is that you need to do PCNL? When the size of the stone is more than 2 centimeters, then you need to do percutaneous nephrolithotomy. Right, then what is this antegrade pyeloplasty, and as well as what is this retrograde pyeloplasty? Antegrade pyeloplasty is a surgical procedure used to treat ureteropelvic junction obstruction. Right, ureteropelvic junction obstruction is being treated by the antegrade pyeloplasty, whereas you take retrograde pyeloplasty. Retrograde pyeloplasty is a surgical procedure used for the treatment of the ureteropelvic junction obstruction, which is not the primary concern in this particular case. Okay, so the answer here is the PCNL, because the size of the stone is like more than 3 centimeters, more than 2 centimeters, right? Next question. Cutoff diagnosis of the priapism is 1 hour, 2 hours, 3 hours, and 4 hours. So what exactly is the priapism? It is like painful erection of the male genital organ. What is the cutoff for the diagnosis of the priapism? For how many hours, like the painful erection of the male genital organ should be there to consider it as priapism? to consider it as priapism? Yeah, very good, Nabi. Nabi has answered it. That is 4 hours. That is 4 hours. Then how is that you will treat this particular priapism? See, this priapism, it is of 2 types. One, we have what is called the ischemic priapism, and the other, like what we have, is non-ischemic priapism. Ischemic priapism is what? It is the painful erection due to impaired venous outflow. Right? It is painful erection due to impaired venous outflow. What is the treatment that you will give in case of the ischemic priapism is you need to do the aspiration of the blood from the penis. Right? You need to do the aspiration of the blood from the penis. And you also need to give intracavernosal injections. Right? Intracavernosal injections. That is in case of ischemic priapism. Whereas in case of non-ischemic priapism, what is non-ischemic priapism? It is the prolonged erection, and in non-ischemic priapism, you don't have pain. And that is caused by increased arterial inflow to the penis. And what is that you will do in the management? In the management, you need to treat whatever is the underlying cause, right? And embolization, right? Embolization of the abnormal vessel has to be done, okay? And that will be the treatment options, right? And yes, you also need to give the trazodone as well. So that we can give in case of non-ischemic priapism. So to call it as priapism, for how many hours the painful erection, I mean, the erection should be for nearly around 4 hours, okay? Right. One more question on the ABG. Calculate the anion gap for the following values. Sodium 137, potassium 4, chloride 100, bicarbonate 15. So, like, very important for calculating the anion gap, do we take the potassium into consideration? We don't take the potassium into consideration for calculating the anion gap. So it is sodium minus, right, chloride plus bicarbonate. So how much this value comes around? This value, it comes around 22 millimoles per liter. So what do we consider it as this? HAGMA, that is high anion gap metabolic acidosis. High anion gap metabolic acidosis. What are the causes for high HAGMA? Very important condition is diabetic ketoacidosis. The other conditions are lactic acidosis. The other conditions are renal failure. Even that will cause high anion gap metabolic acidosis. Next is the ethylene glycol intoxication. Next one is methanol ingestion. Okay, these are the causes for HAGMA, right? Whereas you take NAGMA. So to call it as NAGMA, the anion gap should be in between 8 to 12. What are the causes for NAGMA? The causes for NAGMA will be diarrhea, right? Will be diarrhea. The other causes will be renal tubular acidosis. Then the other causes will be the pancreatic fistula, right? And then we have carbonic anhydrase inhibitors, that is the acetazolamide. These are all the conditions which will be causing the NAGMA. That is normal anion gap metabolic acidosis. Yeah, even your RTA, renal tubular acidosis, that will be causing NAGMA. So you need to know how to calculate the anion gap, what are the conditions where you will have HAGMA, and what are the conditions where you will have the NAGMA. And treatment is what you need to treat the underlying cause in both the scenarios, right? Then, the next question. So we have a 56-year-old man presents to the emergency department with severe shortness of breath and fatigue for past 3 hours. He reports vomiting and epigastric pain 2 days back, for which he took an anti-emetic drug. His past medical history is significant for hypertension and the type 1 diabetes mellitus. The lab values show, right? One second, there is an ad which has come up. Yeah, the lab values show 356 milligrams per deciliter is the blood sugar value. The doctor advises the immediate ABG analysis, which revealed the pH of 7.32, PCO2 38, bicarbonate 15. This type of acidosis has increased anion gap. Which of the following condition does not belong to the same classification of metabolic acidosis as this patient? Yeah, so this particular patient is having high HAGMA. This particular patient is having the HAGMA, high anion gap metabolic acidosis. So the question says, which of the following condition does not belong to the same classification of the metabolic acidosis, right? Just now we have discussed, right? That is renal tubular acidosis, okay? That is renal aciduria. What is that you will have? NAGMA. right? You'll have the NAGMA, okay, normal anion gap metabolic acidosis, right? Whereas in renal failure lactic acidosis, you'll have the HAGMA, high anion gap metabolic acidosis, right? It's a straight question. The only length of the question is big, whereas the answer, if you see, it is very simple, right? This is how the questions will be in the INI-CET. All these are like previous year questions of the INI-CET. So how are they appearing? They are appearing very lengthy. But how is the answer? The answer is very simple, right? So just be with a positive attitude. That is what I was saying since the beginning of the session. Be with a positive attitude. Definitely you will hit the exam properly, right? Once you just become underconfident, then you will be ruining your exam. Just be strong, just be confident. Definitely you will be doing the best, because all these days you have worked a lot. Now, coming on to the next question. We have a 5-year-old child presents to the OPD with the pedal edema and as well as the facial puffiness for the last 5 years. The blood pressure is 126 by 80 millimeters of mercury and 3+ is the proteinuria. Examination showed 100 RBCs per high power field, right? And what do you think is the likely diagnosis in this patient? PSGN, minimal change disease, membranous glomerulonephritis, focal segmental glomerulosclerosis. Yeah. Why minimal change disease, yaar? Yes, Muguntan and as well as Yahai. It is not minimal change disease because there is hematuria, right? Sunil, you are also doing the same mistake. Anvesh, Anvesha, you are also doing the same mistake. Okay, there is hematuria, right? So when there is hematuria, can you consider it as minimal change disease? No, not at all. In minimal change disease, you will not have hematuria, right? And some of you are saying membranous glomerulonephritis, right? Gift chulu, membranous glomerulonephritis, as such, you don't have hematuria, first point. Second point is membranous glomerulonephritis, you get that in elderly individuals. You get that in elderly individuals. Okay, so that is the reason why not even membranous glomerulonephritis, right? And focal segmental glomerulonephritis, hematuria can be there, but why isn't it the FSGS? In FSGS, even though it is a nephrotic syndrome, you have the presence of the hematuria. But focal segmental glomerulosclerosis, it is commonly observed in adults. It is commonly observed in adults. So that is the reason why the answer is the post-streptofocal glomerulonephritis, right? See, a very, very important point or very, very important trick I will tell you, okay? Please don't jump onto the conclusion of the answers without reading the question properly, right? What is utmost required during the exam is complete concentration on the question, complete census on the question itself. No external thoughts which should be flowing through your brain during the exam, right? Actually, it's a very, very simple question. Very simple question. But why is it like many of the students have done the mistake in this, right? They did not see this particular hematuria component, urine examination showing 100 RBC. Okay, so please don't do this silly mistakes. Silly mistakes are the one which will drag you back, right? Even you might be a topper, even you might be a first rank candidate, but when you do a silly mistakes, your rank will go to something 100,000, 10,000 also. Okay, so the answer is the post-streptococcal glomerulonephritis in this question. Right, it need not be, Sunil, there is no history of preceding infection. They may give you in the history or they may not give you in the history. It is not mandatory. History of preceding infection, it is not mandatory that should be given in the history, right? But definitely hematuria will not be there in the BCD options, okay? And BCD options, B is the one which will see you will see in children, but you don't have minimal change disease having hematuria, right? So the answer is PSGN. Yeah. So coming on to the next question, the patient is having the following hand movements. In which of the following conditions will you see this? Thyrotoxicosis, hypercarbia, hemibalismus, hypoxia. Right. So, yeah, very straight question, right? So what exactly is this? This is like flapping tremors. Okay. So what are all the conditions where you will have flapping tremors? You will have that in case of carbon dioxide narcosis. You will have that in case of the uremic encephalopathy, right? And you will also have that in patients with hepatic encephalopathy. These are the three conditions where you will have this flapping tremors, which is also called as the asterexis. Whereas in thyrotoxicosis, you don't have the flapping tremors, right? You will have the tremors, okay, on outstretching the hand, you will have this particular tremors. Now, what exactly is your hemibalismus? Hemibalismus, 1 second, the ad has come up. Right. So what exactly is the hemibalismus? Hemibalismus, it is the one where you have flinging movements of the shoulders. Flinging movements of the shoulders. That is what is your hemibalismus. Whereas in hypoxia, the patient will be disoriented and as well as irritability. You don't have this flapping tremors or the astraxis, right? Next question. Okay. We have a 22-year-old patient has a fever with severe shortness of breath and red currant jelly sputum. On examination, he has altered sensorium with a respiratory rate of 40 per minute. Lab showed the serum creatinine 1.9, blood urea nitrogen 5 millimoles per liter. And which of the following is the correct about the management? OPD management, IPD management, ICU management. Yeah, what is that you want to do? Yeah. So in this, what is that you need to, Sunil, why you want to admit in ICU and that too you want to give IV drugs, Sunil? So you need to calculate the curve 65 in this patient. You need to calculate the curve 65. Okay, right? Abdul, why do you want to admit the patient to ICU, yeah? Right, you take whether this particular patient confused or not. Altered sensorium is there. Okay, give a score of 1. And urea levels, how much it should be? If it is more than 7, you need to give a score of 1. But here the urea levels is 5. So score is 0. Right? Respiratory rate more than 30 per minute. Okay, it is 40. Okay, give one more point. 1. Blood pressure should be less than 90 by 60 to give a point. And how much is the blood pressure of this particular patient? Okay, the blood pressure is not given. So blood pressure is not given, so leave it. And age of the patient more than 65 years, then you need to give a score of 1. Our age of the patient is only 22 years. So the score is 2. When the score is 2, you need to admit the patient in the ward, that is IPD management with IV drugs. When is that you need to admit the patient to ICU? When the score of your curve, if it is like more than or equal to 3, then you admit the patient to ICU. Okay. And if like the score is like 0 to 1, then it is OPD management. It is OPD management. Okay. I hope this point is very clear for you. Right? Those students who have done the mistake. So the answer here is, so any question related to pneumonia, what they will be asking you is, what is the next line management? Okay. So what is that immediately you need to make out is you need to calculate the CVRT. That is by your curve 65. And then you need to assess the treatment part. Okay. So that was about the questions related to the nephrology and the integration. Now, coming to the questions related to the neurology. So a 28-year-old male was brought to the emergency room with a history of the road traffic accident. The GCS progressively declined. This point is very, very important. GCS progressively declined over hours and axial T2 weighted MRI showed multiple, this point is also very, very important, multiple small hypodense lesions at the corticomedullary junction and basal ganglia. What is the diagnosis? Diffuse axonal injury, extensive subarachnoid hemorrhage, hypoxic cerebral injury, multiple hemorrhagic contusions, right? Very good. So all of you are answering it correctly. So what is that? Yeah, answer is A. What is that one point which is telling you that it is diffuse axonal injury is? Number 1, the progressive decline in the GCS. That is one point. Another point which is telling you that it is the diffuse axonal injury is the presence of multiple small hypotense lesion in the corticomedullary junction. So all these points, they are very much suggestive of the diffuse axonal injury, right? And in case of, whereas you take the other options, subarachnoid hemorrhage, can it occur following the road traffic accident? Yes, it can occur following the road traffic accident causing the head trauma. But in case of the subarachnoid hemorrhage, what is that you will have? You will have the presence of the blood. And where will be this presence of the blood? This particular blood will be there in the sylvian fissure. That is what you will have in case of subarachnoid hemorrhage. And they will also have the severe headache and neck stiffness on examination, right? Then you take the hypoxic cerebral injury. In hypoxic cerebral injury, why is that? The name itself tells you that is due to lack of oxygen supply to the brain, right? And there are various causes for hypoxic cerebral injury. That is cardiac arrest can cause hypoxic cerebral injury. Drowning can cause hypoxic cerebral injury. Respiratory failure can also cause hypoxic cerebral injury. But the MRI finding which has been given, that is the presence of the multiple small hypointense lesion. They are not in favor of your hypoxic cerebral injury. That is the reason why this is ruled out. Now coming to multiple hemorrhagic contusions. Multiple hemorrhagic contusions, right? It will be secondary to traumatic brain injury. It will be secondary to traumatic brain injury, right? But the specific location of multiple hypointense lesion in the corticomedullary junction is very much in favor of the diffuse axonal injury. What will be the clinical features in diffuse axonal injury? The patient will be in altered sensorium, cognitive impairment will be there, motor deficits will be there, there will be spastic quadriparesis, sensory abnormality will be there, abnormal posturing will be there, neurobehavioral changes will be there. So this will be in case of diffuse axonal injury. And what is the treatment? It is just only supportive care. That is what we do in case of diffuse axonal injury. Rehabilitation therapies, that is physiotherapy and occupational therapy. Some medications, that to symptomatic management. What is that symptomatic management? Because there is spasticity, you need to give the antispasmodic drugs. Right, you need to give antispasmodic drugs. Okay, that is what is the treatment for the diffuse axonal injury. Right. So 1 minute. Right. So that is about the first question on the diffuse axonal injury. Now, coming on to the next one. A female patient presents to you with a unilateral headache. It is associated with nausea, photophobia, and phonophobia. What is the drug of choice for acute management? This is also the one which is a straight question. This is not at all a difficult one. Okay. So nausea, right, photophobia and phonophobia, unilateral headache. All these points are suggestive of what? All these points are suggestive of your migraine. So in acute attack of migraine, what is that we give? Sumatriptan, right? And what exactly is your sumatriptan? Your sumatriptan, it is 5-HT 1B 1D receptor agonist. Right, 5-HT 1B 1D receptor agonist, and that is considered as the drug of choice. And how do it act? It will act by constricting the cranial blood vessels and decreasing the release of the inflammatory peptides. That is how this sumatriptan will act. Whereas you take all other drugs, you take flunarizine. What is flunarizine? It's a calcium channel blocker, and it is given as prophylaxis for migraine. It is not given as the acute attack. Propranolol, what is that? It's a beta blocker, and this is also given as prophylaxis for migraine, right? What is topiramate? Topiramate, it is an anticonvulsant drug. It is anticonvulsant drug. Okay, that is also given as the prophylaxis in case of migraine, but not for acute attack. Okay, so the answer here is the sumatriptan, right? Yeah. Yes, in diffuse axonal injury, yes, CT is the best, definitely. But you can also visualize that in MRI as well. You can also visualize that in MRI as well. Okay. Right. Now, we move on to the next question. Yes. So the next question is, what is the probable diagnosis for a 37-year-old male who is a chronic alcoholic and has recently stopped drinking alcohol but presents to the emergency department after 3 days with symptoms of disorientation, tremors, hallucination, then hypertension? Alcoholic hallucination, Korsakoff psychosis, delirium tremens, and then Marchia-Fava Bignami disease. Right. So here the correct answer is what? The correct answer is yes. Right. The correct answer here is the delirium tremens. Delirium tremens. So delirium tremens, it is the one which will occur 2 to 5 days after alcohol cessation. Right. 2 to 5 days after the alcohol cessation. Okay. What will be the clinical features of delirium tremens? Altered mental status, disorientation, hallucination, autonomic hyperactivity. And why is that this patient is having hypertension? This particular hypertension is because of the autonomic hyperactivity. Okay, so that is what is your delirium tremens. Then how is that you will rule out the other options? You take alcoholic hallucination. Please remember, the alcoholic hallucination is a condition which is characterized by auditory hallucinations. Right, it is characterized by auditory hallucinations. And these auditory hallucinations that will occur within that will occur within 12 to 24 hours after the alcohol cessation. Okay, so that is your alcoholic hallucination. Whereas you take Korsakoff psychosis. Korsakoff psychosis is what? It is also known as Wernicke's-Korsakoff syndrome. And why is this particular Korsakoff psychosis? This is due to B1 deficiency, right? And that is often associated with chronic alcoholism. But what will be the manifestation of the Korsakoff psychosis? The manifestation of the Korsakoff psychosis is memory loss, right? And cognitive impairment. That is what you will observe in case of Korsakoff psychosis, okay? And this Korsakoff psychosis that does not present with disorientation and as well as tremors. So that is the reason why your Korsakoff psychosis is completely ruled out. Then what is this Marchia-Favre-Bignami disease? So this is also the disorder which is associated with chronic alcoholism, right? And what is that you will have in these disease is demyelination of what? Demyelination of the corpus callosum. That is what is your the Marchia-Favre-Bignami disease. So it is also the rare disorder associated with chronic alcoholism. Right? What will be the clinical features in case of these? Fourth option, cognitive impairment will be there. There will be cognitive impairment. Okay. And in case of the fourth option, you don't have disorientation, you don't have tremors, you don't have hallucination. Okay. So the answer here is the delirium tremens. Right? In case of delirium tremens, you need to be aware of the treatment. So what is the treatment for delirium tremens? What do you think is the treatment for delirium tremens? Anyone? Yeah, yes, Sanika Dabir, you're right. We give benzodiazepine, that is diazepam or lorazepam should be given. So this diazepam or lorazepam is the one which will control the symptoms and prevent the seizures and as well as the agitation. That will be the treatment for delirium tremens. Supportive care is also the another important form of the treatment, and you need to treat the underlying alcohol use disorder and withdrawal. Okay, so that is about the delirium tremens. So the treatment is diazepam and as well as the lorazepam. Next question. Okay, so this is like the question. Yeah, lorazepam is best because it's fast acting and it does not cause respiratory center depression. Okay. Which of the following combination of the seizures and its corresponding medication is not accurate? GTC is lamotrigine, focal seizures, levetiracetam, typical absence, topiramate, myoclonic, valproic acid. Yes, anyone? Yeah, very good. So the answer is C, right? In case of GTCS, actually the drug of choice is valproic acid, but lamotrigine also can be given. And in focal seizures, drug of choice is carbamazepine. Levetiracetam also can be given. But for typical absence seizures, the drug of choice is ethosuximide, right? Or the valproic acid. Ethosuximide or the valproic acid. So less than 4 years, we give ethosuximide in absence seizures. More than 4 years, we give valproic acid. Okay, why is that we don't give valproic acid less than 4 years? Because valproic acid is hepatotoxic. So less than 4 years, the individual cannot bear this particular hepatotoxicity caused by your valproic acid. So that is the reason why less than 4 years, we don't give valproic acid. We give it after 4 years. Okay, then next is the myoclonic drugs. What is a drug of choice? That is valproic acid. That is a true statement. Okay, but the one which is incorrectly matched is the typical absence seizures. We don't give topiramate. We don't give topiramate. Okay, so that was the question on the anti-epileptics. And I'll just show you a table related to this anti-epileptic, very, very important table. Right? Which particular anti-epileptic for which type of epilepsy? Yeah. So you see this table, which is very important. So for absence seizures, it is ethosuximide and valproic acid. For generalized tonic-clonic seizures, grand mal, it is valproic acid and lamotrigine. Simple partial seizures, it is the carbamazepine or phenytoin. Same is even your complex partial seizures. And myoclonic jerks or myoclonic seizures, the drug of choice is valproic acid or clonazepam. Then atonic seizures, the drug of choice will be valproic acid and lamotrigine. Infantile spasm, which is also called West syndrome, that is ACTH therapy or vigabatrin if it is associated with tuberous sclerosis. Febrile seizures, it is not only that you need to reduce the temperature, right? You also need to give the rectal diazepam. Then the status epilepticus. Status epilepticus, like the drug of choice is lorazepam. Drug of choice is lorazepam. And photosensitivity epilepsy, you need to avoid the triggering of the visual stimuli or the flashlight. Okay. So this is one particular table which is very, very important. I'll be sending you this PDF once the session is over. Yeah. Coming on to the next question. A 30-year-old man presents with distal leg weakness, reduced muscle stretch reflexes with no complaints of tingling or numbness. On examination, there is atrophy of the muscles below the knee. The following clinical findings are seen, and similar history is seen in the elder brother. The most probable diagnosis is. The most probable diagnosis is. Okay, I think we have some mixture of the students. Some students, they're watching the past questions. Right, so the answer is the Charcot-Marie tooth disease. The answer is Charcot-Marie tooth disease. What is Charcot-Marie tooth disease? This is a form of, right? This is a form of hereditary neurological disease that affects the peripheral nerves. That affects the peripheral nerves. And because the peripheral nerve is affected, the distal leg weakness, reduced muscle stretch reflexes, that is what is observed just below the knee, because it is a form of the peripheral neuropathy. And why? How is that you are able to tell hereditary? Because the similar history is there even within the elder brother. So these patients, they'll have muscle weakness and muscle wastings, and there will be loss of the deep tendon reflexes. There is hyporeflexia or areflexia will be there. Okay. Then you take the other options. That is Refsum's. What is Refsum's disease? Refsum's disease, it's a genetic disorder which is characterized by body's inability to break down the phytanic acid. Okay. So there is increased accumulation of the phytanic acid. And this Refsum's disease, it is due to deficiency of the enzyme which is required for the metabolism of the phytanic acid. And this enzyme is deficient mainly because of the gene mutation. What is that particular gene that is being mutated? That is PHYH gene that is being mutated, and that will result in Refsum's disease. And what will be the clinical features of Refsum's? They'll have peripheral neuropathy. Along with peripheral neuropathy, the patients with Refsum's, they'll have retinitis pigmentosa. They will also have the hearing loss. They will also have the balance issues. They will have the skin changes. All these are observed in case of the Refsum's. Okay. And even anosmia, absence of smell, that is also the notable feature in case of the Refsum's. Next, you take the neuropathy associated with the Sjogren's. In Sjogren's, what is the classical clinical manifestations? Dry eyes and dry mouth, which is not there in this particular patient. So that is why your Sjogren's is being ruled out. That is the reason why Sjogren's is being ruled out. Okay. And the next is rheumatoid arthritis. In patients with rheumatoid arthritis, you should have the stiffness of the small joints. That is mainly metacarpophalangeal joints and proximal interphalangeal joints. And there should be early morning stiffness for more than 1 hour. That is what you should have in rheumatoid arthritis, which is not there in this patient. So even your rheumatoid arthritis is also ruled out. So the answer here is what? That is Charcot-Marie tooth syndrome. Charcot-Marie tooth syndrome. Okay. So it is a hereditary form of the neuropathy. Hereditary form of neuropathy. What type of inheritance? It can be anything. So it is either autosomal dominant or the autosomal recessive type of the inheritance. Okay. Is there any cure for this? No. There is no cure for the Charcot-Marie tooth syndrome. It is only the physiotherapy, occupational therapy, and assisted devices. That is only what is required in case of Charcot-Marie tooth. Okay. So the answer is the first option, CMT. Next question. Right. So what is the diagnosis for a 24-year-old female who presents with fever, headache, ataxia, nausea, and vomiting for past 3 days? The patient exhibit neck rigidity and the hip and knee flexion upon the passive flexion of the neck. The lumbar puncture was done. See, CSF analysis, that is definitely a very, very important question. Lumbar puncture, meningitis, very important question. What is given here? The opening pressure is increased, cloudy white precipitate, WBC is increased, neutrophilic predominant, sugars reduced, and ratio 0.2. Protein 70, latex agglutination test positive, Lumulus lysate test negative. What is it suggestive of? Very good. So this is suggestive of the bacterial meningitis. Why is that we need to consider bacterial meningitis? Because it is neutrophilic predominant, because the glucose levels are reduced, because the proteins are elevated, because the CSF pressure is increased. So all these are the points suggestive of bacterial meningitis. Now, why is that we don't consider tubercular, viral, or fungal meningitis? Because in all these conditions, you have lymphocytic predominance. That is the very important point which will differentiate bacterial meningitis from the tubercular, viral, and as well as the fungal meningitis. Okay. Now, you have two important tests which has been given, latex agglutination test and as well as the negative Lumulus lysate test. What is this both suggestive of? Even these two tests, they are very much suggestive of the bacterial etiology, right? And what is the common bacteria that will be causing the bacterial meningitis? We have the Streptococcus pneumonia, Neisseria meningitidis, Haemophilus influenza. These are the common bacteria which will be causing the bacterial meningitis. Okay, the correct answer is BM, bacterial meningitis. Right. Yeah. Yeah. The very important is that neutrophilic predominant. Okay. Right. Next question. Which of the following subsequent options is not viable treatment choice for GB syndrome? Right. So Guillain-Barré syndrome, the another name for it is what? That is AIDP, acute inflammatory demyelinating polyneuropathy. And it is a disorder where the individual will have the acute flaccid paralysis. And this acute flaccid paralysis, it is the ascending type of paralysis, initially lower limbs, then trunk, and then the upper limbs. Okay. And in these patients, the first important sign will be the deep tendon reflexes are lost. Can anyone tell me which cranial nerve is affected in patients with the GB syndrome? Which cranial nerve is affected in patients with the GB syndrome? Anyone? So the cranial nerve which is affected in GB syndrome, that is the seventh cranial nerve, not third, not third. It is the seventh cranial nerve that is affected in case of the GB syndrome, right? And how is that you will diagnose the GB syndrome? The investigation of choice for the GB syndrome. Anyone? First of all, what is the etiology? The etiology should be preceding infections, right? That is Campylobacter jejuni bacterial infection, or it could be preceding viral infection also. But the most common is the Campylobacter jejuni infection. And what is the pathogenesis? That is molecular mimicry. Molecular mimicry is the pathogenesis. Yeah. The investigation of choice will be no. It is not CSF analysis. It is not CSF analysis, yeah. What is the investigation of choice? No. Because this albuminocytological dissociation, you also have that in Freund syndrome. You also have that in Freund syndrome. What is Freund syndrome? Freund syndrome is like where there is a spinal block secondary to tumor, right? That albuminocytological dissociation can also be seen in the Freund syndrome. That is the reason why CSF analysis is not the investigation of choice. Yeah, bladder and bowel impairment will be there, but very minimal. Very minimal bladder and bowel impairment will be there in Guillain-Barré syndrome. Not the nerve conduction study. Nerve conduction study will just show you demyelinating pathology. There are multiple conditions where you have demyelination. The investigation of choice is the antibodies, right? It is the antibody. The antibody is the anti-GM1 antibody. The antibody is the anti-GM1 antibody. Okay. Whereas you have Miller-Fisher syndrome. Right here, the antibody is the anti-GQ1 antibody, right? And what is the drug of choice? What is the drug of choice for the Guillain-Barré syndrome? Drug of choice will be the intravenous immunoglobulin. Intravenous immunoglobulin. Then what is the other alternative therapy? The other alternative therapy that you can do in case of Guillain-Barré syndrome is plasmapheresis is what you need to do. And ventilatory support, does it require in patients with Guillain-Barré syndrome? Yes. When will you require? If there is respiratory muscle paralysis, that will happen in almost 5% of patients where there is respiratory failure, type 2 respiratory failure. That is the point when you require the ventilatory support. So please remember, there is no role of steroids. There is no role of steroids. Okay. So that's a very, very important point you need to know. There is no role of steroids. Okay. Next. So that was about the Guillain-Barré syndrome. The CSF analysis showing the albuminocytological dissociation is not the feature of only GBS. It is also the feature of Freund syndrome. Yeah, next question. Yes, this is another very, very important area for the questions. That is ABCD2 scoring system. According to ABCD2 scoring, which factors indicate a greater likelihood of patients with TIA experiencing the future stroke? Age less than 60 years, SBP more than 140, then duration of TIA, right, more than 5 minutes, diabetes mellitus. Which factors indicate a greater likelihood of the patients with TIA experiencing the future stroke? Okay. Okay, let me just tell you. So among this particular ABCD2 score, right, what does this particular A represents for you? A represent the age of the individual. Age of the individual, if it is more than 60, that is a high risk. But age less than 60, it is not a high risk. Okay, then SBP more than 140, yes, it is a high risk. Definitely it is a high risk. But not diastolic blood pressure also should be more than 90. Okay, that is the reason why your option B is gone. That is the reason why option B is gone. Then what should be the duration of the TIA to consider it as the high risk? The duration of the TIA, it should be more than 2 hours for the TIA to get converted into the stroke. So even your option C is also gone, right? Then what is the correct answer here? The diabetes. The presence of diabetes, it is considered as high risk for a patient of TIA to go into a state of the future stroke. Okay, so the answer is what? Diabetes. Whoever has answered D, that is correct. So in the ABCD2 scoring system, A stands for age more than 60 years. B stands for blood pressure more than 140 by more than 90. And C stands for clinical features. What will be the clinical features having more high risk? That is unilateral weakness, that is hemiparesis, right? And D stands for duration more than 60 minutes. And one more D, that is diabetes mellitus. So this is the risk factors to tell the TIA. TIA stands for what? That is transient ischemic attack. This transient ischemic attack that will progress to the development of stroke. Okay, this is very, very important question. Right? What ABCD2 scoring system and TIA progressing to the stroke, right? Next question. The duration should be more than 60 minutes. Sajan, more than 60 minutes. I said 2 hours. Huh? Yeah, I'm sorry. More than 60 minutes. I'm very sorry. More than 60 minutes, right? Next. Yes. Now, coming to the next question, which of the following statement is false regarding the patients with trigeminal neuralgia? More common in females, pain along 5-2, 5-3 divisions of the trigeminal nerve, that is maxillary and mandibular division, deep-seated pain, no objective signs of sensory loss. Which of the following is a false statement regarding trigeminal neuralgia? Okay, please remember, trigeminal neuralgia, it is more common in females rather than males. That's a true statement. And it is more common, the pain is more common in the maxillary and the mandibular division, but not in the ophthalmic division. In ophthalmic division, what is very common is autonomic symptoms are very common. Autonomic symptoms are very common in case of the ophthalmic division. And very important is, it is not a deep-seated pain, right? It is a superficial pain, right? It is a superficial pain, right? And this particular pain, it will be there only for a few seconds. It will be there only for a few seconds. And this pain will be like electric shock-like sensation. This pain will be like electric shock-like sensation. Okay, and there is no objective sensory loss. That's a correct statement. What is a false statement here? Deep-seated pain is a false statement. Now you need to be very much aware of the drug of choice. Can anyone tell me what is the drug of choice in case of trigeminal neuralgia? Drug of choice for trigeminal neuralgia. Yeah. So we give carbamazepine, and if the patient does not respond to carbamazepine, then we give oxcarbamazepine. Oxcarbamazepine. Then what is the other molecules that can be given? The other molecules that can be given is the gabapentin. So carbamazepine, oxcarbamazepine, and as well as gabapentin. These are the commonly used drugs. Okay, and these patients will also have muscle spasms. So for the treatment of muscle spasm, we need to give baclofen, which is a skeletal muscle relaxant, right? Which is a skeletal muscle relaxant. Now, the other drugs which can be given for the treatment of pain is tricyclic antidepressants also can be given. What is the tricyclic antidepressants? Amitriptyline or nortriptyline can be given to manage the pain. Okay. And if medical management does not work, if the medical management does not work, then you need to do surgical treatment. What will be that surgical treatment? That surgical treatment will be microvascular decompression procedures, right? Microvascular decompression procedures, and then gamma knife radiosurgery, where we give high dose radiation that is focused on the trigeminal nerve root. Gamma knife radiosurgery, where high dose radiation is focused on trigeminal nerve root. Then next important is rhizotomy. Next important is rhizotomy. So rhizotomy in this particular procedure, what is that we do is nerve fibers associated with trigeminal nerve, they're selectively destroyed using the heat, chemicals, or electrical current. That is about your rhizotomy. And that completes the discussion of your trigeminal neuralgia, right? Next. Yeah, which of the following statements about the Weber syndrome is incorrect? Incorrect. So first of all, what exactly is your Weber syndrome? Right, good. So Weber syndrome, it's a midbrain stroke syndrome. It's a midbrain stroke syndrome. Okay. And what are the structures which are affected in case of Weber syndrome? You have ipsilateral third nerve palsy and contralateral involvement of the corticospinal tract. So these patients will have the ipsilateral third nerve palsy. And because of contralateral corticospinal tract involvement, there will be contralateral hemiplegia. And corticospinal tract is an upper motor neuron. So thereby there will be contralateral spasticity as well. And ipsilateral paralysis of the lower face. That is not observed in case of the Weber syndrome, right? Now, you take the facial paralysis. That is usually observed in facial nerve palsy. That is usually observed in the facial nerve palsy. And in order to have the facial nerve palsy, the lesion should be in the pons. The lesion should be in the pons, but not in the midbrain. So your Weber syndrome is what? It's a midbrain syndrome, right? So that is the reason why the answer D, that is fourth option, will not be there in case of Weber's. So this completes the discussion of the questions related to the neurology. Then we'll quickly take up the questions related to the pulmonology, right? So until now, I think we have done with endocrinology, we have done with cardiology, we have done with nephrology, and we have done with the neurology. So next is the pulmonology. Right. So as I have said you, I'll be sending this particular PDF or PPT after the class with annotations or with explanation. I'll be sending that on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? And you can follow me on my Instagram, that is Rajesh Gubba, for the recent updates related to general medicine, right? Okay. Now coming on to the questions on the pulmonology. So we have a 45-year-old man. He's being ventilated for ARDS following a lobar pneumonia. The bedside nurse has a number of questions regarding the strategy for ventilating this man as his lung function improves. Which of the following points is correct? Which is a true statement? Which is a true statement? Answer. During weaning, patients should not be allowed to go for long periods with no mechanical ventilatory support if they are showing signs of respiratory distress. Second, if the patient is febrile, minute volumes will be lower. Third, PEEP should be weaned to 0 before extubation. And D, fraction-inspired oxygen, PaO2 113 millimeters of mercury. Tracheostomy should be done should be immediately performed if the patient fails SVT. So this is a tricky question. Let me see how many of you can answer this. Right. No, I did not get the correct answer from any one of you. C is not correct. D is also not correct. Okay. So, no, even B is also not correct. Right. So, very good, Sunil Acharya. So, the answer is A. Answer is A. Let me just solve this point by point. Right. The first point is, if the patient is febrile at the time of weaning the patient from the ventilator, please remember, the patient should not be allowed to go for long periods with no mechanical ventilatory support if they are showing signs of respiratory distress. If they are showing signs of respiratory distress, don't wean the ventilator. Don't keep the patient ventilator off. No, it should not be done. That is a correct statement in ARDS patient. Now, when the patient is febrile, minute ventilation or minute volumes should be high. Minute volume should be high. What do you mean by the word minute volume? Minute volume is nothing but the total ventilation. That is respiratory rate multiplied by tidal volume. Respiratory rate multiplied by tidal volume is the one which will give minute ventilation. And when the patient is febrile, respiratory rate increases. So thereby minute volume also increases. So the correct answer is not your B. B is wrong. Then coming to this particular PEEP, always remember, before weaning, the PEEP should not be made to zero. PEEP should not be made to zero. Why is the PEEP required before extubation? PEEP is required for opening of the alveoli at the base. Right? Because the inflammatory exudate, it will accumulate in the base. Right? So the basal alveoli, they get affected more. So PEEP is definitely required before weaning to keep the basal alveoli being open. Then you need to maintain FiO2, right? You need to maintain the fraction of the inspired oxygen to ensure that the PeO2 should be around 60 to 80 millimeters of mercury, not 113 millimeters of mercury. That's a wrong statement. Okay. Then what about tracheostomy? Should be immediately performed if the patient fails SBT? No. See, if the patient is failing one SBT, don't do tracheostomy. If the patient is failing multiple SBTs, right? If the patient is failing multiple SBTs, then only you need to do tracheostomy. Okay. So the correct answer is what? First option. Okay. I hope this explanation is clear. Right. Coming on to the next question. So we have a patient, right? What would be the most appropriate course of action for managing a 45-year-old patient who has been SBT means spontaneous breathing trial. Yes, Meet Patel. Spontaneous breathing trial. What is spontaneous breathing trial? Spontaneous breathing trial is that where we place the individual on minimal ventilatory support. We place the individual on minimal ventilatory support. If the patient survives the minimal ventilatory support, then we will take out the ventilator. We will take out the ventilator. And during the spontaneous breathing trial, what is all that we need to check for? We need to check for if there is any development of respiratory distress. You need to check for respiratory rate. You need to check for the pulse rate. You need to check for the blood pressure. You need to check for the saturation. All these we need to monitor during that spontaneous breathing trial. If these become abnormal during spontaneous breathing trial, then patient should not be taken out from the ventilator. The patient should be continued with the ventilator. Okay, that is what is called SBT. Who's that? Meet Patel. Yes, Meet Patel. Is that clear about SBT, spontaneous breathing trial? Right. Okay. Now, yeah, coming to this question. So the patient is having the chest X-ray shows 3 centimeters mass in the upper lobe near the lung apex. What is that you will do? Will you do bronchoscopy, CT guided biopsy, sputum cytology, sputum for AFB? Right? Yeah. So it is the CT guided biopsy. Why? Because the tumor, right, or the lesion is present at the apex. when the lesion is present in the apex, you cannot do the bronchoscopy to take the biopsy from that particular place. Okay. When will you do bronchoscopy? Bronchoscopy is usually done if the patient is having the central tumor, right? Or if the patient is having endobronchial tumor. That is the point when we do this bronchoscopy, right? And this bronchoscopy, it is not effective in case of the peripheral lung masses. Just 1 minute. Okay, so for peripheral lung masses, your bronchoscopy is not effective. Ours is what the tumor is present at the apex. It's a peripheral mass, so you cannot do bronchoscopy, right? And sputum cytology, it will not help you in making out the tumor. You may have some malignant cells, but the sensitivity and specificity of the sputum cytology is very less. And sputum for AFB is not required because there is a mass in the upper lobe, which is very much suggestive of the malignancy. Okay, because the patient is having the history of smoking, right? Now, can anyone tell me what type of the tumor this could be? Can anyone tell me what type of the tumor this could be? Yeah, very good, blast. That is small cell carcinoma of the lung. Small cell carcinoma of the lung, because he is a smoker, right? The tumor you will have in small cell carcinoma, you will have the tumors in the peripheral location, even in the central location as well, right? Yeah, which of the following is not a feature of the Gase-Box syndrome? Which of the following is not the feature of the Gase-Box syndrome? Anyone? Yeah, usually we consider small cell carcinoma. It could be even squamous cell, but preferably it is small cell because the individual is a smoker. Yes. Which of the following is not the feature of the Gase-Box? The one which you don't see in case of the Gase-Box. First of all, what is Gase-Box syndrome? Gase-Box syndrome, it occurs in patients with the COPD. It occurs in patients with the COPD. In patients with COPD, there will be hypoxia. And hypoxia, it is a stimulus for the erythropoietin production. And this erythropoietin is the one, when it is produced in excess quantity, that will cause erythrocytosis. There will be erythrocytosis. And in patients with Gase-Box syndrome, they will have normal leukocyte count. And they can be obese individuals as well. But what is it you don't have in patients with Gase-Box will be hypotension. Hypotension is not the feature of the Gase-Box, right? In fact, because of this erythrocytosis, there will be increase in the blood pressure, but not decrease in the blood pressure. Okay, so that is what is the Gase-Box syndrome, which is like the complication of the COPD, right? How do you treat this Gase-Box syndrome? Okay, the treatment approach for Gase-Box syndrome, it revolves around the underlying treatment of COPD. So you treat COPD, definitely the Gase-Box syndrome will get corrected. Okay, so the answer is hypotension will not be there, right? Next question. Which of the following is the initial probable diagnosis for a 5-year-old child who has been experiencing recurring respiratory infections with thickened sputum, bronchial wall thickening observed on chest X-ray, and has had steatorrhea since birth? Hyaline membrane disease, cystic fibrosis, alpha-1 antitrypsin deficiency, malabsorption syndrome. Yes, right. So, very good. So the correct answer here is, right, the correct answer here is cystic fibrosis, not malabsorption syndrome, Swati. It is cystic fibrosis. Why? First point, the child, 5-year-old child, recurrent respiratory tract infection, then the presence of thick sputum and presence of steatorrhea. All these points are suggestive of cystic fibrosis. In cystic fibrosis, the recurrent infections will cause what? The recurrent respiratory tract infections will cause bronchiectasis, right? And that too, you will have the bronchiectasis in the upper lobe, and these patients, they will have a very thick sputum, right? And how is that you will be treating this particular thick sputum is, you need to give 7% sodium chloride to liquefy the sputum. right? And why is that this steatorrhea? The presence of the steatorrhea, it is indicative of the pancreatic insufficiency. It is indicative of the pancreatic insufficiency, right? So this is the common manifestation in cystic fibrosis. This is a common manifestation in cystic fibrosis. Okay. Now, you take hyaline membrane disease. Hyaline membrane disease, right? It is a respiratory condition that primarily affects the infants. Okay, our patient age is having 5 years. So your hyaline membrane disease is being ruled out, right? Then you take alpha-1 antitrypsin deficiency and as well as the malabsorption syndrome. See, child having steatorrhea, recurrent infection is very much suggestive of cystic fibrosis, right? And in case of your alpha-1 antitrypsin deficiency, there will be emphysema. That will be panasnar emphysema will be there, but the thick sputum will rule out your alpha-1 antitrypsin deficiency. Okay, so in cystic fibrosis, the multiple organs are affected: lungs, bronchiectasis, GIT, pancreatic insufficiency, right? And diabetes mellitus can be there, and liver, primary biliary cirrhosis will be there. Okay, and in cystic fibrosis, you also have the involvement of the genital tract. There will be infertility in males and as well as females. And why is this? Due to mainly CFTR gene mutation, right? CFTR gene mutation. Now, it is an inherited disorder. Now, can anyone tell me what type of inheritance you will have in cystic fibrosis? What type of inheritance you will have in cystic fibrosis? Yes. Anyone? Just 1 minute. So, yeah. So what type of inheritance that you will have is, it is the autosomal recessive type of inheritance. It is autosomal recessive type of inheritance. And next important thing you need to know is, like, yeah, very good. Who is that? Mugundan, right? So which chromosome is affected, Mugundan? Which chromosome is affected? Chromosome number. I am not asking amino acid number. Chromosome I am asking. Which chromosome is affected? Yeah, very good. So the chromosome that is being affected here is, that is chromosome number 7, right? And now the on this particular chromosome, you have a gene, CFTR gene, and this particular CFTR gene, it has totally 1480 amino acids. Out of these 1480 amino acids, like where is the abnormality? The abnormality is on the 508 position. Okay, the abnormality is in the 508 position. What is that amino acid which is present on the 508th position? That is phenylalanine is being present, and that phenylalanine is being deleted. That phenylalanine is being deleted. Okay, yeah. What is the investigation of choice, KK? The investigation of choice. Your sweat chloride test is a screening test. Sweat chloride test is a screening test. It is not the investigation of choice, right? So the investigation of choice will be the genetic analysis. Investigation of choice will be the genetic analysis. Okay, right? Sweat chloride test is a screening test, right? And how much should be that the sweat chloride levels? The sweat chloride levels should be more than 60 milliequivalents per liter. Now, can anyone tell me in which condition you will have false positive elevation? What's the differential diagnosis of the sweat chloride levels more than 60? What is the differential diagnosis for the sweat chloride levels more than 60? Anyone? In which other conditions you will have sweat chloride levels more than 60? Yes. Addison's. The other condition is Addison's. Okay, right. Now, what is CFTR modulator therapy? Anyone? What is the drug which we give for CFTR modulation? What is the drug that we give for CFTR modulation? Anyone? The drug that we give for CFTR modulation is the ivacaftor. Yeah, that is ivacaftor. Okay, right. Yeah, so basically the cafters. So that was about the cystic fibrosis. Yeah, coming on to the next question. A 65-year-old chronic smoker came to the medicine outpatient department with complaints of upper chest discomfort and drooping of the eyelid. Drooping of the eyelid. Okay. And he also complained of pain radiating to the upper arm, tingling sensation in fourth and fifth digits of his left hand. The chest X-ray is given below. Which of the following is the most likely diagnosis? Pancoast, upper lobe pneumonia, SVC syndrome, aspergilloma. Right, very good. So that is excellent. That will be your Pancoast tumor. Because what are the points suggestive of Pancoast tumor? So Pancoast tumor, it is an apical tumor. First point, it is an apical tumor. And in case of Pancoast, you have the compression of cervical sympathetic chain. Because of compression of the cervical sympathetic chain, there will be pain radiating to the upper arm and there will be tingling sensation, right? And why there is drooping of the eyelid? The drooping of the eyelid, whichever is there, right? Drooping of the eyelid, whichever is there, that is mainly because of the Horner syndrome. That is due to compression of or destruction of the sympathetic chain. Horner syndrome, where there will be ptosis, meiosis in ophthalmos, then there will be anhydrosis, and there will be also loss of ciliospinal reflex. And this particular Pancoast tumor, you tell me quickly, what type of malignancy is this Pancoast? What type of malignancy is Pancoast? In which type of tumors you will have this Pancoast? Adenocarcinoma. Adenocarcinoma. Okay, adenocarcinoma, you will have this Pancoast. Okay, whereas SVC obstruction, that is what is observed in small cell carcinoma of the lung. Right, small cell carcinoma of the lung. Okay, whereas Pancoast, right, it is apical tumors which is observed in adeno. Whereas in SVC obstruction, you will have the SVC obstruction is present in small cell carcinoma of the lung. So the answer here is the Pancoast. Right. Next question. So the next question is, yeah, what should be the next appropriate action in the management of an elderly male who has been on prolonged bed rest and is now experiencing symptoms of breathlessness and chest pain? CT pulmonary angiogram, ECG, CT thorax, echocardiography. Very good. So Swati, what is the diagnosis? The diagnosis is the individual is having prolonged bed rest. Now he is experiencing breathlessness. So this is very much suggestive of pulmonary embolism. And in pulmonary embolism, what is the investigation of choice? That is CTPA, right? That is CT pulmonary angiogram. But what is the screening test? What is the screening test that you will be doing in pulmonary embolism? The screening test that you will be doing in the pulmonary embolism is the D-dimer. So the D-dimer levels, they are elevated. The D-dimer levels are elevated, right? And the investigation of choice is CT pulmonary angiography. Now, if you are not able to do CT pulmonary angiography, then what is the next best investigation? Next best investigation is ventilation perfusion scan, because in pregnancy, you cannot do CT pulmonary angiography. In that case, you need to do the ventilation perfusion scan. What will be the most common ECG finding in patients with pulmonary embolism? That will be sinus tachycardia, right? And CT thorax not required. Echocardiography. What is the echocardiography? Very, very important sign. That is nothing but McConnell sign. Can anyone tell me what is McConnell sign? Anyone? What is McConnell sign? Quickly. Yes, Mugundan, what is McConnell sign? So it is RV free wall, right? It is RV free wall hypokinesia with apex being hyperkinetic. Right, with apex being hyperkinetic. Okay, right. So that is about your echocardiography, right? And you will notice that the RV is dilated. You will notice that the RV is dilated. That is what you will observe in echocardiography. Yeah. So discussion about the pulmonary embolism is, what will be the important points about the pulmonary embolism? Right. The important points about the pulmonary embolism is, like, the most common clinical feature in case of pulmonary embolism will be dyspnea. Right. That will be dyspnea. But if the patient is having massive pulmonary embolism along with dyspnea, these patients will have right ventricular failure and as well as hypotension. If there is right ventricular If there is right ventricular failure and hypotension, you need to give thrombolytic therapy. You need to give thrombolytic therapy. That is for massive pulmonary embolism. But you take submassive pulmonary embolism. In case of submassive pulmonary embolism, right ventricular failure will be there, but blood pressure will be normal. And in these patients with submassive pulmonary embolism, we don't do thrombolytic therapy. We give anticoagulants. We give anticoagulants. Okay. So, and if there is recurrent pulmonary embolism from the lower limbs, then you need to place IVC filter. Right? IVC filter you need to place if there is recurrent pulmonary embolism from the lower limb veins. Okay. So that is about your pulmonary embolism. Okay. Yeah. Name of the criteria is Wells criteria. And if the Wells criteria, if the value is like more than 6, that is very much suggestive of pulmonary embolism. Investigations already I have discussed. And chest X-ray. Chest X-ray is very, very important in case of pulmonary embolism. Right? What is all that? One is so what is all that you will have is, one is Hampton's hump, right? Then next is the Pallas sign. 1 minute. What is it? Right. So yeah, the Hampton's hump, and the other one is the Pallas sign, and then the Western mark sign. Okay. Now, what is this Hampton's hump? It's a wedge-shaped infarct distal to the pulmonary embolism. What is Pallas sign? It is enlarged right descending pulmonary artery. What is Western mark sign? It is pulmonary oligemia. Pulmonary oligemia. That is what is your Western mark sign. Okay. So this is about the topic related to pulmonary embolism. Next question. Next question is on pulmonary function test. Pulmonary function test. This is a very, very important area for the questions. Pulmonary function test, definitely you need to revise and then go to the exam. Without revising pulmonary function test, don't go to the exam. Okay. Right. So a chronic cigarette smoker has now joined the construction company. His pulmonary function test results are given below. What is the most likely diagnosis for this patient? Should we do Doppler of the lower limbs before thrombolysis in massive pulmonary embolism? Yeah, see, Meet Patel, Doppler of the lower limbs, it is mainly for to rule out DVT, deep vein thrombosis. But deep vein thrombosis is not just the only etiology which will be causing pulmonary embolism. There are multiple etiologies which are causing pulmonary embolism, right? And yes, if it is deep vein thrombosis causing pulmonary embolism, yes, you can do lower limb Doppler, right? Lower limb Doppler, what is that? You will see, you will have a cutoff sign, okay? Right. Right. So in this patient, if EV1 is 0.9, FVC is 1.9. FEV1 by FVC is right 0.4. After bronchodilation, FEV1 is 1.9 and the FVC is 3.9 and FEV1 by FVC is 0.4. What is it suggestive of? What is it suggestive of? Okay, so right. So this particular question, it is suggestive of reversibility testing on the pulmonary function test, right? So there are two obstructive lung diseases where you need to check for the reversibility, COPD and the other one is bronchial asthma. In COPD, there is no reversibility, right? And in bronchial asthma, there is presence of reversibility after giving bronchodilator therapy. And what is the parameter that you need to check for the reversibility? That is FEV1. After giving bronchodilation, if the increase in FEV1 is less than 12%, then this will be COPD. It is irreversible. And if the increase in FEV1 is more than 12%, that is, it is completely reversible. That is very much suggestive of the bronchial asthma. Okay. Now, if you take the question here, the FEV1 before bronchodilation is 0.9. And after bronchodilation, it is 1.9. So it is like increased more than 12%. It is increased more than 12%. So first of all, how will you decide that it is an obstructive lung disease? Because normal value of your FEV1 by FVC is 0.7. Normal value of your FEV1 by FVC is 0.7. But here the value is 0.4. That means less than 0.7, which is suggestive of obstructive lung disease. And in restrictive lung disease, the value will be more than 0.7, right? More than or equal to 0.7 in case of restrictive lung disease. So first you should be able to decide that it is an obstructive lung disease because your FEV1 by FVC is less than 0.7. Then bronchodilator reversibility is there because your 0.9 liters have become 1.9 liters. That means it is increased by more than 12%. So it is suggestive of the bronchial asthma. I hope this question is clear for here. Right. So coming on to the next question. Can this scenario be an overlap of the RLD and as well as the obstructive lung disease? I don't think so. It is purely obstructive lung disease. Why? Because FEV1 by FVC is reduced to less than 0.7, very much suggestive of the obstructive lung disease, right? Okay, coming on to the next question. Which location in the abdomen is most frequently affected by the tuberculosis? Very simple and easy question. It is not a difficult one at all. It is ileocecal junction. Why ileocecal junction is the most common site for the abdominal tuberculosis? Because the Peyer's patches, which is nothing but the rich lymphatic supply, it is there at the iliac junction or the ileocecal junction. So that is the reason why the abdominal tuberculosis is like more common in the ileocecal junction. Okay? Right. Next question. So this is another question, mixture of the ABG and as well as the pulmonary function test. So a 65-year-old female patient weighing around 60 kg is on mechanical ventilator for ARDS secondary to urosepsis. The respiratory parameters are as follows. Tidal volume is 360. The respiratory rate is 30 breaths per minute. PEEP is 5 centimeters of water. FiO2 is 90%. The arterial blood gas findings are as follows. PaO2 50, carbon dioxide 38, pH 7.38. What is the next step? What is that you need to do in this patient? Reduce FiO2, increase tidal volume, increase respiratory rate, increase PEEP. Kya karna hai? Right. So the correct answer is, why you want to increase the respiratory rate? The carbon dioxide is normal, right? Carbon dioxide is 38. That is 36 to 44 is the normal levels of your carbon dioxide. You will increase the respiratory rate whenever there is hypercapnia. Here the patient's carbon dioxide is normal. So there is no point in increasing the respiratory rate. And always remember, in case of the patients with ARDS, they should be having low tidal volume. They should be having low tidal volume. And how much should be the tidal volume? That is 6 ml per kg. How much is the weight of our patient? 60 kg. 6 multiplied by 60, that is 360. So tidal volume, whichever is there, is correct. And if you increase the tidal volume, these patients will develop barotrauma. Even if you increase the FiO2, or sorry, if you reduce there is no point in reducing the FiO2 because the FiO2 is like 90%. At the rate of 90%, he is maintaining the partial pressure of oxygen 50. And if you reduce the FiO2, like the partial pressure of the oxygen will further drop down. So don't reduce the FiO2 here. So that is also incorrect. So the point is, what is the very important point in ARDS? There should be high PEEP. And how much should be that high PEEP? It should not exceed 10 again. So the PEEP should be around 10 centimeters of water. How much is the PEEP here? The PEEP given here is only 5. It is very less PEEP for an ARDS patient. ARDS patients, they should have a high PEEP. And what is the purpose of keeping high PEEP? That is to open the alveoli. Right? That is to open the alveoli. Okay? Because the alveoli are like collapsed and fibrous here in patients with ARDS. Right? So the answer is increase the PEEP. Next question. Yeah, this is also the question on the pulmonary function test. Yeah, yes, Ayush. Increased PEEP also will cause barotrauma. But how much is the maximum PEEP that you can keep is 10. If you try to increase beyond 10, definitely it will cause barotrauma. Right? Okay. Right. The given image shown is the normal graph and as well as the patient's graph as well. Which of the following diagram can be inferred from the graph? Chest wall neuromuscular disease, sarcoidosis, the idiopathic pulmonary fibrosis, and then bronchiectasis. Right. So whoever has answered. Okay. So you take the first 3 disorders, chest wall neuromuscular disorders, sarcoidosis, and then idiopathic pulmonary fibrosis. All these are what? All these are restrictive lung diseases. All these are restrictive lung diseases. Okay. In restrictive lung diseases, your FEV1 by FVC will be more than or equal to 70%. Will be more than or equal to 70%. Whereas bronchiectasis, it's an obstructive lung disease. So here, the FEV1 by FVC will be less than 70%. Now, if you see this image here, normal FEV1 by FVC, which is given for the patient, is 83%. So here, if you observe the FEV1 by FVC, which is given for the patient, it's 50%. It's reduced. So where is that you will have FEV1 by FVC, which is being reduced? That is in case of bronchiectasis. That is in case of bronchiectasis. Okay. So the answer is D. And you cannot go with FEV1 and FVC alone, because FEV1 can be reduced in restrictive lung disease. FVC, even that also can be reduced in restrictive lung disease. But you need to take the ratio to differentiate between the obstructive lung disease and as well as the restrictive lung disease. Okay. So the correct answer here is what? That is the bronchiectasis. Right? Next question. Okay. So the next question is, like, we have a 40-year-old man presents with daytime sleepiness and impaired concentration. Right, daytime sleepiness and impaired concentration and as well as memory. On examination, his BMI is 41, blood pressure is 160 by 100. His awake ABG is given, right, where partial pressure of oxygen is 66, partial pressure of carbon dioxide is 50, bicarbonate is 28. What is the most likely diagnosis in this particular patient? Obstructive sleep apnea, narcolepsy, obesity, hypoventilation syndrome, central sleep apnea. Yes. Right, very good. So it is, yeah, very good, Subhajit Jha. So it is nothing but your obesity hypoventilation syndrome, which is nothing but Pickwickian syndrome, right? Now, how is that you will be able to differentiate it from the obstructive sleep apnea? So the points which are in favor of the obesity hypoventilation syndrome is the increased BMI. So if you take the BMI of the patient, it is like 41 kg per meter square, which is very much increased, right? And in case of obesity hypoventilation syndrome, you take the awake carbon dioxide, right? When the individual is awake, you can find that the PCO2 is being elevated. The PCO2 is being elevated. That is in awake patient. Okay. And if you take the ABG also, it is very much suggestive of the acidotic component is there, and compensatory metabolic alkalotic component is there. Fine. And the next important, how will you differentiate it from the obstructive sleep apnea is, in obstructive sleep apnea, very, very important point is the BMI may be normal, may be increased. But the point which is going against your obstructive sleep apnea is that in obstructive sleep apnea, when the individual is awake, right, the individual is awake, the carbon dioxide levels will be normal, right? And the even oxygen levels also will be normal. Okay. So these 2 points, they are going against your obstructive sleep apnea. See, obstructive sleep apnea, they will develop hypoxia, they will develop hypercapnia when the patient is sleeping. When the patient is asleep, then you'll have hypoxia and hypercapnia. So that is the reason why the answer is not the obstructive sleep apnea. Then what is your narcolepsy? Narcolepsy is excessive daytime sleepiness, right? There is excessive daytime sleepiness. And in these patients, there will be cataplexy. Now, what do you understand by this word cataplexy? Cataplexy means sudden loss of muscle tone. Sudden loss of muscle tone is what is called cataplexy. And there will be disrupted sleep patterns. So, like excessive daytime sleepiness, cataplexy, and disturbed sleep patterns. That is what you will observe in case of the narcolepsy. And in patients with narcolepsy, the ABG will be normal. The ABG will be normal in patients with narcolepsy. Okay. So this is not narcolepsy. Now, coming to central sleep apnea. Central sleep apnea is a condition in which there is lack of respiratory effort during the sleep. There is no respiratory effort during the sleep. Okay, there will be pause in the breathing. There will be a pause in the breathing. That is what is your central sleep apnea, right? So the answer here is your obstructive sleep apnea. Sorry, the answer here is obesity hypoventilation syndrome, right? Obesity hypoventilation syndrome. Yeah, Ashutosh, what is your chain strokes respiration? So chain strokes respiration is that there is increase in respiratory rate, followed by that there will be apnea for certain period of time. Again, there will be increase in respiratory rate. There will be hyperventilation. Okay, so hyperventilation followed by apnea. That is what is called chain strokes respiration. Where do you have this chain strokes respiration? Is mainly in patients with congestive heart failure. You'll have chain strokes respiration in patients with cerebral stroke, right? Brain stroke, bilateral cerebral damage. You'll have chain strokes respiration. Okay, so the answer here is obesity hypoventilation syndrome. Coming to the next question. Yeah, so with this, we are done with the pulmonology questions. With this, we are done with the pulmonology questions. Okay, so almost 2 hours, 45 minutes, we have done the session. We will just take a small break. We will just take a small break here, and then we will continue the session after 10 more minutes. 10 o'clock, we will continue the session. At 10 o'clock, we'll continue the session. Okay. All right. So the next topic for the discussion will be the rheumatology. Right. So the first question in the rheumatology will be, which of the following condition leads to the development of the wing beating tremors? Wilson's disease, Huntington's chorea, Parkinsonism, Sydenham's chorea. Yes. Anyone to answer? Leads to the development of the wing beating tremors. No one is answering. Right. What exactly? Yeah, very good. So some of you have started answering. So what exactly is wing beating tremors? Wing beating tremors is nothing but the asterexis. Okay. Now, where is that you will have the asterexis is? The asterexis is usually observed whenever there is hepatic encephalopathy or uremic encephalopathy or carbon dioxide narcosis. And you will have that in case of Wilson's disease. So Wilson's disease, that is due to the copper accumulation within the liver. And because of the copper accumulation within the liver, these patients will develop what is called macronodular cirrhosis. And this particular cirrhosis, right, macronodular cirrhosis will progress to the development of the hepatic encephalopathy. And in case of this hepatic encephalopathy, you have the presence of the wing beating tremors. Okay. And what exactly is this particular Wilson's? It is one of the genetic disorder which is characterized by impaired copper metabolism. Impaired copper metabolism. And in these patients, it is not only the involvement of the liver, right? The other organs which get affected in case of Wilson's will be, you have the involvement of brain, and you also have the involvement of the Descemet's membrane of the cornea, where you have the presence of the KF ring, where you have the presence of the KF ring. Okay. Now, coming to, yeah, coming to the Huntington's chorea. What exactly is this Huntington's chorea? Huntington's chorea is that where you have quick jerky movements. They are involuntary movements and they are quick jerky movements. And it is also an inherited disorder, right? And this is due to mutation of a particular gene called the Hunt gene. Present where on which chromosome this particular Hunt gene is being present? Sorry, sorry, sorry. Right. So it is the abnormality is on chromosome number 4. The abnormality is on the chromosome number 4. Okay. Right. Okay. And that is what is your the Huntington's chorea, right? Next. And next is the Parkinsonism. What is the involuntary movements that you will have in case of the Parkinsonism? That is, resting tremors is what you will have. Resting tremors is what you will have in case of Parkinsonism. That will be the involuntary movements in Parkinsonism. And Sydenham's chorea, you will have that in case of rheumatic fever. And here also you have the chorea. Here also you have the presence of the chorea. Okay. So this is about the wing beating tremors which are observed in case of Wilson's disease, right? And in case of Wilson's, can anyone tell me what is the first line treatment? Anyone? What is the first line treatment in case of Wilson's? Quickly. First line treatment in Wilson's. Any one of you, please? The first line treatment in case of the Wilson's. No. D-penicillamine is not the first line treatment. No. D-penicillamine is not the first line treatment. Yes? I'm waiting for your answer. The first line treatment will be zinc, right? And then trientine. And then trientine. It is only when these two formulations fail, that is zinc formulations and trientine formulations fail, then we give this D-penicillamine. Then we give D-penicillamine. All right. So coming on to the next question. A patient with rheumatoid arthritis has been treated with methotrexate and low-dose corticosteroids for the past 4 months, right? However, the disease is still progressing. What would be your recommendation for further management of this particular patient? Stop oral methotrexate and start parenteral methotrexate. Add sulfasalazine and hydroxychloroquine. Continue corticosteroids and methotrexate. Start only anti-TNF alpha agents. Yeah. What is that you want to do? Shubhajit, directly you want to start anti-TNF alpha? No. So it is not directly we need to start the TNF alpha. Right. So the correct answer is you need to give a triple therapy first. Okay. If the patient is not responding only to the methotrexate, then what is that you need to add is you need to add the hydroxychloroquine, right? And you also need to add the sulfasalazine. Right, you also need to add sulfasalazine. So this will be the triple therapy. Right, so this will be the triple therapy. It is only when this particular triple therapy fails, then we need to add the anti-TNF alpha agents. Okay, and what are the examples of the anti-TNF alpha agents? That includes the adalimumab, etanercept, and as well as the infliximab. Okay, so we need to add the sulfasalazine and as well as the hydroxychloroquine. And what exactly is the drug of choice in these patients? The drug of choice will be methotrexate. And you need to know, so methotrexate, your hydroxychloroquine and sulfasalazine are non-biological DMARDs, or they are called conventional DMARDs. But you need to know what are the biological DMARDs. That is a very important area for the questions. So I'll just give you the list of the biological DMARDs. Okay, so right. So this is the list of the biological DMARDs. This is a list of biological DMARDs. Okay. So we have the TNF alpha inhibitors, example, adalimumab, etanercept, and infliximab. Then we have interleukin 6 inhibitors, that is tocilizumab. Then B cell modulators, that is rituximab. Then we have T cell co-stimulant blockers, which is nothing but the abatacept. Then we have Janus kinase inhibitors, that includes baricitinib and as well as tofacitinib. So these are the biological DMARDs, out of which are your targeted synthetic DMARDs. They are mainly Janus kinase inhibitors, that is baricitinib, then the tofacitinib. These are the targeted synthetic DMARDs. Okay, so this was the question on the treatment of the rheumatoid arthritis. So the drug of choice for rheumatoid arthritis is definitely methotrexate. Can anyone tell me what is the important adverse effect associated with methotrexate? What is the important adverse effect which is associated with the methotrexate? Anyone? The important adverse effect which is associated with methotrexate is this will cause bone marrow suppression. This will cause bone marrow suppression, and this bone marrow suppression can lead to the development of pancytopenia. And the other important feature is, yes, very good, Shubhadija, that it will also cause the pulmonary fibrosis. And it is also the one which will be responsible for the hepatic fibrosis as well. Hepatic fibrosis as well. Okay. These are the adverse effects with methotrexate. All right. And what is the investigation of choice for rheumatoid arthritis? The investigation of choice for rheumatoid arthritis will be the antibody, and that is anti-CCP, that is anti-cyclic citrulinated polypeptide, right? It is not RA factor, because RA factor, it is positive in multiple other conditions. So RA factor is not the investigation of choice. It is anti-CCP, which is the investigation of choice. Okay. Now, the next question is, what is the most probable diagnosis for a female patient who exhibits symptoms of fever, oral ulcer, photosensitivity, and facial rashes as depicted in the image provided? Dermatomyositis, SLE, rosacea, melasma. Right. So this is a straight question. That is, over the malar rashes, you are having the erythematous patch, and that is very much suggestive of the systemic lupus erythematosus. Okay. And systemic lupus erythematosus, it's an autoimmune disorder, and multiple organs and systems are affected. Right. You have the involvement of the skin. You have the involvement of the joints, kidney, heart, lung. So everything is being affected. Multiple organs are being affected. And the characteristic rash, this we call it as the butterfly rash or the malar rash, which is the hallmark of the patients with the systemic lupus erythematosus. Whereas you take dermatomyositis. Dermatomyositis is also an autoimmune condition where you have the involvement of the skin and as well as muscles. And which muscles are affected mainly? It is the proximal muscles which are commonly affected in patients with the dermatomyositis. Okay. Then next you take the rosacea. And in dermatomyositis, you don't have that particular malar rash, whichever is given here. That malar rash or butterfly rash is not the feature of your dermatomyositis. Okay. Next, coming to the rosacea. Now, what exactly is the rosacea? This is also a common skin condition. It primarily affects the face. It primarily affects the face, where there will be redness of the face, flushing of the face, and sometimes you will also notice the appearance of the pimples over the face. And for the development of rosacea, there should be a triggering factor. What is the trigger for the development of rosacea? Exposure to the sunlight, okay, and exposure to certain foods, and exposure to the alcohol. Okay, so these are like the triggers for the development of the rosacea, but you don't have butterfly rash, right? That you don't have butterfly rash in case of rosacea. So that is why it is gone. Then next is the melasma. Now, what exactly is melasma? Melasma is also a skin condition, but where in case of melasma, you will have a dark patch on the face, right? Particularly, where is that you will observe over the face? That is over the cheek, over the forehead, over the nose, or the upper lip. That is a place where you have this dark pigmentation in case of the melasma. And this melasma, it is associated with the hormonal changes, okay, like pregnancy or like hormonal contraception, right? There you will have, during that scenario, you have this particular melasma. And this malar rash, it is not the feature of your melasma, okay? And if you take the skin manifestations in patients with the SLE, the skin manifestations in SLE will be butterfly rash, discoid rash, and then photosensitivity. Okay, this table is very, very important. I'll show you a table of the skin manifestations in the SLE, cutaneous manifestations, right? That is butterfly rash, discoid rash, and photosensitivity. And you take this photosensitivity. For the development of the photosensitivity, the antibody is the anti-Rho antibody. And how do you treat this photosensitivity? The treatment of this photosensitivity is you need to give the HCQS. Hydroxychloroquine is the treatment that you need to give for photosensitivity. And there is also development of the oral ulcer. There is also subcutaneous lupus erythematosus, Raynaud's phenomena, alopecia, and then vasculitis. So these are all the cutaneous manifestations. Okay. Yeah, Ayush, I'll come to the diagnostic criteria. Don't worry. Just give me 2 minutes. I have one more question on the SLE. I'll come to that particular diagnostic criteria. Right. Yeah. Champang Paji. So dermatomyositis and as well as polymyositis, the difference is that in case of dermatomyositis, you have the skin involvement and as well as the involvement of the proximal muscles. Whereas in case of the polymyositis, there is no skin manifestations, right? You have only proximal muscle weakness in case of polymyositis. That is the important difference. So skin manifestations are not observed in case of the polymyositis. All right. Now, coming on to the next question. What is the most common extra-articular manifestation of the rheumatoid arthritis? Most common extra-articular manifestation of rheumatoid arthritis. Okay, subcutaneous nodule, Sjogren's syndrome, Felty's syndrome, then vasculitis. Right, very good, Krishna Vamshi. So that is the subcutaneous nodules, and these subcutaneous nodules, they are present over the extensor aspect of the forearm, and these are non-tender. These are non-tender. They are not painful. Okay, they are the most common extra-articular manifestation in rheumatoid arthritis. And Sjogren's syndrome, it is associated with the rheumatoid arthritis. Okay, what is Felty's syndrome? Felty's syndrome, it is characterized by a triad where you have the presence of rheumatoid arthritis. There will be also neutropenia, and there will be also splenomegaly. There will be also splenomegaly. Vasculitis can also be observed, but among all these, the most common manifestation is subcutaneous nodules, right? And what will be the lung involvement? Lung involvement in case of the rheumatoid arthritis will be the pleural effusion. Some of you are asking me to talk about the pleural effusion just now, right? So if you take the pleural effusion, what type of pleural effusion you will have in the case of rheumatoid arthritis? It is exudative type of pleural effusion is what you will have in patients with the rheumatoid arthritis. So we have two types of pleural effusion, transudative and as well as exudative. What is a very important difference is the protein content. In case of transudative, the protein content will be less than 3 grams per deciliter, whereas in exudative, it is more than 3 grams per deciliter. And then next important difference is the pleural fluid protein to the serum protein ratio. the pleural fluid protein to serum protein ratio will be less than 0.5, whereas it is more than 0.5 in case of the exudative. And another important difference is the pleural fluid LDH to the serum LDH. The pleural fluid LDH to the serum LDH value is less than 0.6 in case of transudative, and it is more than 0.6 in case of the exudative. Okay. And these three together, in case of exudative, they are given by a name of a criteria called the Light's criteria. And in the Light's criteria, if it is positive, that is suggestive of exudative type of pleural effusion. And how many should be there? 1 out of 3, right? Out of these 3, at least 1 should be there, right? At least 1 should be there to consider it as the Light's criteria to be positive. Okay. So that is about your pulmonary manifestation in rheumatoid arthritis. And in rheumatoid arthritis, the other pulmonary manifestation is you also have the presence of the nodules. Necrobiotic nodules can be there in patients with the rheumatoid arthritis. So we have a syndrome called Kaplan syndrome. What is this Kaplan syndrome? Rheumatoid arthritis plus Kohlwerker's pneumoconiosis. And in Kohlwerker's pneumoconiosis, you have the presence of multiple necrobiotic nodules, right? And yeah, so this will be your lung manifestations in case of rheumatoid arthritis, right? Now, can anyone tell me, and one more important lung manifestation in rheumatoid arthritis will be the interstitial lung disease. Interstitial lung disease, okay? And yes, Ayush, the subcutaneous nodules, they are present over the extensor aspect of the forearm, right? Now, can anyone tell me what is the lung manifestation in case of SLE? What is the lung manifestation in patients with SLE? The lung manifestation in patients with SLE is that they will develop pleuritis, right? They will develop pleuritis. And ILD will be there, interstitial lung disease, but that is less common. But these patients, they will develop what is called a shrinking lung syndrome. Now, can anyone tell me what is the cause of this shrinking lung syndrome? Anyone? What is the cause of shrinking lung syndrome in patients with SLE? What is the cause of shrinking lung syndrome in patients with SLE? Quickly. The cause of shrinking lung syndrome in patients with SLE, it is mainly because of diaphragmatic myopathy. The antibodies are formed against the diaphragm and the diaphragm will get paralyzed. Once the diaphragm is paralyzed, the dome of the diaphragm increases and that will push the lung. Thereby, the lung will become shrunk or the lung will become small. And that is what is called shrinking lung syndrome, right? That is a lung manifestation in SLE. Whereas in rheumatoid arthritis, lung manifestation will be exudative type of pleural effusion, necrobiotic nodules, and as well as the interstitial lung disease. Okay, right. Now, coming on to the next question. Patient presents with the cutaneous vasculitis, glomerulonephritis, and peripheral neuropathy. Which investigation should be performed next to help in the diagnosis? ANCA, RA factor, surface antigen, MIF. Yeah, very good. So the answer is the ANCA. So which ANCA you will do it here? Which ANCA you will do? Is it P ANCA or is it C ANCA in the clinical scenario? In this clinical scenario, is it P ANCA or is it C ANCA? Very good, Krishna Vamshi. So it is the P ANCA because whatever the clinical manifestations which has been given, that is your cutaneous vasculitis, glomerulonephritis, and peripheral neuropathy, they are very much suggestive of your microscopic polyangiitis. Microscopic polyangiitis. So where you need to do P ANCA. Okay. Whereas you take C ANCA. Where is that you do this particular C ANCA? C ANCA, you do that in case of the Wegener's granulomatosis. And in case of Wegener's granulomatosis, what is the triad in Wegener's? The triad in Wegener's is upper respiratory tract involvement, lower respiratory tract involvement, and as well as the glomerulonephritis. That is what you have in case of Wegener's. Okay. Now, RA factor very common in patients with the rheumatoid arthritis. There are multiple other conditions where the RA factor can be positive, but very common condition is the rheumatoid arthritis. And in rheumatoid arthritis, what is the important clinical manifestation? Multiple small joint involvement. That is a clinical manifestation in case of rheumatoid arthritis. And surface antigen HBsAg being positive. Right, you will have this positive in case of the hepatitis B viral infection. Right, in hepatitis B viral infection, you'll have various clinical manifestation, but the cutaneous vasculitis, glomerulonephritis, and peripheral neuropathy, they are not commonly associated with hepatitis B infection. So your HBsAg is gone. Now, what do you understand by this word MIF? MIF stands for migratory inhibitory factor. Migratory inhibitory factor. What is this migratory inhibitory factor? Basically, it's a pro-inflammatory cytokine. It's a pro-inflammatory cytokine that has been implicated in various inflammatory conditions. Okay, it is not specific to any particular disease. right, various inflammatory conditions, this MIF will be released. That is migratory inhibitory factor. Okay. So testing for MIF alone would not provide sufficient diagnostic information that will identify the underlying disease. So MIF is not the correct answer. So the correct answer here is the ANCA. Right? Yeah, Kamlesh, the P-ANCA, right? What are the conditions where you will have this particular P-ANCA? The P-ANCA, it is positive in case of microscopic polyangiitis. Microscopic polyangiitis, MPA. Microscopic polyangiitis, you will have P-ANCA, and granulomatosis with polyangiitis, which is nothing but vaginous granulomatosis. There you will have C-ANCA being positive. Okay. Yes, Kamlesh, is that clear for you? Right. So that was about the question related to ANCA. Right. You see the next question. A triad of the skin lesion, asymmetric mononeuritis multiplex, and eosinophilia. This is very, very important. Seen in which of the following condition? Cryoglobulic vasculitis, polyarteritis nodosa, Churg-Strauss syndrome, then the giant cell arteritis. Right? So if any form of vasculitis, if eosinophilia is given, no doubt you need to go with the Churg-Strauss syndrome, right? So what is another name for Churg-Strauss syndrome? The another name for Churg-Strauss syndrome is, it is also called EGPA. What is EGPA? Eosinophilic granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis. That is called EGPA. Even in case of EGPA, you have the P-ANCA being positive. Okay, so P-ANCA, no. Right, P-ANCA, it is positive in case of microscopic polyangiitis and as well as in case of the Churg-Strauss syndrome, right? And in case of Churg-Strauss syndrome, what is the characteristic manifestation? You will have the skin lesions, right? Asymmetric mononeuritis multiplex and eosinophilia. This is a triad that you will have in case of Churg-Strauss syndrome. This is a triad commonly seen in case of the Churg-Strauss syndrome. Right? Now coming to your cryoglobulinic vasculitis. What exactly is the cryoglobulinic vasculitis? It is the abnormal proteins. What are the name of these abnormal proteins? The name of these particular abnormal proteins will be cryoglobulins. Right? They are called cryoglobulins. They are found in the blood. Right? These are the proteins which are formed during cold. That is why it is called cryoglobulins. Okay. Now what will be the clinical manifestations in case of cryoglobulinic vasculitis? These patients, they will have the purpura. They'll have purpura. And these patients, they will have the development of the joint pain. Right? These patients, they will have the systemic involvement. Right? Systemic involvement. That is what you'll observe in case of the cryoglobulinic vasculitis. Whereas you take polyarteritis nodosa. Polyarteritis nodosa, it's a medium vessel vasculitis. What will be the features that you will have in case of polyarteritis nodosa? These patients, they will have abdominal pain, right? They will have fever, right? And they will have the development of the weight loss, right? They will have the muscle or joint pain, right? They'll have muscle or the joint pain, okay? Right? And this is the feature in case of polyarteritis nodosa. Will there be peripheral neuropathy in case of polyarteritis nodosa? Yes, peripheral neuropathy can be there, but that is not the mandatory manifestation in case of polyarteritis nodosa. Then you take giant cell arteritis. Giant cell arteritis, it's a large vessel vasculitis, right? And this large vessel vasculitis, it is very commonly seen in individuals of age group more than 50 years. And in case of giant cell arteritis, the another name for this is temporal arteritis. Which vessel is commonly affected? It is a temporal artery which is commonly affected where there is tenderness over the temporal artery. That is what is the clinical manifestation, giant cell arteritis. And these patients with giant cell arteritis, they will also have sudden onset blindness. And that is because of the involvement of the ophthalmic artery. So the clinical manifestation, whatever has been given to you, it is very much suggestive of your Churg-Strauss syndrome. Right? So the answer is C. Next. Coming on to the next question. Which condition necessitates the use of anti-nuclear antibodies for accurate diagnosis? Jetka, stopping the ad is not in my hand, right? So it is not in my hand. Stopping the ad and all is not in my hand. Yeah. So the answer is the anti-nuclear antibody. It is very much required in the diagnosis of the SLE. But this anti-nuclear antibody, is it most sensitive or most specific in case of SLE? Please remember, it is the most sensitive antibody. It is the most sensitive antibody, right? And what is most specific antibody in case of the SLE? The most specific will be your anti-Smith, right? And what is the antibody which will tell you about the severity of the disease? That is anti-dsDNA. So anti-dsDNA, it is the one which will tell you about the severity of the disease, right? And what are the antibodies in case of drug-induced lupus? In drug-induced lupus, it is the anti-histone antibody, right? It is anti-histone antibody. That is what you will observe in case of the drug-induced lupus, right? And next important antibody is the anti-Rho. Anti-Rho in case of the SLE is very much suggestive of the photosensitivity, right? It is very much suggestive of the photosensitivity, right? And then you take the APLA syndrome, that is the antiphospholipid antibody syndrome. It is very commonly associated with the SLE, where there will be recurrent abortion, okay? Right. Next, coming to the scleroderma. In scleroderma, what is the antibody? In scleroderma, the antibody is anti-SCL70. Anti-SCL70, right? And in case of drug-induced lupus, as just now I have said, it is the anti-histone antibody. What is the antibody in case of Sjogren's? In Sjogren's, it is anti-Rho and as well as the anti-La. Anti-Rho and as well as anti-La. Okay. So the answer in this question is the SLE, right? Now, some of you were asking me about the diagnostic criteria in the SLE. I'll quickly show you the diagnostic criteria for the SLE. Okay, so in the diagnostic criteria, first and foremost, you should have at least 4 of the following criteria with at least 1 clinical and 1 immunological criteria. What is the clinical criteria? Malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, renal involvement, that is proteinuria, neurological involvement, seizures and psychosis, hematological disorders in the form of pancytopenia. What is the immunological criteria? That is ANA antibody being positive, or anti-Smith being positive, or anti-dsDNA being positive. Okay, so there should be at least 4 of the following criteria with at least 1 clinical and 1 immunological, right? Then what will be the laboratory test? Complete blood picture will show you the pancytopenia. ESR will be elevated. Urine analysis will show you that there is presence of the proteinuria. The antibodies, they are being elevated, that is ANA, anti-dsDNA and anti-Smith, right? And complement levels may be decreased. Complement levels may be decreased. And you need to do the additional test, that is antiphospholipid antibody, that is lupus anticoagulant, anti-cardiolipin antibody, and anti-beta-2 glycoprotein antibody. Okay. Renal biopsy is required, that is mainly to look for the presence of the wire loop lesions. So this is the criteria, right? Any mnemonic? I think everyone is aware of this particular mnemonic, right? One second, ad is coming. Okay. The mnemonic is soap brain MD. Okay, soap brain MD. So you wash your brain with soap, then you will get an MD seat. In that you have that serositis, oral ulcers, arthritis, photosensitivity, right? So all that will come under in this particular mnemonic. That is soap brain MD, right? Next, we'll move on to the next question. Okay, a 54-year-old woman presents to you with complaints of the swollen fingers, heartburn, and occasional joint pains. On examination, the skin over her hands is shiny, taut and thick with non-pitting edema. There are associated interstitial lung disease and ANA antibody being positive. Topoisomerase 1 antibody and anti-RNA polymerase 3 antibody. What is the most likely diagnosis? Limited cutaneous systemic sclerosis, diffuse sclerosis, Raynaud's Peutz-Jeghers syndrome. What is this? Right, very good. So it is very much suggestive of the diffuse scleroderma. It is very much suggestive of diffuse scleroderma. Now, why is that you are considering it as diffuse scleroderma? Why not cutaneous? See, in case of limited scleroderma, the antibody is anti-centromere antibody, right? Anti-centromere antibody. Whereas in case of diffuse scleroderma, the antibody is anti-topoisomerase antibody. What is given in our question is the anti-topoisomerase antibody and all the other clinical features. Swollen fingers, heartburn, occasional joint pain, skin over the hands is shiny. All these are the features suggestive of scleroderma, right? Now, You take Raynaud's phenomena. Raynaud's phenomena is observed in both the forms of scleroderma, that is in cutaneous and as well as diffuse scleroderma. You have the presence of this particular Raynaud's phenomena. What is this basically? It is the change in color when the fingers are being exposed to the cold temperature. So initially, like the color of the fingers will be pale. Then later they turn into blue and later they turn into red. Okay, so yeah, your pale is nothing but white, blue, and as well as red. That is what is your Raynaud's phenomena. Okay, so that will be present in both, that is diffuse and as well as even in case of the limited, but it is more common in diffuse rather than the limited scleroderma. Then what exactly is your Peutz-Jeghers syndrome? Peutz-Jeghers syndrome is an inherited condition, right? What exactly are present in these patients? There will be presence of the hamartomatous polyps. Right, you have the presence of the hamartomatous polyps where in the G80. Okay, hamartomatous polyps are present within the G80, right? And not only that, the other organs which are affected in Peutz-Jeghers syndrome will be breast, testicles, and as well as the ovaries. These are the other organs which are affected in case of the Peutz-Jeghers syndrome. Okay, now, yeah, so these are the points which are, so the question is very much suggestive of your diffuse cutaneous systemic sclerosis, right? What will be the drug of choice or what is the treatment for scleroderma? It is steroids. Steroids are the drug of choice, right? Now, coming on to the next question. Right. So it's a simple and straight question. There is no difficulty in this question at all. A 45-year-old female patient presents to you complaining of dryness in the mouth and eyes. Serum testing reveals positive anti-Ro and anti-La antibody. The test is the test in the image below was positive with a score of less than 5 mm in 5 minutes without anesthesia. What is the likely diagnosis? Right. So what is the name of this particular test? That is Schimmer's test. Okay, so Schimmer's test is the one which will tell you about the lacrimal secretion. Can anyone tell me what is the test that is being done for assessment of salivary secretion? What is the test that is being done for assessment of salivary secretion in case of the Sjogren's? For assessment of the salivary secretions, we do what is called xylography. Right, we do what is called xylography, right? But what is the investigation of choice in case of the Sjogren's? Okay, apart from antibodies, antibodies are there, anti-Ro and anti-La antibodies, but anti-Ro antibodies can be there even in photosensitivity in case of SLE. The investigation of choice in these patients will be biopsy. The investigation of choice will be biopsy. Now, what is that you will observe in the biopsy? In the biopsy, you will have the infiltration of the inflammatory cells. What is that inflammatory cells? That is CD4 plus T lymphocytes. Right, CD4 plus T lymphocytes. That is what is being observed in the biopsy of these patients with the Sjogren's. Can anyone tell me what is the differential diagnosis for Sjogren's? Differential diagnosis for Sjogren's. Differential diagnosis for Sjogren's, we have a syndrome called as the Hereford syndrome. Can anyone tell me what is this Hereford syndrome? Okay, so Hereford syndrome, which is also called uveitis. Where is that you will observe this Hereford syndrome? You will have that in patients with sarcoidosis. Sarcoidosis. Okay, so in uveitis, you have the enlargement of the parotid, right? You have the enlargement of the parotid. And how will you diagnose your uveitis is you need to do biopsy, right? And what does the biopsy in case of the Hereford syndrome will show you? The biopsy in case of the Hereford syndrome will show you the presence of non-caseating granuloma, right? Non-caseating granuloma. Now, what is the treatment that you will be giving in case of Sjogren's? So you don't have any specific treatment. It is completely supportive treatment. For example, if you are having dry eyes, you need to give the artificial tears that will increase the lubrication within the eyes, right? Then you can give topical anti-inflammatory drugs like cyclosporin, and the oral secretions are not there. The individual is asked to take more and more water, right? 1 minute, ad has come up. So the individual is advised to take more and more water. 1 second. Yeah, so the individual is advised to take more and more water. Okay, and the next important point here you need to note is cevimeline. Cevimeline is another drug which can be used to increase the salivary secretion. And in patients with Sjogren's, you take in females, particularly with Sjogren's, they have the destruction of the Bartholin's glands, because of which they'll have dry vagina. So in case of dry vagina, what will be the clinical manifestation they come up with? They come up with dyspareunia, where there will be painful sexual intercourse. So what is that you need to give for the treatment of dyspareunia is you need to give lubricants. Okay. That was about your, and it is only when systemic manifestations are there in Sjogren syndrome. When systemic manifestations are there in Sjogren syndrome, that is the point when you need to give rituximab. You need to give rituximab. Okay, that was about your Sjogren's, right? Next question. I did not show you the question only, and how was that you were able to tell the answer for the next question? Okay, so coming on to the next question. We have a 29-year-old female presented to the dermatology outpatient unit complaining of recurrent oral and genital ulcer. The ulcer first appeared around 6 months back inside the lower lip, stayed for a week, and after that multiple ulcers developed inside the mouth and tongue. Genital ulcers stayed for a few days and extremely painful, resolved with crust. However, they were less frequent than compared to that of the oral ulcers. She also complains of frequent inflammation in her eyes, resulting in blurred vision, photophobia, and excessive lacrimation. She had seen various doctors, but her symptoms have increased with time. Her dermatologist had referred her to a rheumatologist who had offered her multiple tests, including the skin biopsy. She was started on immunosuppressive medication, and her condition has improved. Which of the following condition will be right? So this is very much suggestive of your BICETs. So the BICETs, the hallmark manifestation is what? The presence of recurrent oral ulcer. And this recurrent oral ulcers, they are very painful. And the presence of recurrent oral ulcers, they are pathognomic for your BICETs. Now, can anyone tell me what is the HLA for BICETs? Anyone? What is the HLA for BICETs? Fast, quick. What is the HLA for BICETs? Yeah, so it is HLA B5 or HLA B51. That is a HLA for the BICETs. Okay, and in which country the BICETs is very common? The BICETs, it is very common in Turkey. It is very common in Turkey. Okay, now coming to the rheumatoid arthritis. How will you rule out rheumatoid arthritis? In rheumatoid arthritis, you have joint manifestations more commonly than presence of the recurrent oral ulcers. Then you take psoriatic arthritis. In psoriatic arthritis, very important is you have the involvement of distal interphalangeal joint. And in case of psoriatic arthritis, can anyone tell me what is the HLA association for psoriatic arthritis? HLA association for psoriatic arthritis. Yes. HLA association in case of psoriatic arthritis will be HLA-B27, right? And the HLA association for rheumatoid arthritis will be HLA-B27. That will be HLA-B27. Sorry, I'm sorry. In case of the rheumatoid arthritis, it is HLA-DR4. It is HLA-DR4. Okay, right. And whereas in case of SLE, just now we have discussed multiple systems are being involved in case of SLE, right? And you don't have genital ulcers in patients with SLE. Okay, so in that way, the SLE is being ruled out, right? So the correct answer here is the BICETs, right? Then next to this particular BICETs, yeah, and in case of the BICETs, it says that a skin test was done. Can anyone tell me what is the name of the skin test that is being done for BICETs? Yeah, reiters, it is HLA-B27. Reiters are reactive arthritis. HLA-B27 is being done. Can anyone tell me what is the name of the skin test? Yeah, very good, Lavanya Rajan. So it is the Pathergy test. Okay, so the Pathergy test will be positive in case of the BICETs, right? That is what is your BICET syndrome, right? So that finished your BICETs then. So that was the questions on the rheumatology. Then we will go on to the questions related to the emergency medicine. It is not exactly emergency medicine. It is like a mixture of the questions are there. Okay. So please match the following medical conditions with their corresponding description. This was the question asked in the INI-CET last year. So Kaplan syndrome initially observed in coal workers, asbestosis present with crazy pavement pattern, mesothelioma, lower lobe involvement, sarcoidosis exhibit the presence of the pleural effusion. Yeah, right. So the correct answer here is Yeah, only Ashutosh. Ashutosh, you have answered it correctly. So A1, what is A1? That is the Kaplan syndrome. Yeah, Kaplan syndrome that is observed in coal workers. That is a true statement. Okay. Then you take B is 4. What is B is 4? That is your asbestosis patients, they exhibit the pleural effusion. They exhibit the pleural effusion. All right. And the next one is the C3. That is mesothelioma. It affects the lower lobes of the lung. Mesothelioma, it affects the lower lobes of the lung, right? And the next one is the sarcoidosis. In sarcoidosis, you have the presence of the crazy paving pattern. It is you have this crazy paving pattern, but this crazy paving pattern, it is not specific only for sarcoidosis. The crazy paving pattern, it is also observed in patients with pulmonary alveolar proteinosis. Even in pulmonary alveolar proteinosis, you have this crazy paving pattern. So what exactly is your crazy paving pattern? It is like mosaic pattern which is resembling the crazy paving. Okay. Right. So that is why the answer is A. That is first option. Yeah, crazy paving pattern also can be observed in case of COVID as well. Okay. So the answer is A. That is the first option. We'll move on to the next question. Which of the following is not a complication of the blood transfusion in a 25-year-old mother who developed acute postpartum hemorrhage, hypovolemic shock, and underwent major blood transfusion after delivering a baby boy? Hypocalcemia, hypokalemia, hypothermia, and then hyperkalemia. Right. So what is that you don't have after the major blood transfusion is you don't have the development of hypokalemia, right? Hypokalemia is not seen in blood transfusion. What is that which is observed in case of blood transfusion is hyperkalemia. Why do you get that particular hyperkalemia? Hyperkalemia occurs due to leakage of potassium from the red cells in the stored blood. Thereby, you'll have hyperkalemia but not hypokalemia. Now, hypocalcemia can be seen. Why hypocalcemia is observed? Hypocalcemia, it refers to low levels of the calcium in the blood that can potentially, that is mainly because of citrate-induced hypocalcemia. Citrate, why is that we are using citrate? It's an anticoagulant. Okay, so there is a temporary decrease in calcium levels due to anticoagulant, that is citrate. There will be formation of calcium citrate and that will result in hypocalcemia, but that is only temporary. Right? And hypothermia, will it be there? Yes, hypothermia, it will be definitely there. Okay, whenever you are giving the blood of lower temperatures, then the individuals can have the development of the hypothermia, right? So this can occur as a complication of the blood transfusion, but hypokalemia will not occur, right? Instead, what is that you'll observe? Hyperkalemia is being observed, right? And what are the other complications of the blood transfusion? Allergic reactions, febrile non-hemolytic transfusion reactions, acute hemolytic transfusion reactions, electrolyte imbalance like hyperkalemia and hypocalcemia. So these are the abnormalities that you will have in case of the blood transfusion, right? And very important is iron toxicity. Repeated blood transfusions, like in case of thalassemias, they that will cause iron overload as well, right? Next question. Yeah, even your trally and as well as TACO. Okay, so this particular trally is what that is transfusion related acute lung injury. TACO is what? Transfusion associated circulatory overload. That is what is called TACO. Okay, so please go through the complications of blood transfusion before going to the exam. Very, very important point. Okay, next. What is the lifelong treatment for individuals? Yeah. What is a lifelong treatment for individuals who have received a potent prosthetic mitral valve replacement? Very good, Subhajit. So you need to give the warfarin. Warfarin is what? It's an anticoagulant. Okay. So this warfarin will prevent thrombogenic events. It will prevent the clot. Okay. It prevents the clot proteins to get accumulated over the valve. Okay. So warfarin is the one which you need to give in case of the prosthetic valves. It is not the aspirin. Okay. Why? See, your aspirin is also a form of antiplatelet drug. Aspirin alone, right? Aspirin alone, it will act the inhibition of the platelets, but it cannot prevent the formation of the fibrin threads. Okay, so warfarin would be the best option rather than the aspirin. Okay, next question. So a farmer has come with symptoms of pinpoint pupil, excessive salivation, increased secretion from the body. The most probable diagnosis is opioid overdose, organophosphate poisoning, stroke, heat stroke. Yeah, it's a direct question, right? Tulasi, why did you answer A, Tulasi? Yes, Ashutosh, why A? Krishnavamshi, why A? Right? Okay, because you are having pinpoint pupil, you are answering it as an opioid overdose. But one point you need to understand here is, in opioid overdose, they will have a pinpoint pupil, but they will not have the features of increased salivation and body secretion. Okay, but because if you observe here, there is excessive salivation and increased secretion. You don't have that in case of the opioid overdose. Right? Yeah, okay, you thought it. Chalo, okay, fine. So the answer is the organophosphorus poisoning. Now you take in stroke. In stroke, you can have the pinpoint pupil, right? In stroke, you can have pinpoint pupil. But that increase in body secretion and salivary secretions, they are not the feature of this particular stroke. Okay, right. And in case of the heat stroke, what is that you will have in heat stroke? In heat stroke, you have extreme dehydration. Okay, you will have extreme dehydration. You don't have excessive salivation, you have extreme dehydration in case of the heat stroke, right? So the answer here is the organophosphorus poisoning, right? So in organophosphorus poisoning, you have muscarinic effect and as well as nicotinic effect, right? I hope you are aware of this particular mnemonic, that is sludge, or some of the books give the mnemonic as dumbbells. Dumbbells. What is this particular dumbbells? Diarrhea. D is diarrhea. U stands for urination, increased urination. M stands for myotic pupil. B stands for bradycardia. Another B stands for bronchoria. L stands for lacrimation, increased lacrimation, right? And next is the E is emesis, that is vomiting. S stands for salivation. S stands for salivation. All these are muscarinic effects. Okay. Even you have nicotinic effects also. The nicotinic effects of your organophosphorus poisoning is there will be fasciculations. Your fasciculations are nicotinic effects. Even muscle paralysis causing respiratory failure, that is also nicotinic effect. Okay. And how do you treat this organophosphorus poisoning? First and foremost, decontamination. Remove the contaminated clothing. Atropine, that should be given intravenously or intramuscularly. And the other drugs are pralidoxime. Okay. So this is about the treatment, right? What is the optimal temperature for the water bath recommended for a patient with frostbite? Recommended for frostbite: 42 degrees, 37 degrees, 32 degrees, 30 degrees. Okay. So we have a mixture of answers. The answer is 42 degrees. Okay, the correct answer is 42 degrees Celsius, right? So basically, what is that you are doing? You are trying to do rewarming. You are trying to do rewarming. And for rewarming, the recommended temperature for a water bath in the frostbite is around 40 to 42 degrees Celsius. Right, 40 to 42 degrees Celsius. Okay, this particular temperature helps to promote vasodilatation. Why is the reason like we are giving 40 to 42 degrees? This will promote vasodilatation, and that will improve the blood flow to the affected areas, and that will help in the rewarming process. That is the reason why you need to use a temperature of around 40 to 42 degrees. Okay, whereas 37, 32, 30, no, they will not cause the vasodilatation. Okay, so in the management of the frostbite, what are all required? So first and foremost, you need to move the patient to the warm environment, and you need to remove the wet clothing, and then gradual rewarming with a temperature of water of 40 to 42 degrees, right? And these patients, they will have pain because of the frostbite. They'll have severe pain, And what is that you can give as a part of the treatment for the pain? You need to give NSAIDs. Non-steroidal anti-inflammatory drugs can be given, right? And then you need to protect the unaffected areas. You need to protect the unaffected areas. Okay. So this is about the treatment for the frostbite. Next question. Except for the following. Read the first point. Except for the following, which of the options listed can be used to manage a person experiencing breathlessness at high altitude of 3000 meters? Intravenous digoxin, oxygen supplementation, immediate descent, acetazolamide. Very good, Arjun Kumar. Arjun Kumar has answered it. So basically, what is this? What is the diagnosis this suggests you of? This is HAPE. What is HAPE? High altitude pulmonary edema. That is what is called HAPE, right? And in high altitude pulmonary edema, it is characterized by fluid accumulation in the lungs, leading to breathlessness and as well as the respiratory distress. Okay. And in case of HAPE, oxygen supplementation is required, right? And immediate descent. You just move the individual from the high altitude area to the low altitude area, right? That is also very much required. Then acetazolamide, which is a carbonic anhydrase inhibitor. What is it required for? It helps in prevention and treating the altitude sickness. It helps in prevention and treatment of the altitude sickness. That is the reason why the acetazolamide is being used prophylactically. Before the ascent, right, we give this acetazolamide. But there is no role of intravenous digoxin in case of high altitude pulmonary edema, right? So this is about the high altitude pulmonary edema. Okay. And the other drug that we can give is calcium channel blockers. That is nifedipine. But this is not a first choice, but nifedipine can also be given, right? So that is about your high altitude pulmonary edema. Now, coming to the next question. During a scorching summer afternoon, a man who had been tolling in the field unexpectedly collapsed. Upon examination, there were no apparent physical indications of dehydration, although his radial pulse was detectable. Right, radial pulse was detectable, right? And 1 minute, ad is coming up. Radial pulse was detectable. The doctor determined that the man's serum electrolyte levels were within the normal range. One second, guys, 1 second. I'm having an ad, so that's why I stopped. Yeah. So the doctor determined that the man's serum electrolytes were within the normal range. Shockingly, the man's body temperature is 106 degrees Fahrenheit. Considering these circumstances, which of the following should be administered as an initial form of the immediate assistance? Inject epinephrine immediately, cover with hot damp sheets, cover with cool damp sheets, start CPR. Yeah, very good. So all of you have answered it correctly. So cover with cool damp sheets. What exactly is the diagnosis? Very good, blast. So the answer is this particular patient is suffering with the heat stroke. The patient is suffering with the heat stroke. Okay. So in this patient, there is no signs of dehydration. Okay. There is no signs of dehydration. Why? Because the radial pulse is present. But the only point is body temperature is quite high. So what is the next best treatment? Cover the body with cool damp sheets. Okay. And if you give epinephrine in this patient, that will be fatal for the patient, right? And not the hot damp sheets. It is a cool damp sheets. What is that you need to require? And CPR is not required. Why? Because the pulse is normal. When the pulse is normal, why is that you want to start with the CPR? So this is a case of the heat stroke. This is a case of heat stroke. The another name for the heat stroke, it is also called sunstroke. It is also called sunstroke. What will be the clinical features in patients with a heat stroke? The individual will be in a state of altered mental status. Disorientation will be there. Core body temperature will be elevated. And how will be the pupils? The pupils will be myotic pupils. The skin will be dry and hot. And anhydrosis will be there. Sweating will not be there in case of the heat stroke. Okay. What is the treatment? You remove the cloths first and bath with ice water or ice pack. Okay. And you need to give oral fluids and as well as IV fluids should be given. Okay. That is a treatment for the heat stroke, right? Moving to the next question. Okay. So what are the most appropriate tests to perform in a 62-year-old male patient with heart failure who is scheduled for the heart transplant? and experiences severe respiratory distress 4 hours after receiving 2 units of the whole blood transfusion and is found to be hypoxemic, tachycardic, and elevated mean arterial pressure. Considering that his renal function test is normal, his blood hemoglobin levels are 6 grams percentage. That what is the investigations that you want to do? Chest X-ray, BNP, absolute neutrophil count, leukocyte antibody, platelets. So what is that you want to do first? Right, very good. So you need to do chest X-ray and as well as the brain natriuretic peptide. So can anyone tell me what is the diagnosis of this clinical scenario? Yes, can anyone tell me what is the diagnosis of this clinical scenario? The answer is what now? The answer will be C. The answer will be C. What is the diagnosis? So this particular patient has developed high output heart failure. It is not only the question of, it is not Trally, it is actually TACO. Right? And not only that, this particular patient has developed high output heart failure because of this particular anemia. Because of anemia, this particular patient has developed this congestive cardiac failure. So in congestive cardiac failure, you will notice that the BNP levels are elevated, for which reason you need to do BNP, right? And in the chest X-ray, you will notice that there is pulmonary edema where you will have Kerley B lines and alveolar infiltrates and pleural effusion, for which reason you need to do chest X-ray, right? So the answer is 1 and as well as 2, that is chest X-ray and brain natriuretic peptide levels, right? So that was severe respiratory distress secondary to the blood transfusion. Secondary to the blood transfusion, right? Next question. A patient who is a tour guide of Mount Everest presents with blisters on her hand as shown in the figure below. These are the blisters. She has severe pain and on examination erythematous and tender. Which of the following is used in the management of this particular patient? Oxen, apply heat, pentoxifillin, NSAIDs. Yes, very good, Subhajit. So what exactly is this now? What is the diagnosis, Subhajit? So like you have the formation of the blisters. You have the formation of the blisters and that is secondary to a frostbite. That is secondary to the frostbite. Okay, what did I tell you? Just now we have discussed the frostbite. If there is pain secondary to frostbite, you need to give NSAIDs. You need to give NSAIDs. Okay, right? So like, do we give oxygen for the management of the blisters on the hand? No, the patient is concerned about the blisters. Okay, so oxygen is not typically used in the management of the blisters on the hand. Okay, right. Whereas apply heat to the area and cast it as soon as possible. Okay, so this option is not recommended for the management of the blisters. The problem is blisters there. Okay, when you apply the heat, that will increase the inflammation, that will increase the discomfort. So application of the heat over the blisters, that is not being recommended, right? Next is pentoxifillin. What is pentoxifillin? It's a medication that can improve the blood flow, right? And it is used in the treatment of vascular disorders. Used in the treatment of the vascular disorders, but not in the case of blisters secondary to your frostbite. So the answer here is the NSAIDs, non-steroidal anti-inflammatory drugs. Okay, next question. An elderly diabetic and hypertensive patient was carried to the emergency room in a comatose state. On examination, the blood pressure was 170 by 100 millimeters of mercury and pulse rate is more than 100 per minute. Plantar reflexes were bilaterally extensor. What is the next step to do? Check blood sugar levels, give antihypertensive, IV mannitol, and then CT brain. Right. So, okay. So now what is the clinical scenario of our patient is he is diabetic and is also hypertensive. Okay. So, and pulse rate is how much? More than 100 and the blood pressure is more than like 170 by 100 and bilateral extensor plantar reflex. B said, yeah, Give antihypertensive, IV mannitol, and then CT brain. Blast, what are you suspecting? Are you suspecting a hemorrhagic stroke? Are you suspecting a hemorrhagic stroke, all of you? You're suspecting silent MI, yeah? In MI, there should be a chest pain, right? Okay. Now, the answer here is, okay, the answer, what is that we need to do first? The question given is what is that we need to do first? So the answer is check the blood sugar levels. So in the given clinical scenario, the patient is elderly and patient is in comatose state with hypertension and tachycardia. Now, you just observe one point here. If it is due to raised intracranial pressure because of hypertensive stroke, okay, if there is raised intracranial pressure, what will happen to heart rate? Anyone? What will happen to heart rate? No. It's not hypertensive emergency. Yeah, please tell me. What will happen to heart rate if it is due to raised intracranial pressure? There will be bradycardia, right? There will be activation of the Cushing's reflex. There will be bradycardia. Okay. So, but our patient is having tachycardia. The heart rate is more than 100. So, don't think of raised intracranial pressure. Don't think of raised intracranial pressure. What is that this patient might be having? This particular patient might have developed hypoglycemia. The patient might have developed hypoglycemia, right? And it is because of the hypoglycemia, the patient is in state of coma, right? There is tachycardia. Because the patient is hypertensive, hypertension is there. And in a state of coma, what is that you will have? You will have bilateral extensor plantar reflex. Bilateral extensor plantar reflex. Okay. So what is that you need to do is check the blood sugar level first. Check the blood sugar level first. Okay. Right. So some of you said like BCD, some of you said CT scan, some of you said like to give labetalol. Many things you people said, right? So the answer is the check blood sugar levels. Okay. Now, antihypertensive. See, patient's blood pressure is definitely, it is elevated, right? And administering the antihypertensive medication without identifying the underlying cause could be potentially harmful. The hypertension here, it could be because of hypoglycemia also. Because of increased sympathetic activity secondary to hypoglycemia, there can be hypertension here, right? So jumping on to giving antihypertensive, that will not be a first-line treatment. Now giving the mannitol. When do we give mannitol? If there is raised intracranial pressure. There is no point to tell that there is raised intracranial pressure here. The patient is having tachycardia. There should be bradycardia if there is raised intracranial pressure. And what about CT scan? Yes, CT scan is definitely, it's an important diagnostic tool in the evaluation of a comatose patient. But with the findings which has been given to you, the essential investigation is the blood sugar levels. Later you do the CT scan. But the first important is check blood sugar levels. Okay. Right, nine. It is not like we can't think like that. You have to think like that. You have to think like that, right? Okay. Now, so we'll move on to the next question. Yeah. So that was about the questions related to the emergency medicine. Now we'll quickly move on to the questions related to the hepatology. Yeah, Bhairavi Ganti. For example, like if the patient is having hypoglycemia, what is that we'll do? We'll give dextrose, right? We'll give dextrose. We'll give dextrose. Okay, right. Now, we'll move on to the questions related to the hepatology. Right. So the first question in the hepatology is, a patient presents to the emergency department with history of ingestion of 10 tablets of the paracetamol. He has developed oliguria. And liver function test shows deranged values. Which of the following can be used in the management of this condition? N-acetylcysteine, dopamine, ursodeoxycholic acid, and furosemide. Yeah. So in case of paracetamol poisoning, what exactly is the drug of choice? That is N-acetylcysteine. That is what is used for paracetamol toxicity. What basically is your N-acetylcysteine? It will act as the precursor of the glutathione, right? And what it will try to do, N-acetylcysteine, it will try to increase the levels of the glutathione. Okay. Once it will increase the levels of the glutathione, that will assist in the metabolism of NAPQI. So basically, what is happening in paracetamol poisoning? The NAPQI, which is a toxic metabolite of the paracetamol, it is getting accumulated because of the exhaustion of the glutathione. Whenever you are giving N-acetylcysteine, it will increase the glutathione and it will increase the metabolism of the NAPQI. Okay, right. Whereas the other three options, they don't have any role in case of paracetamol toxicity, right? And which renal pathology we give N-acetylcysteine? In which renal pathology we give N-acetylcysteine? Yes. N-acetylcysteine, it is a drug of choice in case of contrast-induced nephropathy. In case of contrast-induced nephropathy, we give the N-acetylcysteine. We give N-acetylcysteine. Okay. Yeah. When to do alkalinization of the urine? In cases of urinary tract infection, we give that citralca syrup, right? And yes, Kamlesh, what is that? No, sir. You mean to say contrast-induced nephropathy, we don't give N-acetylcysteine is what you are saying? No, sir. In contrast-induced nephropathy, we give IV fluids and the drug of choice will be N-acetylcysteine, right? Okay. Now we move on to the next question. Okay. So the question is, a patient presents to you with fever, jaundice, and malaise. What is the most likely diagnosis based on the serology report given below? IgM positive, surface antigen positive, anti-HBsAg negative, then anti-HCV negative. Can we give N-acetylcysteine? Renal pathology, I said, right? Not renal failure, renal pathology. In which renal pathology we give N-acetylcysteine, I said. I didn't say renal failure. I said in which renal pathology? That is in contrast-induced nephropathy. Okay? Right. Yeah. So what is this suggestive of? Right. So this is suggestive of your acute hepatitis B because your IgM anti-HBC is positive and surface antigen is positive. Okay. And anti-HBs is negative. Serology of hepatitis B. I show you one table. I'll show you one table. Very, very important table. That table you do mug up and then go to the exam. There are some things where you should not go to the exam without revising them. Like I was just discussing complications of blood transfusion. Without revising complications of blood transfusion, don't go to exam. Without revising pulmonary function test, don't go to exam. Without revising serology of hepatitis B, don't go to exam. Right? And without revising ABG, arterial blood gas analysis, don't go to exam. These are some things which are like core, definitely asked questions. Okay. Right. Anyways, I have one more question on the serology. There I'll show you about that particular table. Right. Coming on to the next question. A child presents to the emergency department with a history of ingestion of 10 to 20 ferrous sulfate tablets. Arterial blood gas analysis revealed acidosis. Which of the following can be used in the management of this condition? Deferoxamine, activated charcoal, dimethaprol, penicillamine. Yeah. So in case of the iron toxicity, what is the drug that we give as the iron chelating agent? That is deferoxamine. Okay, deferoxamine. Right. Then you take the other molecules which have been given in your options. So the other molecules you take, okay, activated charcoal, we give it for many of the poisonings, but you take this dimethaprol. Can anyone tell me for which all poisonings or dimethaprol is a chelating agent in? There was what test to perform in viral hepatitis? What was the options for that? We do many tests, right? Yeah. So dimercaprol, it is a chelating agent for arsenic. It's a chelating agent for gold, and it's a chelating agent for mercury poisoning. So it is an antidote for arsenic, gold, and as well as the mercury poisoning, right? As well as acute lead poisoning. Even in case of acute lead poisoning, we give this dimercaprol in combination with edited calcium sodium. We give in combination with edited calcium sodium. And penicillamine is what? Penicillamine, it is the drug which is approved in the treatment of the Wilson's. Okay, it's the drug which is approved in the treatment of the Wilson's. That's a copper chelating agent. Okay, next. A 20-year-old male presented with 1 week history of the yellow skin and sclera, but is otherwise asymptomatic. He gives history of viral upper respiratory infection 10 days ago, which resolved 2 days back. There is history of similar episode of icterus 2 years back when the patient had long hours of basketball practice. The serum bilirubin is 2.4 milligrams per deciliter. Unconjugated bilirubin is 2.1. And conjugated bilirubin is 0.3, right? And the AST and ALT are normal. Which of the following is the most likely diagnosis? Yeah, so it is your Gilbert syndrome, right? So what exactly is here? It is unconjugated bilirubin. It is the unconjugated bilirubin which is being elevated. So what are the hereditary conditions where you have unconjugated bilirubin which is being elevated? That is in case of Gilbert's. And the other one is Crigler-Najjar syndrome. So how will you rule out Crigler-Najjar syndrome? How will you rule out the Crigler-Najjar syndrome in this clinical scenario? Right, that is age. Crigler-Najjar syndrome, it is present in the infants, that is in children. Okay, but whereas the Gilbert syndrome, it is the one which is present in the adults, right? And what exactly is the problem in case of your Gilbert's or Crigler-Najjar's? The activity of the UDP glucuronyl transferase, the activity of the UDP glucuronyl transferase enzyme that is being reduced. That is what you will observe in case of the Gilbert's. You take in case of Dubin-Johnson's and you take in case of Rotar's. In Dubin-Johnson's and as well as Rotar, it is conjugated hyperbilirubinemia. In Dubin-Johnson and Rotar, it is conjugated hyperbilirubinemia. But whereas in case of Gilbert's, it is unconjugated hyperbilirubinemia. And this particular Crigler-Najjar syndrome, if you observe, there also you have reduced UDP glucuronyl transferase activity, but the age is in the infants. Age is infants. Okay. So that is what is the difference. And that is how you will be able to make out. Right? Right. So the answer is, the answer in this particular question is what? That is Gilbert syndrome. Next question. Which of the following is not a component of the child-pug score? Yeah. So this is one important area where the scoring systems, there are three important scoring systems for the liver. One is child-pug score. The other one is the discriminant function score. That is your DF score. And the other one is the MELD score. These three scores you need to be very much aware of. This is another potential area where the questions are being asked in the liver. Scores, CP score, MELD score, DF score. Right, very good. So the answer here is the liver function test, which is not the component of your child-pug score, is the liver function test. So actually in case of the child-pug score, what are the other components which are present in the child-pugs apart from this is bilirubin, albumin, then prothrombin time. Then the other important components will be ascites and as well as the hepatic encephalopathy. Ascites and hepatic encephalopathy. Your liver function tests like AST and ALT, they are not the components of your child-pug. They are not the components of your child-pug, right? And based on the score, you will assess the survival rate. You will assess the survival rate. I'll show you this, right? That is, you see this table, very, very important table. Yeah. So if the child-pug score is like 5 to 6, then 1 year survival rate is 100%. If the child-pug score is like 7 to 9, 1 year survival rate is 81%. And if the child-pug score is 10 to 15, then the 1 year survival rate is 45%. Okay. So that is the importance of child-pug score. right? And what are the other scores for assessment of the liver severity? That is your MELD score, then discriminant function score. This discriminant function score, it is mainly for hepatitis, for alcoholic hepatitis. Right, for alcoholic hepatitis, you do this discriminant function score. Now, let me talk about the your MELD score. What are the components that are being added in the MELD score? Okay, so just remember your CIBIL score. Okay, CIB, right? C stands for creatinine. I stands for INR, international normalized ratio. B stands for, yeah, bilirubin. Yeah, CBI or CI. Okay, good. CBI. Right, fine. So the creatinine, then the bilirubin, and then the INR, that is international normalized ratio, right? And what is the important? You don't require to remember the formula. You don't require to remember the formula, right? And what is the importance of this particular MELD score is, if the MELD score is like more than 14, it's an indication for orthoptic liver transplantation. It's an indication for orthoptic liver transplantation. Okay. Then DF score, discriminant function score. That is for what? That is for assessment of the severity of alcoholic hepatitis. And if your discriminant function score is like more than 32, that is the point where you need to give steroids. You need to give steroids or pentoxifillin. You need to give steroids or pentoxifillin. That is what is the importance of your discriminant function score, right? And you take child-pug score. So how much should be the child-pug score for liver transplantation? If the child-pug score is more than 7, one minute, I don't know what happened. Okay, sorry. I'm sorry. Okay. So if the child-pug score, if it is like more than 7, that is the point when you need to do liver transplantation. Okay, that is the point when you need to do liver transplantation, right? So this is about your the scores, MELD score, discriminant function score, and as well as the child-pug score. Yeah, you take discriminant function score. Discriminant function score, what are the parameters that we take into consideration is, we take bilirubin into consideration. We take bilirubin into consideration, and as well as INR into consideration. Bilirubin and as well as INR. These are the two components which are taken in the discriminant function score. Okay. And why is that we are giving pentoxifillin, or why is that we are giving steroids, is mainly to suppress the inflammation. To suppress the inflammation of the alcoholic hepatitis, we give this pentoxifillin or the steroids. Either of these can be given. Okay. So that is about the child-pug score. So which of the following is not the component of the child-pug score here? That is, liver function test is not the component of the child-pug score, right? Next question. Okay, next question is related to hepatitis B treatment. Okay, right. A 30-year-old male with chronic hepatitis B and HBeAg positive presents for evaluation. The patient's viral load was 10 to the power of 5 per ml. SGPT is found to be doubled. Right? What is the appropriate management in this particular patient? Lamivudine, tenofovir, pegylated interferon, combined PEG with lamivudine. No. Some of you have answered correctly and some no. So the correct answer is no. Okay, the correct answer is you need to give tenofovir. Whoever has answered tenofovir, that is correct. Okay, let me tell you. So first you need to know the indications for starting antiviral drugs. Okay, first of all, what are the antiviral drugs that we can give? First line antiviral drugs. Remember this particular mnemonic, that is PET. Okay, what does this PET stands for? That is pegylated interferon. This is given through subcutaneous route. then the other drug is entecavir, then tenofovir, right? Then tenofovir. Okay, so these are the first line. These are the first line drugs for the treatment of the hepatitis B virus. All right. Now, this pegylated interferon, it is given through subcutaneous route. It is like parenteral route. That will not be the first among these three drugs. That will not be the first among these three drugs, right? And what is that we use among the options which has been given to you is the tenofovir. And tenofovir you need to give for nearly around 48 weeks. You need to give nearly around 48 weeks. That is almost like, 48 weeks you need to give. Now the point is, what is the indication to start the antiviral drugs? When is that you need to start the antiviral drugs? You need to start the antiviral drugs if there is doubling of, right? If there is doubling of your SGPT, right? If there is doubling of the SGPT, and along with that, if the viral load, if it is increased to more than 2 into 10 to the power of 4, if it is increased to more than 2 into 10 to the power of 4, that is the point when you need to start the antiviral drugs. Okay. No, it is not 2000, it is 20,000. 2 into 10 to the power of 4 is 20,000. Okay. That is the point when you need to start the antiviral drugs. And which antiviral drug it is preferable to start with? Tenofovir or entecavir. Okay. So the correct answer here is tenofovir. Okay. Lamivudine also we give for the treatment of the hepatitis B virus, but lamivudine is not the first line antiviral drug. The first line antiviral drugs are pegylated interferon, entecavir, and as well as the tenofovir. Okay. But this pegylated interferon, it is administered parenterally through injectable form. Most of the patients does not prefer that injectable forms. Right. Coming on to the next question. Yeah, 48 weeks, which is 11 months. Which benzodiazepine is suitable for safe administration to a 40-year-old chronic alcoholic experiencing withdrawal symptom based on the liver function test that indicated AST of 140, ALT 110, and GGT 500 international units per liter? Which is that can be given safely? Which is that can be given safely in this clinical scenario? Diazepam, alprazolam, clonazepam, lorazepam. Right. So the correct answer is the lorazepam. The correct answer is the lorazepam. Okay. So why is that we are giving lorazepam? Lorazepam, it is not extensively metabolized in the liver. Okay. It is not extensively metabolized in the liver. Right. And the clearance of lorazepam, it is less affected by liver dysfunction. It is less affected by the liver dysfunction compared to the other benzodiazepines. Okay. Right. And this particular lorazepam, it has a shorter half-life than compared to that of diazepam. It has a shorter half-life than compared to that of the diazepam. That is the reason why lorazepam, it is suitable option for managing alcohol withdrawal symptoms in patients with the liver disease. Okay. So that is the reason why the lorazepam is being preferred. Whereas you take the first three options A, B, C, they are metabolized by the liver. That is the reason why they are not recommended in case of the liver disease. Right. Next question. Okay. In methanol intoxication, which of the subsequent electrolyte abnormality is observed? Metabolic alkalosis with high anion gap, acidosis with high anion gap, acidosis with normal anion gap, alkalosis with normal anion gap. What is that you will have in case of methanol intoxication? Krishnamamsi, why did you answer C? It is metabolic acidosis with high anion gap. Just now we have discussed diabetic ketoacidosis, uremia, lactic acidosis, ethylene glycol intoxication, methanol intoxication. In all of them, it is metabolic acidosis with high anion gap. Hagma will be there in case of methanol intoxication. All right. So, like very simple mnemonic is cult. K stands for ketoacidosis, that is your diabetic ketoacidosis or alcoholic ketoacidosis. U stands for your uremia, that is secondary to acute kidney injury or chronic renal failure. L will be your lactic acidosis, okay, your type A or type B lactic acidosis. T will be toxins. What are these toxins? That is ethylene glycol poisoning and as well as methanol poisoning. Okay, so that is about your methanol intoxication. Now, in a male patient who is a chronic alcoholic, he has come in with abdominal distension, reduced urine output, and swelling of the feet, that is pedal edema. Upon examination, his creatinine levels was found to be 1.6 milligrams per deciliter. What would be the appropriate course of action in managing this patient? Methylprednisolone, heparin, torsemide, octreotide plus albumin. Deepak Reddy. Why methylprednisolone, Deepak Reddy? What are you suspecting? Shubhajit, are you suspecting pre-renal acute kidney injury? So what do you want to give, Shubhajit? What do you want to give then? Right. So, yeah. So basically, this particular patient has developed hepatorenal syndrome. Yeah, very good, Shubhajit. Correct. So this particular patient has developed the hepatorenal syndrome. Okay. So what is the treatment that we give in case of the hepatorenal syndrome is the octreotide plus the albumin. Octreotide plus albumin. So what will be the problem in hepatorenal syndrome? The problem in the hepatorenal syndrome is it is basically a renal dysfunction, and that is due to severe vasoconstriction of the renal blood vessels, and thereby there is reduced renal blood flow causing impairment of the kidney function. That is what will happen in hepatorenal syndrome. So what is that this octreotide will do? Octreotide, it alleviates the vasoconstriction, and the albumin, right, and albumin, it improves the intravascular volume and renal perfusion. It improves intravascular volume and renal perfusion. Okay, so octreotide and as well as albumin, that will be very much effective in the treatment of the hepatorenal syndrome. This hepatorenal syndrome, actually you have two types. One is type 1 and as well as type 2 hepatorenal syndrome. Between these two, the one with worst prognosis will be type 1 hepatorenal syndrome. In type 1 hepatorenal syndrome, there is rapidly progressive renal failure. Whereas in case of your type 2 type 2 hepatorenal syndrome, there is slowly progressive renal failure. There is slowly progressive renal failure in case of your type 2 hepatorenal syndrome. What will be the clinical feature in case of hepatorenal syndrome? There will be reduction in the urine output. There will be increase in the creatinine. Because there is dilution, so there will be hyponatremia, right? And it is a liver pathology causing kidney pathology. So there will be elevated bilirubin, there will be elevated liver enzymes, and this particular patient is having the edema. So there will be also having edema and as well as the ascites. And how is that you treat this hepatorenal syndrome? That is albumin with octreotide. The other options are, we can give, yeah, some of you are telling like terlipressin. Yeah, you can also give the terlipressin, right? And yes, Champagni, so you need to do liver transplantation. If the patient is not responding to the medical management, the treatment of choice will be liver transplantation. Okay, so the answer is D in the options which has been given to you, right? Next question. For a patient with the serum bilirubin of 2.5 milligrams per deciliter, serum albumin levels of 3 grams per deciliter, prothrombin time of the 5 seconds, the INR, the prothrombin time of 5 seconds, encephalopathy grade 1, mild ascites, what would be the child pug score? What would be the child pug score? Bilirubin is 2.5. Albumin 3, that is reduced. Prothrombin time, that is 5 seconds. And encephalopathy grade 1, mild ascites. Mild ascites. Yeah. So yes, very good, Vaibhav Anand. So Vaibhav Anand has answered it correctly. And okay, whoever has answered C. Now, how is that you will be able to grade this? I'll just show you this. Right. I'll show you how to grade this particular score. So, right. So this is like pointers. This is the table which will give you the pointers depending upon the bilirubin, albumin, prothrombin time, ascites, and as well as the hepatic encephalopathy. So based on this particular pointing tables, this was a PYQ in the INI-CET. That means this table is very important. You need to remember when to give 1 point, when to give 2 points, and when to give 3 points, right? Now, based on the score which has been given to us, based on the features which has been given to us, what will be the points? Serum bilirubin is 2.5. Give a score of 2 points. Albumin level 3 grams per deciliter. Give a score of 2 points. Prothrombin time of 5 seconds. Give a score of 2 points. Encephalopathy grade 1. Give a score of 2 points. Mild ascites is there. Give a score of 2 points. Okay. So now all these will give you the score of 10. All these will give you a score of 10. Okay. When it is a score of 10, which particular class does this particular patient comes under? This patient comes under class C. This patient comes under class C. Okay. Right. So yeah, like if suppose if the score of the individual, if it is like 5 to 6, then he comes under class A. If the score of the individual is like 7 to 9, he comes under class B. If the score of the individual, if it is like 10 to 15, then he belongs to class C. Right? So that is the reason why the answer in this particular question is the class C. That is the reason why in this question the answer is class C, right? Okay. Now, after having discussed about the Child-Pugh score, there is one question on the complications of the ascites. Which drug should be preferred for treating a 45-year-old individual with history of chronic alcoholism who had been admitted to the hospital with the symptoms of fever and abdominal pain, was previously diagnosed with liver cirrhosis 2 years ago, as indicated by neutrophil count of 360 cells per microliter in the ascitic fluid? Very good. So this is a question which is suggestive of the SBP, that is spontaneous bacterial peritonitis. So what are the points to tell it is spontaneous bacterial peritonitis? The point to tell that it is a spontaneous bacterial peritonitis is if the neutrophil count is like more than 250 polymorphonuclear cells per cubic millimeter in the ascitic fluid, that is suggestive of SBP, right? And what is the most common organism that will be causing SBP is the Escherichia coli. And what is the drug of choice is the cefotaxime, right? Cefotaxime, right? But how will you prevent the recurrence? Can anyone tell me what is the antibiotic that you will give for preventing the recurrence? What is the antibiotic that you will be giving to prevent the recurrence? Anyone? Very good. So you need to give norfloxacin. You need to give norfloxacin. Okay. So that was about the story related to the SBP, that is spontaneous bacterial peritonitis. So this was the questions on hepatology. We have one question on hepatology, that is hepatitis B, that you will come in the gastroenterology part. I'll be discussing that there as well. So now let us discuss the questions related to the gastroenterology. Right. What is the probable diagnosis for a 50-year-old woman with the skin lesions visible in the provided image, which initially appeared small but has now spread to the entire limb and abdomen? Despite being on the anticoagulant therapy, she has a long-standing history of diabetes and recurrent deep vein thrombosis episode. Right? Excellent. So this was the recently asked question. So the answer is the glucagonoma. The answer is glucagonoma. So whatever the skin lesion, whichever has been given there, right? So it is there over the limbs. And what is the name of that skin lesion? The name of the skin lesion is necrolytic migratory erythema. Necrolytic migratory erythema. This is the skin lesion, right? And along with that, what is the other things the patient is having? Diabetes and as well as recurrent deep vein thrombosis. Recurrent deep vein thrombosis. And how is that you will describe this necrolytic migratory erythema? Necrolytic migratory erythema, right? So this is a red scaly rash, right? It is a red scaly rash that appears in multiple locations of the body, including lower limbs, buttocks, groin, and as well as the perineum, right? So the answer here is the glucagonoma. And how is that you will, first of all, this glucagonoma, where is it commonly observed? It is commonly observed over the tail of the pancreas. And how is the tumor? It is malignant tumor. What is the size of the tumor? It is around 5 to 10 centimeters in size, right? And what is the characteristic features that you have in case of the glucagonoma? One important feature is your necrolytic migratory erythema. These patients will also develop diabetes mellitus. The other important manifestation is development of diarrhea and dermatological manifestation, that is necrolytic migratory erythema. So these are the features that you will have in case of the glucagonoma. All right. Now, how is that you will treat these patients with glucagonoma? First of all, how will you diagnose? You need to check the plasma glucagon levels. The plasma glucagon levels will be more than 1000 picograms per ml, right? And you also need to do CT or MRI of the abdomen. What is the purpose of doing CT or MRI of the abdomen? That is mainly to check for the metastasis. Almost 80% of these glucagonoma, they will undergo metastasis to the liver. It will undergo metastasis to the liver. So how is that you will treat the glucagonoma? The treatment of the glucagonoma is you need to do a debulking surgery. You need to do a debulking surgery. That is what is the treatment for the glucagonoma. And to tell about the other options, you take insulinoma. In insulinoma, you don't have diabetes mellitus. In insulinoma, what is that you will have is hypoglycemia will be there, right? Which will cause weakness, confusion, sweating, and palpitations, right? Then you take gastrinoma. So gastrinoma, it's a pancreatic neuroendocrine tumor where there is excessive amount of gastrin. That will cause increase in the gastric acid production, that will cause peptic ulcers. Because of the peptic ulcers, they will have abdominal pain, vomiting, and as well as diarrhea. That is what you will observe in gastrinoma. You take in case of VIPoma, that is vasoactive intestinal polypeptidoma. This is one of the rare pancreatic neuroendocrine tumor. What will be the features in case of VIPoma? Watery diarrhea, dehydration, and electrolyte imbalances. That is what you will have in case of the VIPoma, right? So this is about your glucagonoma. This is about your glucagonoma, right? We'll move on to the next question. Yeah, mark the correct statement regarding the inflammatory bowel disease, right? So I said you some of the things like you need to revise just before going to the exam. The another important topic is your inflammatory bowel disease. Definitely you need to revise before going to the exam. Yeah. So mark the correct statement regarding the inflammatory bowel disease. Right. So the correct answer is, yeah, skip lesions. They are present in the Crohn's disease. Okay. And mucosal layers are involved in Crohn's? No. In Crohn's, transmural involvement will be there. Whereas in ulcerative colitis, the mucosal layer is affected. Whatever has been given there is ulta, exactly opposite. Okay. And inflammatory bowel disease doesn't have genetic predisposition. It is a wrong statement. They do definitely have a genetic predisposition, right? And Crohn's disease is curable through surgical resection? No. It's a chronic inflammatory disease, right? You need to give anti-inflammatory drugs. Only through surgical resection, right? No, it does not get cured. Okay. And I'll show you a table of differences between Crohn's and ulcerative colitis, which you should definitely revise before going to the exam. So, yeah. So this particular table, so where exactly will be the inflammation? What are the symptomatologies, complications, right? I'll send you this PDF once the session is over, right? So this table you should definitely revise, okay? And the risk factors. So genetic predisposition definitely will be there in this Crohn's and as well as the ulcerative colitis, right? Coming on to the next question. A patient presents with cough, cold, fever, and malaise associated with weight loss and ascites. Radiograph of the chest is shown below. Ascitic fluid analysis showed elevated ADA. Which of the following is the next step in the management? Biopsy, start ATT after laparotomy stricture removal, start ATT, then symptomatic management. PDF will be available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Right. So this, what exactly is this? This is a clinical scenario of the pulmonary tuberculosis, right? Who has developed tubercular peritonitis. Who has developed peritoneal tuberculosis or tubercular peritonitis, right? So how is that you need to manage? You need to manage with the anti-tubercular drugs, okay, which includes isoniazid, rifampicin, pyrazinamide, and as well as the ethambutol, okay? So the answer is C. Coming on to the next question. So a patient with peptic ulcer disease was treated with the H. pylori regimen. Which of the following is used to assess the success of the treatment? Endoscopy, IgG antibody test, urea breath test, and urease test of the biopsy. Right? Yeah, very good. Right, that is the urea breath test. So urea breath test is the preferred method to assess the success of the H. pylori regimen, right? And what exactly is the procedure is not required, but how will you assess the success of the treatment? That is by your urea breath test, right? Very, very important. So the screening test is the urea breath test. The screening test for H. pylori infection is the urea breath test. The confirmatory test is you need to do endoscopy and biopsy. But the screening test for H. pylori infection is urea breath test, right? Next, what is the enzyme? What is the enzyme deficiency in Pompey's disease? What is the enzyme deficiency in Pompey's? Right. So the enzyme which is being deficient in Pompey's, it is lysosomal acid alpha glucosidase. What exactly is Pompey's? Pompey's, it is a glycogen storage disease. And that too, what type of glycogen storage disease? It's a type 2 glycogen storage disease, which is caused by deficiency of this particular enzyme, lysosomal acid alpha glucosidase. Okay. And what exactly is the function of this particular enzyme? This enzyme, it is responsible for breaking down the glycogen, which is a stored form of the glucose. So it has to break the glycogen into glucose within the lysosomes. Now, once this particular enzyme is absent, glycogen is not broken down to the glucose. That is what is the problem in case of the Pompey's. You take this glucose 6-phosphatase. Glucose 6-phosphatase, it is the enzyme which is involved in the gluconeogenesis, right? And once this particular glucose 6-phosphatase is being deficient, what is the enzyme, what is the disorder these patients will develop into? That is von Gerg's disease, right? Von Gerg's disease, which is a glycogen storage disease of type 1, type 1 glycogen storage disease, okay? And next one is the muscle phosphorylase, okay? Now, this muscle phosphorylase, the another name for muscle phosphorylase is myophosphorylase. This muscle phosphorylase, it is the enzyme which is involved in glycogenolysis in the muscle tissue. Glycogenolysis in the muscle tissue. So, yeah, because of the deficiency of this particular enzyme, the patients will develop McArdle disease. McArdle disease. So it is a glycogen storage disease type 5. And this is characterized by exercise intolerance and muscle cramps. That will be the features of muscle, McArdle disease. Next one is the phosphofructokinase. Phosphofructokinase, it's an important enzyme which is required in glycolysis. Okay, so it is required for breakdown of the glucose to produce the energy. Now, once there is a deficiency of this phosphofructokinase, what is the name of the disease that is occurring? Yeah, very good. So the name of the disease is Tarui disease. And what storage disorder is this? This is glycogen storage disorder, that is type 7. That is type 7. And it is a disorder where you have exercise intolerance and as well as the muscle weakness. Okay. So that is about the various enzymes. That is about the various enzymes. So, but what is being asked for us is Pompey's, where you have the deficiency of this particular enzyme, lysosomal acid alpha glucosidase, right? Next question. A 10-year-old child presents with recurrent pulmonary infection, and bulky greasy stools. Quantitative estimation of the stool fat was more than 10 grams per day. Which of the following will be seen in this child? Protein losing enteropathy, distal intestinal obstruction, hypernatremia, rectal prolapse occurring after treatment. Anvesha Das, if it is protein energy malnutrition, why there should be like fatty stools? Why there should be bulky greasy stools? Bulky greasy stools, right? Fatty stools, that is not suggestive of your protein energy malnutrition. Okay, so you will get this bulky greasy stools, fatty stools in case of distal intestinal obstruction. What exactly is the distal intestinal obstruction? It refers to the blockade or narrowing in the lower part of the intestine, right? And because of the narrowing in the lower part of the intestine, this can lead to the development of the symptoms such as recurrent pulmonary infections. There will be steatorrhea, bulky greasy stools, and there is increased stool fat in case of the distal intestinal obstruction. Okay, and what will be the clinical features in these patients with distal intestinal obstruction is they'll have sudden onset crampy abdominal pain. They'll have crampy abdominal pain. Okay, whereas in case of protein energy malnutrition, the proteins are being lost. These patients, they will present with edema and as well as the hypoalbuminemia, but not the greasy stools, right? And the last two options, you don't have the greasy stools at all. Okay, so the answer in this particular question is the distal intestinal obstruction, right? Next question. What is the underlying reason for the ABG finding in a diabetic woman who has been admitted to the hospital due to continuous vomiting after consuming food from outside and has a blood pressure reading 90/60, right? pH 7.52, bicarbonate 30, PaCO 250, sodium 123, potassium 3.2, and chloride levels are 67. Yeah, anyone? Very good. So this is very much suggestive of the persistent vomiting. This is very much suggestive of persistent vomiting. What is that you are observing there? So, okay, here the carbon dioxide is not 20, carbon dioxide is 50, okay? Right. So what is this very much suggestive of? The diagnosis, this is very much suggestive of metabolic alkalosis. Metabolic alkalosis. Okay, so where is that you will have this metabolic alkalosis among the options which has been given to you is persistent vomiting. In diabetic ketoacidosis, what is that you will have is metabolic acidosis, right? And the septic shock, you will have metabolic acidosis. Renal tubular acidosis, you will have the acidosis. You will have the acidosis. Okay, so the answer here is the persistent vomiting where you will have the presence of metabolic alkalosis, right? Then coming on to next question. What is the treatment that you will give in case of persistent vomiting? Very simple. You need to give antiemetics. You need to give the antiemetics. Next question. So we have a 15-year-old girl presented with fatigue, chronic diarrhea and weight loss, bone pain and abdominal distension. Investigation revealed the iron deficiency anemia and as well as the osteoporosis. Which of the following is a single best test done for her evaluation? So 15-year-old girl, fatigue, diarrhea, weight loss, bone pain, abdominal distension, iron deficiency anemia, and osteoporosis. Why do you want to do the TSH level? In TSH, you don't have iron deficiency anemia, right? Yeah. So this particular clinical scenario, it is very much suggestive of the celiac disease. It is very much suggestive of the celiac disease. What exactly is the celiac disease? It's an autoimmune condition which is characterized by immune reaction to the gluten, right? So what is gluten? It's a protein. Where do you have this particular protein? In the wheat. It is present in the barley and it is also present in the rye. Okay. And this particular celiac disease, it can lead to malabsorption. It can lead to malabsorption. And because of this malabsorption, they will have chronic diarrhea, they'll have weight loss, they'll have fatigue. All these are observed in case of the celiac disease, right? So in case of celiac disease, how is that you will diagnose? You will diagnose the celiac disease by IgA tissue transglutaminase antibody. IgA tissue transglutaminase antibody. That is the serological test for the your celiac disease. But what is the investigation of choice? The investigation of choice will be small bowel biopsy. Okay, so small bowel biopsy is the one which will confirm the diagnosis. What is that you will observe in the small bowel biopsy? You will observe that there is villous atrophy. You will observe that there is inflammatory changes. That is what you will observe in the biopsy. And what is the management? Okay, the management is a strict gluten-free diet. Very strict gluten-free diet. Okay, that is very, very important. And along with that, you need to give the nutritional supplements. Iron you should give, calcium you should give, vitamin D you should give, because there is osteoporosis, right? Okay. And what will be the complications in these patients? The anemia. Anemia is a very, very important complication, right? And this is about the celiac disease. Then, yeah, this is what I was talking about, right? The blood investigation of a patient is given below. What is the probable diagnosis? Surface antigen negative, envelope antigen non-reactive, IgG reactive, IgM is non-reactive. Yeah. Right, very good. So it is suggestive of remote infection. In case of acute hepatitis B, what is that you will have? The HBsAg will be positive, right? And IgM anti-HBC will be positive. Okay. Whereas chronic hepatitis B, HBsAg will be positive, then IgG anti-HBC will be positive, right? And you take the remote infection. In case of the remote infection, you have only IgG anti-HBC will be only positive, okay? And you take in case of window period. In case of window period, right, only IgM anti-HBC will be positive. Only IgM anti-HBC will be positive in case of core window period, right? I said you that I will show you a table. I said you that I'll show you a table for the hepatitis B serology. Yeah, this is a table. Okay. Please don't go to the exam without revising this table. Very, very important table. So what has been asked for you is from this point, that is the hepatitis B in the remote past. Hepatitis B in the remote past, only you have the IgG anti-HBC is positive. The remaining all will be negative. The remaining all will be negative. Okay, I'll send you this particular table onto my Telegram channel. I have already sent you my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? I'll be sending you this table and as well as the PPT with explanation. PPT with explanation. Okay, right. Now we'll move on to the next question. Right. So we have a patient, right? A male patient who presented with, he's a youth, comes to the clinic complaining of persistent high fever over the past 5 days. During the examination of his hand, painless lesions are observed and new regurgitant murmur is being detected. The echocardiogram reveals the existence of mass on the mitral valve. Based on these findings, which of the following abdominal finding would be expected in this case? Yes, Bindyananda, I said you right. Medicine Made Easy by Dr. Rajesh Gubba is my Telegram channel. So there I will send it to you. Okay. Yeah. What is that? Yes, Shubhajit, what is your answer? Yeah. So this is a case of infective endocarditis in case of IV drug abusers, right? So no. Why portal hypertension? All of you, why are you answering portal hypertension? In infective endocarditis, you don't have the portal hypertension. What is that you will have is splenomegaly. Splenomegaly is a characteristic feature that you will have in patients with infective endocarditis, right? That's very, very important point. And your splenomegaly, it's one of the part of your minor criteria. You have major Duke's criteria, major and minor. You have 2 major and 5 minor. Okay. So in one of the minor criteria is the presence of splenomegaly. Okay. And the question says very clearly, new regurgitant murmur is being detected. And that is because of your IV drug abuse. So which sided valves are commonly affected in IV drug abusers? Which sided valves are commonly affected in the IV drug abusers? Yes. Yeah, so it is the right-sided valves are commonly affected. That is the tricuspid valve and as well as the pulmonary valve are commonly affected. Okay, right. So this was one of the image-based question which was asked. What clinical examination is being performed in the image? Shifting dullness, ascites, Poodle sign, fluid thrill. Hmm? No, 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 no. It is not Poodle sign. This is not Poodle sign. No, this is not shifting dullness. This is fluid thrill. This is fluid thrill. Okay, I'll show you the better images. Right. Okay. Right. So, don't know. Somewhere I have just dropped that images. Right. So, if you take this, 1 minute. Yes. Yeah. So this is what is your Poodle sign. This is what is your the Poodle sign. Okay. Now, when will you do this Poodle sign? You will be able to do the Poodle sign will be positive when the amount of the fluid in the peritoneal cavity is around 120 ml. If the amount of the fluid in the peritoneal cavity is around 120 ml, then you will do this Poodle sign, right? And next is, yeah, this is what is called shifting dullness. Shifting dullness, like you need to shift the patient to on one lateral side and then you need to do percussion. The shifting dullness will be positive when the quantity of the fluid in the peritoneal cavity is around 500 ml. Okay. Then next one is, this is nothing but your fluid thrill. That was our question also. When will your fluid thrill will be positive? When the quantity of the fluid is around 1 to 1.5 liters in the peritoneal cavity, that is a point when the fluid thrill will be positive. Okay. So this is about the question related to the assessment of the ascites. So what has been given to you here is the fluid thrill. Okay. Right. Then, so the last topic for the discussion, you want me to discuss the infections or you want to read by yourself? I will send the PPT. You want me to discuss the infections or shall I send you the PDF of the infections? डिस्कशन चलो ठीक है जल्दी जल्दी करेंगे फास्ट फास्ट करेंगे ठीक है बिकॉज इन्फेक्शंस दे आर आल्सो द पार्ट ऑफ योर माइक्रोबायोलॉजी ठीक है ठीक है ठीक है ठीक है 10 questions are there. We'll finish it fastly. No problem. So a patient diagnosed to be retropositive was started on heart treatment. Which of the following can be used to monitor the treatment efficacy? CD4 plus T cells, viral load, P24 antigen, viral serotype. Right, very good. So it is the viral load. It is the viral load. Okay. So it is the viral load which will assess the treatment efficacy of the highly active antiretroviral therapy. Now, whenever you have started the highly active, right, whenever you are assessing the highly active antiretroviral, whenever you're giving highly active antiretroviral therapy, the viral load, if it is less than 1000, right, if it is less than 1000, then it is suggestive that the highly active antiretroviral therapy, whatever you're giving, is efficacious. But if it is more than 1000, what is that we will do is we will ask to repeat this particular viral load after 1 or 2 weeks, right? We will ask them to repeat. Even in the repeat viral load also, if the viral load is like more than 1000 copies, that means it is a failed therapy. Okay, the antiretroviral therapy, what the patient is taking, it is like failed. You need to start the second line regimen in this patient. Okay, so viral load is the way by which you will be able to assess the efficacy of the heart. What is the drug of choice in case of the Legionnaire's disease? So basically Legionella pneumonia. Legionella pneumonia. Yeah, okay, very good, Subhajitja. So it is the azithromycin. Azithromycin is considered as the drug of choice. Actually, Legionella pneumonia, what it will cause? This will cause the atypical pneumonia. This will cause the atypical pneumonia, which is also called interstitial pneumonia. And Legionella pneumonia is the one where you have the extrapulmonary manifestations. What will be that extrapulmonary manifestations? This extrapulmonary manifestations will be in the form of diarrhea. And this diarrhea will cause hyponatremia And because of this hyponatremia, these patients will develop the confusion. These patients will develop the confusion. Okay, right? And how is that you will diagnose? The diagnosis of the Legionella is by your culture, and you can also do a urine examination for the antigen of Legionella. And the drug of choice is azithromycin. The drug of choice is azithromycin. Okay, that was about the Legionella pneumonia. Right. Yeah. So I said you about this topic related to meningitis. So like one particular topic in the CNS which you should not go without revising is the table for the CSF analysis: bacterial meningitis, viral meningitis, tubercular meningitis, fungal meningitis, Guillain-Barré syndrome, all this. Yeah. What is the likely diagnosis for a patient who has been experiencing fever, neck stiffness for 11 days? Lumbar puncture showed predominant lymphocytes with sugar 50, protein level like 3000, gram stain negative, chest x-ray revealed upper lobe involvement and enlarged hilar lymph nodes. Okay, so it's a direct question. It's a tubercular meningitis. Okay, so in case of your bacterial meningitis, it is neutrophilic predominant. Whereas these two, it is lymphocytic predominant. But why isn't it the fungal meningitis? Why? Because like the question says that there is chest x-ray showing the upper lobe involvement. That is very common in case of tuberculosis. Okay. And in case of viral meningitis, the glucose levels will be normal. It will not be reduced. The glucose levels will be normal. Whereas in fungal meningitis and tubercular meningitis, the CSF glucose levels can be reduced as well. Okay. Next question. Right. A 45-year-old HIV positive male complained of persistent cough, weight loss, and neck stiffness. He has skin lesions that appear as umbilicated papules and nodules. Right? Umbilicated papules. Champana Paji, just hold on. I'll take your questions. Let us just complete these questions first. Okay? I'll take your question. Right. So umbilicated nodules predominantly on the face, trunk, and upper extremities. Physical examination also revealed neck rigidity. Chest X-ray showed multiple bilateral nodular infiltrates. His sputum CB-NAT is negative, and he has CD4 count of 20. What do you think is the most probable diagnosis in this patient? Okay, so the correct answer is that right. So the correct answer is HIV with disseminated cryptococcosis. HIV with disseminated cryptococcosis. What is given here? There is neck rigidity. Right. And how much is the CD4 count? The CD4 count is 20. Okay. CD4 count is 20. And the points given are umbilicated papules and as well as nodules, which are predominantly over the face, trunk, and as well as the upper extremities. So what is the actually, when you're observing the presence of umbilicated papules, what is that which will strike first? Molluscum contagiosum is the one which will strike first. But remember, in the clinical scenario of HIV, with CD4 count less than 20, right, the most common fungal organism that will be causing meningitis will be Cryptococcus. And even in Cryptococcosis, you have this umbilicated papules and as well as the nodules. Even in the Cryptococcosis, you have umbilicated papules and as well as nodules, which are predominantly over the face, trunk, and as well as upper extremities. So the answer is what? The HIV with disseminated cryptococcosis. It is not the molluscum contagiosum. And your tuberculosis, though, it is completely ruled out. Why the tuberculosis is ruled out? Because your CB-NAT, which the test which has been done, it is negative. So in that way, the tuberculosis is being ruled out. Okay. And you take the histoplasmosis. See, histoplasmosis, they present with respiratory infection. They present with the skin infection, right? But meningeal involvement in case of histoplasmosis, it is less likely. Respiratory involvement will be there, skin involvement will be there in histoplasmosis, but not the meningeal involvement. Okay. And you take molluscum contagiosum, that is option C. So you have umbilicated papules, you have umbilicated nodules, right? And this molluscum contagiosum, they do not cause systemic involvement like what the patient has been given to you. Systemic involvement will not be there in case of the molluscum contagiosum. Okay. So in that way, A, C, D is ruled out. So the answer here is the cryptococcal meningitis. Okay. Next. A patient arrives at the hospital. Yeah, if encephalopathy is given, you can suspect toxoplasmosis, but the option is not there. So a patient arrives with at the hospital with symptoms of fever and chills. A fever profile test is conducted, which rules out malaria and dengue as the causes. However, the RK39 test comes back positive. What is the preferred treatment for this condition? The amphotericin B, griseofulvin, dapsone, hydroxychloroquine. Yeah, very good. So what exactly is the diagnosis here? The diagnosis here is the Kala-Azar, right? Which is nothing but it is the leishmaniasis. Okay. So the drug of choice here is the amphotericin B. The drug of choice is the amphotericin B. Okay. So in these patients, the RK39 test has come positive. What is RK39? Recombinant K39 protein. Recombinant K39 protein. Okay. So what is the drug of choice for the leishmaniasis? That is amphotericin B. So that is your Kala-Azar, which is nothing but visceral leishmaniasis. That is visceral leishmaniasis, right? What is a parasite in case of visceral leishmaniasis? It is Leishmania donovani. It is Leishmania donovani. How is it being transmitted? It is transmitted by the sandflies. It is transmitted by sandflies. What is the treatment of choice? That is amphotericin B, right? So your BCD are incorrect. Your BCD are incorrect. Okay, right. And in case of this Kala-Azar, what exactly will be the clinical manifestations? The clinical manifestation will be prolonged fever. They'll have weight loss. There will be massive hepatosplenomegaly, and there will be also the presence of anemia. The first line treatment is amphotericin B. But what is the second line treatment? Second line treatment in case of visceral leishmaniasis will be miltefosine, right? And the other drug is paromomycin. Miltefosine and paromomycin, these are the alternative drugs for the visceral leishmaniasis. And how is that you will diagnose the visceral leishmaniasis? That is microscopic examination of the bone marrow or microscopic examination of the spleen has to be done, right? The other one is molecular methods, that is PCR. Okay, that is about your Kala-Azar, which is nothing but visceral leishmaniasis. Yeah. A patient who is known case of HIV with CD4 count of 200 cells per cubic millimeter, presents with day 5 of cough and high-grade fever without chills and rigors. There is no history of diarrhea, vomiting, and nuchal rigidity. The chest X-ray is normal. What will be the treatment that you'll be giving in this patient? So the CD4 count is 200, the cough and high-grade fever without chills and rigors. Yeah, what is that you want to give? Right. So what are you suspecting? Yes, Gautam Kumar Yelka, what are you suspecting? So in this particular patient, what is that you need to suspect is when the CD4 count is 200, one of the common opportunistic infection is the pneumocystis jirovecii pneumonia. So in case of pneumocystis jirovecii pneumonia, right, what is the drug of choice? The drug of choice is the cotrimoxazole. That is a trimethoprim and sulfamethoxazole. That is the drug of choice in case of pneumocystis jirovecii pneumonia. Right? And there is no diarrhea, there is no vomiting, there is no nuchal rigidity. Respiratory manifestations, the first, and that too with a CD4 count of 200, you should definitely suspect the cotrimoxazole. And this cotrimoxazole, like how many days you have to give? You need to give 21 days. 21 days of cotrimoxazole should be given. And if the patient is admitted in the hospital, you need to give IV cotrimoxazole, right? Next. Which antibiotic can be administered to a patient with diabetes who develops urinary tract infection that is further complicated by hypotension and unresponsive to IV fluids? Yeah, Satvika Sai. In case of PCP pneumonia, in early stages of PCP pneumonia, the chest X-ray may be normal, right? But in the later stages, you will have ground glass appearance. Right, in later stages, you will have the ground glass appearance. Okay, right. Which antibiotic can be administered to a patient with diabetes who develops urinary tract infection that is further complicated by hypotension unresponsive to IV fluids? Right. That is piperacillin plus desobactam. What exactly is the type of UTI which is given here? The type of UTI which has been given here is a complicated urinary tract infection. Complicated urinary tract infection. Why are you saying that it is a complicated urinary tract infection? Because there is associated hypotension which is not responsive to your IV fluids. That means the individual has gone into a state of sepsis. So it's a complicated urinary tract infection. And complicated urinary tract infection, you need to treat with broad spectrum antibiotic, right? And what is the broad spectrum antibiotic among the options which has been given to you is piperacillin tazobactam, because it is active against both gram-negative and as well as the gram-positive bacteria as well. Okay, so that is the reason why the answer is A. That is first option, right? Whereas amoxicillin clavulanic acid, if you see, they are effective. They are effective in most common or many common urinary pathogens, but this will not provide adequate coverage for the spectrum of the bacteria typically associated with complicated urinary tract infection. So all these three, they are not useful in case of complicated urinary tract infections. Okay, so you need to give high-end antibiotics in case of complicated urinary tract infections, right? Next question. So the next question is, right, which of the following is not a potential complication in a 40-year-old man who presents with 15-day history of fever and 1-day history of altered sensorium, is diagnosed with Plasmodium falciparum through a rapid diagnostic test? The question is, which of the following is not a potential complication? Yeah, very good. So hypoglycemia will be there in case of Plasmodium falciparum. Why? Because liver is affected in Plasmodium falciparum, so there is no hepatic gluconeogenesis causing hypoglycemia, right? Kidney is affected in patients with Plasmodium falciparum infections as a part of the sepsis. That will cause the renal failure where the serum creatinine levels are elevated. And Plasmodium falciparum can cause cerebral malaria. Thereby, the individual will have unarousable coma. That is also a potential complication. But remember, the pH, what is being observed is acidosis is being observed. Acidosis is being observed, but not alkalosis. Not alkalosis. Acidosis is a potential complication of Plasmodium falciparum, right? And yeah. Next question. An HIV positive patient presents with whitish plaque in the mouth and esophagus as shown in the image below. What is the most likely diagnosis? Oral leukoplakia, hairy cell leukemia, oral candidiasis, and oral cancer. So in a background history of HIV, what is that you need to think of, right? There is no other differential diagnosis in a background history of HIV, that is oral candidiasis. Right? That is what is very common in patients with the HIV, right? Then, and what is the treatment? How is that you will treat this oral candidiasis? Fluconazole, right? You need to give fluconazole 150 milligrams, 1 tablet stat. 1 tablet stat. That is a drug of choice. Fluconazole is a drug of choice, right? Then, identify the correct organism and drug to which it is intrinsically resistant pair. To which it is intrinsically resistant pair. Aspergillus niger voriconazole, Aspergillus fumigatus micafungin, Candida albicans amphotericin B, Candida krusei fluconazole. Okay, Aspergillus niger will respond to voriconazole. Aspergillus fumigatus will respond to micafungin, right? Candida albicans will also respond to the amphotericin B. But your Candida krusei, that will not respond to fluconazole. What is that you need to give for Candida krusei? You need to give echinocandins. What are the examples of the echinocandins? That is caspofungin, right? That is caspofungin. And then micafungin. These are the drugs that you need to give for the Candida krusei. The remaining all organisms, they respond to the respective. So krusei, yes, that is resistant to the fluconazole. That is resistant to fluconazole. Okay, right. Last question. So like I was telling you, I said you, like once the entire session is over, I'll be sending you this PPT with the explanation and with annotations onto my Telegram channel. That is Medicine Made Easy by Dr. Rajesh Gubba, right? Yeah, we'll take up the last question. During the discharge of the COVID patient treated with steroids and remdesivir, which of the following will you inform him about? Repeat RT-PCR after 7 days of discharge. Watch for persistent anosmia. Watch for headache and nasal discharge. Monitor the glucose levels. Watch for sinusitis symptoms. Yeah, what is that you want to do? What is that you want to advise? Yeah, very good, Gautam Kumar Yelka. So that is 2, 3, 4, 5. That is C. That is C. Okay, right. I'll tell you one by one. Why is that you need to do everything? I'll tell you. So repeat RT-PCR after 7 days. There is no rule. Okay, leave it. And you take watch for persistent anosmia. Okay, so what is the reason why you need to watch for the persistent anosmia is anosmia can persist in patients after resolution of the other symptoms of COVID-19. Okay, so even after the resolution of the respiratory symptoms, still anosmia can be there. Right, that is the reason why watch for persistence of anosmia. Right, then next is watch for headache and as well as the nasal discharge. Right, headache and nasal discharge can be the symptoms associated with COVID-19 and other conditions such as mucormycosis, because in COVID-19 you are giving steroids and that can cause the mucormycosis. So headache and nasal discharge, not only the feature of COVID-19, it can be associated even with mucormycosis as well. So you need to be vigilant for these symptoms and you need to seek the medical attention if they develop or if they worsen these symptoms. Coming to the glucose levels. Why is that you need to monitor the glucose levels? Because you have given steroids to the patient. That will cause hyperglycemia. So that is the reason why you need to monitor for the glucose levels. Okay. Then the next important is the sinusitis. Okay, you take this particular sinusitis. Sinusitis is also the feature of the COVID-19. It is also the feature of the COVID-19, right? If it is still persisting, that means the organism is still being active. That is the reason why you need to watch for the sinusitis symptoms as well. So the answer is 2, 3, 4, and as well as 5. Okay, and you are repeating the RT-PCR 7 days after the discharge. It is not necessary, not required. So the answer is 2, 3, 4, and as well as 5. So what is the treatment for the COVID-19? For mild cases, just only the home care. Just only the home care. Okay. So the last part, if you see. Right. So mild cases, just only home care. But whereas you take in case of moderate cases, right? In case of what do you mean by the word moderate cases? Where the respiratory rate is more than 24, saturation has been dropped down to 90 to 93%. In that scenario, you need to admit the patient in the ward, and in the ward, you have to give oxygen and you need to maintain the saturation between 92 to 96%. Okay. And what is the preferred oxygen therapy? That is by the face mask, right? That is by face mask, right? And the other drugs that you need to give in case of moderate, if there is no contraindication, you can give anticoagulants. That is low molecular weight heparin or unfractionated heparin, right? IV methylprednisolone. Okay. So this is what is the treatment that you need to give in case of the COVID-19, right? So what is that you need to monitor here? You need to monitor for the persistent of anosmia, watch for headache and nasal discharge, monitor the glucose levels, and watch for the nasal symptoms, right? So that finishes. Right, that finishes your entire story of all the questions related to the PYQs. Right? It is not that all the PYQs of the previous years I did not discuss, but the important questions whichever are there, I've just picked up and I've tried to discuss. Right, this particular PDF I'll be sending to this Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. And you can follow me on my Instagram handle, that is Rajesh Gubba, right? And where you will have, where you can get the recent updates in the medicine, right? So with this, I wind up this particular session, right? So I hope the session was useful, right? Yes, how was the session? Okay. So thank you very much. And I wish you all the best. Stay positive and stay motivated, right? Stay strong during the examination time and in the examination hall, right? Don't think about the result that will be appearing after 3 to 4 days. Just think about that particular question and open your brain, read the question properly, don't do silly mistakes, right? And go to the examination hall on the prior time, right? And just keep all the things that you need to take just before going to the exam, right? So with this, I wish you all the best, and I'll be waiting for your result. Okay. Once you get your result, just please text me on my Instagram. I'll be very happy that you have got a good marks, right? Thank you very much, and I wish you all the best.